इसके चेयरपर्सन कौन है? Okay. So, very good morning to all the invited guests and faculty members, and 20 people are online. So, we welcome all of you, and we are going to start the first session. There is some changes in the sequence of the presentations. So, first lecture is opioid-free oncoanesthesia current status by Dr. Abhishek Kumar. Dr. Abhishek Kumar is a faculty in KGMC Lucknow, and for this session, we invite the chairperson, Dr. Madam Monica Kohli, ma'am. Dr. Monica Kohli, ma'am, is a professor and head department of anesthesia at KGMC Lucknow, and we have another chairperson, Dr. Kalpana, ma'am. Dr. Kalpana Balakrishnan, ma'am. She is a director of Cancer Institute at RDR Chennai. So we request the chairpersons, please have the seat. Good morning, guys. And my over to. Good morning, everyone. I am Dr. Abhishek Kumar, Assistant Professor from Department of Anesthesia, KGMU. On behalf of SOAPC Lucknow City, I welcome all the faculties, delegates to the CME of Society of Oncoanesthesia and Perioperative Care. Starting with my first lecture of today's, that is opioid-free oncoanesthesia. What is the current status? And I think it is important that we are balancing analgesia, safety, and oncological outcomes. So my presentation, the outline will be introduction, the timeline and emergence of what we call as opioid crisis, why we need an opioid-free anesthesia, interrelationship between pain, immunomodulation. What is the goals of opioid-free anesthesia? The current evidence and literature review, the clinical application with a case example, a relationship between return to intended oncological treatment, ERAS, and opioid-free anesthesia, and followed by conclusion and take-home message. So introduction, we know that the practice of anesthesia is a balanced anesthesia where we try to balance analgesia, amnesia, muscle relaxation, and loss of reflexes. Traditionally, we have been following opioid-based analgesia in last 2 decades. But then there is an emerging concept of opioid-free anesthesia, which is primarily based on the rationale of minimizing adverse effects of opioids. So this is a timeline. In 1800s, when we extracted morphine, it was used for pain relief. Then as the surgical specialty developed in 1920, we started using morphine in surgical anesthesia. And after the 2 world wars, there was development of synthetic opioids and the concept of balanced anesthesia emerged. So we started incorporating the synthetic opioids in the perioperative care. In 2000s, we used opioid-based analgesia. But I think in 2010s, the concept of ERAS emerged, and then we started realizing the adverse effects of opioids. And currently in this decade, we are gaining the acceptance of opioid-free anesthesia, particularly due to the short as well as long-term adverse effects of opioids. And future, I think we need more evidence to decide whether opioid-free anesthesia will be standard of care or not. Now, something about opioid crisis. Now, the adverse effect of opioid is not related particularly to the patient and an individual. It has now become a public health problem, particularly in Western worlds. It is mainly due to opioid overuse and dependence. And in US, over 130 opioid-related deaths are reported daily. The main adverse effects are addiction, respiratory depression, and overdose-related deaths. what is the role of anesthesia in this public health problem? I think we are the physicians who are using opiates on a daily basis. And traditionally, the anesthesia relies heavily on opioids and post-operative opioid prescriptions, particularly in cancer patients, which we often do, lead to long-term opioid dependence. What does opioid-free anesthesia aims? It aims to reduce or eliminate opioids during and after surgeries with an aim of related to reduce opioid-related side effects. I think these three are most important thing. Surgical patients are at high risk. Second, post-operative opioids prescription computes to long-term dependence. And the aim is to reduce opioid-related side effects. And this is a data of which was generated from global burden of disease, which is related to opioid use disorder leading to death. We all know that United States and Canada, the North American countries, are heavily dealing with this crisis, and they are reported deaths of 16 deaths per 1 lakh people. What about Indian in and Asian countries? We are almost, I think our data is not very much strong, but the opioid related deaths in India is related to zero point 0.6 deaths per 1 lakh people. And these are, I think, we are dealing with in last 3 months, the tariffs, which are mostly related to the smuggling of opioid from Canada. And what about India? Is there an opioid epidemic in India? Presently, we do not have any robust data to support this statement, but this is a data from Journal of Public Health. We are trying to address the number of people who needed help for opioid-related problems in lakhs. Now, they have defined opioid-related problems from minor side effects to addiction to deaths. And we can say in lakhs, Uttar Pradesh, that is 10.7 lakhs people needed help from opioid-related problems. Unexpectedly, we thought that Punjab would be the state which will be dealing with this opioid-related deaths, but it's mostly due to the Uttar Pradesh is most populous country and the data is in numbers. So I think Uttar Pradesh is top. Coming to the adverse effects of opioids, we have some acute effects which we often see in during surgery, and the long-term effects which is seen in cancer patients, which I think we are not very much familiar with these patients on a daily basis. Acute effects, respiratory depression is our most important concern. Others are GI problem, that is nausea, vomiting, constipation, ileus, which leads to post-operative discharge delay, urinary retention, while long-term effects are basically opioid-induced hyperalgesia, tolerance, dependence, withdrawal, immune modulation. And what about cancer progression? We'll be seeing in the further slides. So what is the answer to these chronic problems which we see in cancer patients, that is opioid-induced hyperalgesia, opioid tolerance, opioid dependence? I think the answer can be opioid-free anesthesia in these cases. Now, something about why we are talking opioids and cancer cells. I think there is a complex relationship at the molecular level and pharmacological level so that this concept emerged. Now, there are some pathways like angiogenesis, signal transducer of activation and transcription, and immunosuppression pathway. These three pathways affect the cells in our body. Like we can see in between that is the cells are developing to the cancer cells are becoming tumors, and the tumor is going from metastasis. These three pathways are responsible for progression of tumor, progression of normal cells to metastasis. And we can see that the opioids are related in all the three pathways. Now, if we see that the surgical stress responses are colored in purple, while the anesthesiologist interventions which decreases or help in decreases in surgical stress response is in green. Now, this is a very complex thing to understand why we should use opioids and why we should not use opioids. We know that cancer itself causes pain. The perioperative period adds an acute pain, and pain decreases the immunity of a body as the immune system is regulated with the cancer cells. So if there is a pain, a fall in immunity can cause an increase in cancer. But on the other way, the opioid has a direct effect on immunity. It is said that opioids can cause changes in innate as well as humoral immunity, which can lead to progression of the cancer. So we have to make a balance and decide whether opioids related analgesia or opioid related direct effect on the cancer cells, what should we do? I think this should be answered by the evidences which we have. So coming to the definition of what is opioid-free anesthesia, is a technique where no intraoperative systemic neuroaxial or intracavitary opioid is administered. It avoids use of opioids in the perioperative period. I think initially the concept was introduced in bariatric surgeries, where the acute effects of opioids, which lead to respiratory depression and prolonged hospital stay. So the opioid-free anesthesia concept was indeed first introduced in non-cancer surgeries, particularly bariatric patient, and then it came to patients like COPD and old age patients. And with emerging evidence, now we are becoming the standard of care in many surgeries, including cancer surgeries. So what should be the goals? The goals of OFA should be to reduce opioid-induced adverse effects, improve recovery and patient outcomes, minimize the risk of opioid dependence, and it can potentially impact or prevent cancer recurrence and immune function. Pharmacological basis of OFA, we know that the multimodal analgesia is now the standard of care, where we can use an IV adjuncts. We have dexmedetomidine, lignocaine, ketamine, magnesium sulfates, NSAIDs, and dexamethasone. And I think with the emergence of advanced regional anesthesia, availability of ultrasounds, and training, we are supplementing regional anesthesia in almost all the cancer cases. But all these should be patient and procedure specific. So how the opioid-free anesthesia is bridging the gap between OFA and the oncological outcomes? The answer is the multimodal analgesia and regional anesthesia. So if we compare the old way and the new way, that is old way, what we have been doing in last 20 years, we were primarily dependent on opioids, on perioperative analgesia, then PCA, paracetamol. Regional anesthesia was taking a backseat in last 20 years. And with the introduction of dexmet and lignocaine, we started using. And what should be the new way in the opioid-free anesthesia? Regional anesthesia, paracetamol, and the basic drugs should be started first, and it should be supplemented with other analgesics. And opioids should be just for minimal use or breakthrough pains. So this is, I think, the most important thing. Is there enough evidence to support the routine use of OFA in oncological surgeries? Let's do a PubMed search. If we type opioid-free anesthesia, they are giving a result of 1,000. If we add the Boolean search and add cancer, they are giving a result of 192 results. And if you add oncological surgeries, they are giving a results of 29 results. So we can say that the evidence is not much, but let's dwell into the further research. So currently the evidence regarding opioid-free anesthesia is mostly preclinical as well as clinical. Now, preclinical studies are mostly animal studies, biomarkers, and in the laboratory studies. While the clinical studies also, we have retrospective data more than randomized controlled trial. So currently we know that we have a lot of data of preclinical and laboratory studies than any randomized controlled trial or meta-analysis. Some of the clinical studies, I'm going to just read the conclusion statements. So if we see that opioid may directly affect on immune systems through opioid receptors, it was published in British Journal of Pharmacological Cells. Then natural killer cells, I think these are the most important cells which are involved in immunity and cancer progression. They also said that it may be affected by morphine. Similarly, what about the cytokines? Opioids can also interact with inflammatory cytokines, which control gene expressions. Similarly, the biopsy specimens from 34 patients of lung cancers, it was said that the overexpression of new opioid receptors has been associated with reduced overall survival and reduced cancer progression-free survival in cancer patients. And similarly, in a laboratory study of non-small cell lung cancers, treatment with that is methyl opioid antagonist inhibited invasions of cancer cells. So these was about preclinical studies. What about the clinical studies? We can say that the prevailing trend in experimental studies was saying that opioid use during cancer resection surgery was associated with negative oncological outcomes. However, the large retrospective databases studies suggest a potentially different effect of opioids in cancer subtypes. That means whatever the data we have, different opioids were studied with different type of cancer cells, and all the studies results in varied results. So this is a summary of some of the retrospective studies. If you read the statement, we can say that in the first left corner, 2,800 patients were there of renal cell carcinoma, and higher intraoperative opioid administration was associated with reduced recurrence survival. In the second right upper corner, 1,000-patient cohort for non-small cell lung cancer, increasing opioid dose was not associated with in risk of recurrence or death. In the third, similarly, intraoperative dose of fentanyl was not associated with risk of recurrence. And in the fourth, we can see that it was associated with reduced overall survival. So I think still the retrospective data is not conclusive in which direction we should go. Similarly, in the lower corner, there was a randomized control trial who underwent prostatectomy for cancer, and they were randomly assigned for opioid-free versus opioid-based anesthesia. And they also saw the biochemical recurrence and not the clinical recurrence, and it was similar in both the groups. So what about the systemic review and meta-analysis? This is a systematic review and meta-analysis which was published in 2021. This systematic review and meta-analysis included 26 RCTs, but they included both oncological as well as non-oncological surgeries. The key findings were that it had reduced post-operative adverse effect, lower incidence of nausea and vomiting, significantly reduced post-operative opioid consumption, but there was no significant difference in post-operative pain and PSU discharge time. So they concluded that OFA improves post-operative outcomes without compromising safety, but they also included that more high-quality RCTs are needed for widespread clinical adoption. Is there any systematic review for cancer patients that OFA and post-operative outcomes in cancer surgeries? They did a systematic review. It was based in for cancer surgeries, but till now, I think it was published in 2022. Two RCTs were only eligible to meet the inclusion criteria, and they focused on gynecological cancer surgeries and prostate. But they reported significant heterogeneities, and no meta-analysis was possible because it was having only two RCTs. So still there is a major knowledge gap on OFS impact in cancer surgeries, and we are lacking any long-term oncological outcomes. We do not have much data to support that there is a difference between long-term oncological outcomes between opioid-based as well as opioid-free anesthesia. There are some randomized control trials which have been done for post-operative recovery after breast cancer surgeries with the use of regional anesthesia. They also concluded that the regional anesthesia-based OFA improves early post-operative recovery without compromising pain control in breast cancer surgeries. So they do not have also data of cancer-free survival or cancer recurrence in the long term. So if we read what are the summary of the evidences, the current evidence suggests potential benefits in reducing opioid-related side effects and improving early post-operative recovery. But there is at present no justification for any change in perioperative opioid prescription with the goal of effective cancer recurrence. That means we should use opioid-free anesthesia with a goal to decrease the adverse effects related to opioids, to help in early discharge and follow ERAs. But if we are practicing opioid-free anesthesia with a goal so that it will not change the cancer recurrence, I think we do not have much evidence for that. So what are the barriers and challenges in implementing OFA? Obviously, lack of awareness and training, resistance to change from opioid-based protocols, lack of concrete evidence, institutional guidelines favoring opioids, and unavailability of OFA drugs, techniques, and monitoring. So just an example how we should apply OFA in our patients. Clinical considerations are important. If you are learning OFA, we should know which patient should we give OFA, like low to moderate surgical pain. Patients in which we are expecting a high amount of intra and post-operative pain, OFA can be a limiting factors. Absence of opioid dependence, hemodynamically stable patients, no contraindication to the drugs which we are going for OFA drugs, and there is a feasibility of regional anesthesia. Cautions and safety aspects. We should be cautious in patients with severe cardiovascular instability, bradycardia, chronic opioid dependence. Again, inadequate feasibility, hypersensitivity to the other drugs, and uncontrolled anxiety. Let's see an example. There is a 58-year-old female with a BMI of 32. She is a patient of locally advanced CA breast posted for MRM with axillary dissection. She has the comorbidities of type 2 diabetes, hypertension, history of gastritis to NSAIDs use. So the preoperative concerns regarding to pain is there is chronic opioid use for which she was taking Ultracet and NSAIDs intolerance. So how should we proceed in this case? Like in preoperative period, it is important that she should be counseled for OFA and multimodal analgesia, a preemptive analgesia using pregabalin, paracetamol, and dexamethasone. Induction can be done with drugs with ketamine, propofol, and the other drugs which can be supplemented for analgesia is lignocaine, dexmedetomidine, and magnesium sulfate. For maintenance with TIVA with propofol or dexmedetomidine, and we should supplement regional anesthesia, PEX1, ESP, SAP, and ketamine infusion can be continued intraoperatively as well as postoperatively in a sub-anesthetic dose, that is analgesic dose. Postoperative IV multimodal analgesia should be continued with IV paracetamol, dexmedetomidine, and ketamine, and no opioids should be used in intra and postoperative period. So finally, what is the relationship of opioid-free anesthesia with other strategies? Now we are aiming from some strategies in oncological surgeries, that is outer circle is our main goal, that is the oncological outcome, short and long-term outcomes. And it can be achieved with return to intended oncological treatment. There is a session on RIOT. It basically means that the perioperative period on the stress response should be minimal so that the patient goes for further treatment, whatever is planned from radiotherapy, chemotherapy, or should be discharged to home. And it can be achieved by with enhanced recovery after surgery. And also with multimodal analgesia, I think can be a core part where uh, oncological outcomes can depend. So this is all about risk-benefit balance. So if we can see it's the same that the oncological outcome depends on enhanced recovery after surgeries and return to oncological treatment, which depends on the teamwork and multidisciplinary approach. And multimodal analgesia should be OFA, but again, the current evidence is small, so we are not sure whether OFA will change the any course in cancer recurrence or survival. But yes, an opioid-free anesthesia will give an early recovery and discharge to the patient, so that the quality of life is improved and the patient can go for oncological treatment, further oncological treatments. So the key message and conclusion is the sentences which are highlighted in yellow, I think we do not have much evidence for that, but the sentences which are in green, I think we can advocate these practices. OFA may reduce tumor progression by avoiding opioid-induced immunosuppression, but yes, it supports ERAS with faster recovery and fewer opioid-related side effects. It can enhances immune function, potentially improving oncological outcome. But use of multimodal analgesia for effective pain control without opioids can be our standard of practice. It may return to intended oncological treatment, but there is at present no justification for any change in perioperative opioid prescribing with the goal of effective cancer recurrence. So final thoughts and conclusion, OFA is not a opioid never, but yes, we can reduce the overall usage of opioids. And I would like to conclude with a tribute to this man who expired on 27 September this year, Millers. Thank you. Yes.
Now, given the fact that we know the cancer cells, why do you think we do not have enough robust evidence on plus or minus about it?
Ma'am, most of the studies, first of all, the whatever evidence which we are mostly of retrospective nature, retrospective cohort. For building a strong evidence, we need an RCT, and for cancer patients, we need a prospective RCT with a good follow-up. I think we lack any follow-up studies where the primary intervention is opioid-free anesthesia and the primary outcome is cancer recurrence survival or survival. We do not have that much evidence. We do not have that much follow-up studies. And moreover, there are multiple factors which can affect cancer recurrence and cancer survival. It can be surgical, anesthesia, the tumor biology, tumor cells. So it's very difficult to plan such studies where the primary outcomes and of OFA and cancer-free survival is studied directly.
Thank you. We don't know that patients are discharged with terminology.
Yes, ma'am.
We do incorporate opioid-free post-operative. It takes there is no standardized guidelines for doing these studies so that everyone follows the same thing so that the evidence is robust. It's my key.
Yes.
Very confident.
Thank you.
Everyone. Good morning, everyone. Greetings from my institute, Kidwai Memorial Institute of Oncology, and I've been working here from last 29 years. There is one skill above all else that an anesthetist is expected to exhibit, and that is to maintain the airway impeccably. The topic given to me is airway management in head and neck surgeries. If you look at the 4th National Audit Project of the Royal College of Anesthetists and the Difficult Airway Society, you'll see 43 of the 133 serious airway complications were in patients with head and neck pathology. And if you look at the rate of difficult endotracheal intubation, 16% among patients presenting with head and neck, and which is 6 times higher than the normal general surgical patient population. So the primary concern being potential difficulty in both tracheal intubation and extubation. This can be because of the presence of the growth, the anatomical changes and fibrosis related to surgery, radiotherapy, prolonged surgeries, bulky flaps, edema around the airway, risk of bleeding and risk of aspiration. So sometimes we will have clear pointers of difficult airways. You can see the fistulas, you can see the ankyloglossia, the facial defects, the poor submandibular compliance, trismus, fixity of larynx defect, and thyroid swellings. But what is more concerning to us is the patients who outrightly appear normal. When you look at the patient and when you assess the difficult airway, you will not find anything until and unless you see the imaging. So if I have to secure an airway in head and neck patient, I would look for the detailed history, assessment, communication with the surgeon, reassessment on the day of surgery, airway cart and gadgets ready, my plan ABC in place, roles assigned, and surgeon in the OR. I will take, since 20 minutes is very less to talk about airway management in head and neck, I will take particularly only of some cases and some history about the head and neck cancers, which is pertaining to typically oncological cases. So when I'm working the history, I'll ask for the hoarseness, which may be due to glottic tumors, infection, edema, nerve involvement, a dyspnea, which can be due to deviation, narrowing, or cardiopulmonary causes, orthopnea because of large pharyngeal or neck masses or anterior mediastinal tumors, and stridor because of significant airway narrowing. But this you need to really remember that slowly progressive tumors do not exhibit any symptoms and signs of airway compromise due to conditioning of the respiratory muscles as long as spontaneous ventilation is preserved. And hoarseness occurs when there is an invasion to the vocal cord. So patient may have a very narrow airway, but he may not show you any symptoms, but it will present to you when you give anesthesia. Taking the other histories like post-radiation, post-surgery, history of difficult airway, OSA, or a history of previous tracheostomy. If you look at the effects of radiotherapy on the airway, what is more concerning to us is the edema, the fibrosis, ankylosis. And I would say that osteoradionecrosis is sometimes when you're holding the mandible too tight for a patient with post-RT. I have seen where we have had pieces of bones in our hands. So you need to be very careful when you are taking a patient of post-RT. And I'm talking about this when radiation was not so much targeted. So when high-dose RTs were given, we used to get such cases too. And another thing is you'll have the airway very, you will not find any difficulty in airway, but when you do scopy and when you try to lift the epiglottis, you may not be able to lift the epiglottis because of the fibrosis. Another difficult thing is previous surgery. Now, previous surgery is very important is that we lose the bony framework, which interferes with our mask seal, ventilation, laryngoscopy, and intubation. And accordingly, depending on the type of surgery, we may have different symptoms which we need to look for. So remember that airway assessment in head and neck surgery should be tumor-centric. You have to evaluating their impact at different stages of airway management, starting from mask ventilation to laryngoscopy, intubation, SGA placement, phonar, difficult extubation, and the risk for reintubation. Remember that the sensitive and positive predictive value of traditional airway assessment is very poor at predicting difficult airway. And especially in head and neck cases, it does not account for aspiration risk, lower airway problems, fail to assess the severity of upper airway disease, and base of the tongue pathology. So we need to have some advanced airway assessment techniques in such cases. So I'm going to highlight only 3 of them, and the most important which I find is the nasal endoscopy, which is a narrow flexible endoscope to visualize the nasal passages, pharynx, and larynx. An assessment of the airway while demonstrating the possible impact of pathology and location of any obstruction. Now, if you look at these endoscopies, what do you see? These assess for us the supraglottic and glottic airway, including the vocal cords and piriform sinuses, but this is giving us only a supraglottic view. If we still want to go and see subglottic, you can topicalize the airway and the subglottic anatomy can also be evaluated. Another thing what the nasal endoscopy gives is it allows us to assessment of the pathology, which may preclude face mask ventilation, prevent direct laryngoscopy, or impede successful tracheal tube placement. But it is not always correct. You have your own limitations with nasal endoscopy. This case which I did about a week ago, what we saw in nasal endoscopy was this opening. And the moment induction of anesthesia was given, it became this. So after induction of general anesthesia, it may differ from view in a conscious patient where patient is managing pharyngeal tone and is in a semi-recumbent position. So significant reduction in pharyngeal tone may also lead to airway obstruction. So if you see this study, there were about 138 patients who were taken and they saw 44 they will do awake intubation and 94 they will do induction and secure the airway. But what happened was after they did nasal endoscopy, 20 patients came towards the induction site. So that much difference a nasal endoscopy can do. The next advanced technique being the virtual endoscopy. What virtual endoscopy? It is a process by which the CT and MRI images are created into a 3D construction. This endoscopy is of a thyroid case where they said that the tracheal opening is about 1 millimeter. And this can be used by the anesthetist for the plan of airway management. But again, it has its own limitation. Small lesions may be missed, natural color is absent, secretions can be incorrectly reconstructed as lesions, and excessive smoothing of the air walls can occur. Another significant thing that is we can use ultrasound for assessing and confirming the position of tracheal tubes and readiness for intubation. But yes, all of us don't do ultrasound for that. But what clearly we require in head and neck patients is I would want to assess the subglottic diameter, estimate the tracheal size, tracheal deviation and stenosis, width and location of underlying trachea, but this is where it helps us the most in head and neck patients. So if you look at this patient upfront tracheostomy was done by surgeon, but the surgeon also needed the help to find out where the trachea is and where the tracheostomy should be done. So this is how it is a must that any difficult airway you are doing, you can with ultrasound or by palpating have your cricothyroid marked. Another use for ultrasound being the assessing the vocal cords, which actually more be used for checking after extubation. Now, one more thing which I love in the assessment technique is doing the flexible bronchoscopy. So if you see, it provides us a very valuable information about the size, friability, extent of lesion, and the dynamics during respiration, which we don't get in other static techniques. So a large mobile tumor of the vocal cord that exerts ball valve effect can be picked up with awake flexible endoscopic evaluation. This was a huge thyroid which was compressing the trachea. Our routine neck x-rays, our AP fuse for narrowing, displacement, lateral view for the column, then again your CT MRI. You can see in this MRI the tongue lesion, and this CT, you can utilize CT for tumors which are in upper or lower airway, extensive masses which are causing narrowing of the airway. You can assess the minimal diameter of the trachea. You can decide the size of the tube, tumors which are compressing the airway, and displacement of the larynx and trachea. Now, what is most important in head and neck when you're securing airway for head and neck cases is communication with the surgeon. Communicating regarding the ease of intubation, nature of airway duration, what are the anesthesia needs, the potential of airway compromise. But when you are looking at the airway imaging with the surgeon, you should communicate regarding the location of the tumor, the size, the spread, the vascularity, degree of obstruction, extent of laryngeal and tracheal deviation, and also to know the airway obstruction. Now, once you have this preoperative evaluation done, you should be able to establish that if mask ventilation is likely following induction, if laryngoscopy and intubation are likely to be difficult, if an awake technique is more appropriate, or if FONA is feasible, because that is really important, because most of the other surgeries, the FONA is not an issue, and you, in many cases in head and neck, you get where front of neck access is also not accessible. Then have a self-questionnaire for yourself that have you assessed the airway properly? Do I have the gadgets? Can I ventilate? Can I intubate? Have my plan B ready? Size of the tube, type of the tube, rescue plan, and do I have help? So if you look at this airway card, the first one is the general, and the other one is with advanced, which is having jet ventilation, your ventilating bougie, your cricotherapy set, and your rigid bronchoscope. And if you look at this is how the thing should be ready when you are doing a difficult airway in head and neck surgeries. I'm sure there's no place for us to stand when I placed everything and I realized that, yes, we do require all this. Another important thing, remember, maintain oxygenation to prolong apnea time, continuous no desat, continuous oxygen from the worst station through nasal cannula during awake or paralyzed intubation attempts, directly through nasal cannula. You can do with Thrive, SHFNO, or you can be doing para-oxygenation throughout the procedure so that the safe apnea time is extended. And the most important thing, surgeon always ready when you're trying to do these difficult airways. So let's look at the common cases we encounter. The first one being the tumors on face or lip, which can distort the airway anatomy, difficulty in mask holding, mask ventilation. Depending on the tumor, use the size of the mask. The edges to contour the mask should be soft. You can use an LMA if the mouth opening is good to oxygenate these patients. Alternate techniques for pre-oxygenation and rapid sequence induction to follow. Allow faster intubation. Coming to the nasal cavity tumors, the challenges faced are occluded nasal opening, bleed on touch, rule out nasal spurs. To overcome, use the other nose, and remember that you may require to put the Riles tube also through that nose. If that is not possible, an oral flexometallic tube would do good. Coming to the buccal mucosal tumors, your trismus is there. You can use your, as I said, the pain trismus, which can be relieved, but the other ones you should be aware is which will not be relieved are the submucous fibrosis, radiation, and metastasis. You can use fiber optic or a video laryngoscope for it. Tongue tumors, I think one of the most, the tumors which we need to be very, very careful about are the exophatic tumors, which bleed on tube. Right side more challenging than the left because the scope is, we take the scope through that side. Infiltration prevents tongue protrusion and moving tongue to one side and the base of tongue lesions. You can use left side blade placement or you can do a nasal fiber optic. Coming to the microlaryngeal surgeries, if you're doing under general anesthesia, it can be either by a tracheal tube, smaller size, apneic intermittent ventilation, jet ventilation, or Thrive. If you are doing a microlaryngeal laser surgery, remember that you are sharing the airway, you want an immobile field, you want a non-flammable tube, you want adequate oxygen. At the same time, you have to wait against combustibility, and adequate ventilation and carbon dioxide removal. So I just want to put this video for everybody to see that when we are using Cortex tube for laser, how the laser hits the cuff and how it melts so easily in a Cortex tube. And see on the right side, when the laser tube it has hit, it takes so longer. So if you see medical legally, you never stand anywhere if you are using a Cortex tube. Just a fraction of a second, it melts away. In the center video I've just shown is that you can fill saline or you can fill methylene blue, and see when it's a wet surface, it takes a little longer to burn. When he will take the laser to a drier area, it will just burn off. Since a paucity of time, I'm just running through these. Coming to the laryngectomy, another important thing is that the primary ETT size and the method of intubation is dependent on the bulk of the tumor, the available space at the laryngeal inlet, and the other predictors for difficult laryngoscopy and intubation. So managing, I would say that video laryngoscope has really changed our intubations of CA larynx, which used to earlier go for upfront tracheostomy. And this is one thing Benumaf long back has proposed, and it still is the best thing to do when you're doing a difficult airway. Have a double setup. That is, the surgeon opens the skin and reaches up to the trachea but doesn't nick the trachea, and you try the intubation. So this is a double setup which is very, very safe to do, because sometimes it happens you may not be able to intubate, but it takes time to locate the trachea. So this is a double setup, can really help. Thyroid surgeries, I think this one case I would like to show you is this patient had stridor. If you look at the CT scan, this was the CT scan where they had shown that there is no tracheal opening. It was about 1 millimeter. And how video laryngoscope helped us to, we did had a gritty feeling when we were putting the bougie. But once the bougie was put, the tube was railroaded. As all of us know that most of the thyroid tumors are anteriorly placed. So the muscle will give us place so that a bigger tube goes. But always remember, if the thyroid tumor is posterior to the trachea, your expansion will never be there. That is when you have to relate your tracheal tube size with the opening. But when it is anteriorly, you see it will be 5 millimeter opening, 4 millimeter, but your tube goes is 6.5, 7. So that's a difference which you will see in the anterior and posterior tumors. A word about critically obstructed airway. You should, as it is assessed by nasal endoscopy or flexible endoscopy, patients with a moderate degree of stridor can be considered for airway management, either under awake or under inhalational induction. So airway assessment and expertise will guide the method, whether we'll be doing awake flexible, awake video, inhalational, and neuromuscular blockade only after securing the airway. Remember that the need for surgical airway can arise at any time during airway management of such cases, and rigid bronchoscope is of big help in tumors which are mass lesions in and around the airway, and the mass lesion can also be caught by a rigid bronchoscope. I want to put a word about the advantages with the video laryngoscope. Why I love video laryngoscope so much is it gives us a wide view of the glottis, which we can identify the landmarks, both normal and distorted anatomy, and also we get a space to effectively aspirate the secretions as well as the blood from the airway under direct vision. And another thing what I like about video laryngoscope is we can change the gadgets. I want to put a bougie. I want to put a stillet in the tube. I want to change the size of the tube, which I may not be able to do in fiber optic. So, and it throughout the process, when the tube is going inside, it is visible to me, which is not visible in fiber optic scope, because the moment I put the scope and when I'm pushing the tube, it's a blind nasal intubation. Coming to the cautions with fiber optic bronchoscope, remember that we can have sudden complete obstruction of airway during awake fiber optic tracheal intubation. We can have the effect of local anesthetic agents. Fibril tumors can bleed due to infection of endoscope or endotracheal tube. The scope can critically narrowed airway have the cork in the bottle effect. Tumor fragments can be dislodged, leading to airway obstruction. And remember, sucking in of the mobile pedunculated lesion during airway management, which can be aggravated in apprehensive and agitated patients. Hybrid technique looks good, but I think a little difficult to do. Somebody holds the video laryngoscope, other person, but it is of advantage when you use the fiber optic as a stillet. You use the video laryngoscope, put the tube on the fiber optic, use it as a stillet, and then intubate. Another gadget which I was very happy to have as a demonstrating piece with me was this video stillet, which is nothing but a Bonnefils with a flexible tip. So I just tried it in patients who were paralyzed, but this is recommended for awake intubation also. So it's about 12 lakhs. So the price makes it a big factor, but I'm sure the institute which can afford can have this video stillet as another gadget for difficult cases. A word about tracheal resection, but it's not complete airway management in onco setup if we don't talk about thyroid infiltrating tracheas. So remember, in this about 6 rings were removed. This is how your ventilation goes, that you can see both the tubes. I cannot go into details, just showing the armored tube through the tracheostomy, then the tracheal anastomosis, and the guardian tutel later, so that we don't have extension of the neck. TORS, difficult airway, having longer endotracheal tubes, maintaining the sympathetic stimulation throughout the procedure, no access to the airway, and remember that to undock, we should have practice so that if anything happens, we are able to undock it as soon as possible. Intraoperatively, look for tube kings, airway tears, accidental extubations. Extubation, remember that it's an entirely elective process. Delay allows airway edema to resolve and increase the chances of successful intubation. So we have either replacing tracheostomy with overnight intubation, which most of us do, and we follow the extubation the following morning is the expected norm. Airway exchange catheters can assist extubation and maintain the tube with humidified oxygen. Elective tracheostomy, we have clinical criteria for tracheostomy, both for head and neck malignancies and for free flap reconstruction. All of you can, if whoever is interested, can go through them. And your rescue measures should be always ready. If you have seen the ASA 2022 guidelines, the guideline only starts by saying that decide from the beginning only whether awake or under anesthesia, and that is how you should follow your cases. I joined Kidwai and I had upfront tracheostomy to bougies. We didn't even have bougies, then checkscopies, fiber optic, blind intubations, LMA, video laryngoscopy, cricothyrotomy, video stillet, but still I have sometimes the vocal cord laughing at me. So whether you are a first year or whether after 29 years of anesthesia, never be overconfident when you're managing a head and neck anesthesia. We all take it for granted. PG has seen the PA checkup, but I'm telling still this happens with us. So prepare yourself well and have a safe intubation. Thank you. Actually, I've not touched upon carotid body tumors, juvenile angiofibroma. There were so many to touch upon, but just to cut what routinely we see. So I hope it was helpful to you. Thank you.
I think almost one day topics is finished in 20 minutes. Thank you.
Thank you, ma'am, for such a lovely lecture. Thank you, respected chairperson and speakers. This session has been an incredible learning experience, highlighting the importance of specialized anesthesia care for the oncology patients. Now, I request Dr. Josna Goswami, ma'am, to felicitate our chairpersons and speakers. Ma'am, welcome, ma'am. Starting with Dr. Kalpana Balakrishnan, ma'am. Okay. Starting with the Dr. Monica Kohli, ma'am. Now I invite Dr. Kalpana Balakrishnan, ma'am. Inviting our speakers. First is Dr. Abhishek Kumar, sir. Thank you, ma'am. Now I would like to invite Dr. Jason Doctor, sir, to moderate an interesting panel discussion on topic onco-anesthesiologist as a peri-operative physician, surgeons and anesthesiologist perspective. Dr. Jason R. Doctor, sir, is professor and consultant anesthesiologist in the Department of Anesthesiology, Critical Care and Pain, Tata Memorial Hospital, Mumbai. Welcome, sir. Now I request sir to invite our panelists on the stage.
Good morning, everyone. Thank you very much for having us here. And all our panelists. So we have with us Dr. Debashri Lahiri, Assistant Professor from Tata Memorial Hospital. We have Dr. Ashish Kanodia, who is a professor at SGPGI, and he has a lot of patents and innovative equipment to his credit. We have Dr. Sameer Gupta, who is a professor of surgical oncology. You are outnumbered, sir. Yeah, from KGMU. You are from KGMU. And we have Dr. Rajesh Ulalu, who is Senior Consultant and Director at Zymus Hospital, Bangalore. Yeah, so I think we can have two chairs on each side and with the mics at one. Sorry. You can move ahead, that's fine. So I'll be touching upon various aspects of how our branch as anesthesiologists is evolving.
When we joined as residents during our training, anesthesiology was a sought after branch because it was an end specialty and there was nothing ahead to be done. But as we progress over time, we have varying fields of anesthesia diversifying into intensive care, trauma, emergency medicine, pain medicine, pediatric anesthesiology, onco anesthesia, which we are here for. So the perspective of an anesthesiologist is changing and it is not limited to the intraoperative period. And a lot of us are also taking care of preoperative rehabilitation clinics, PAC clinics, post-operatively acute pain services, intensive care units. So let's come to the suitability and SWOT analysis of what are your thoughts on anesthesiologists evolving over time as perioperative physicians, and do you think they are best suited for the role currently? So, Dr. Ashish, I'd like to have some inputs from you regarding what is the scope of evolving as perioperative physicians and what is the stake at SGPGI?
The role as a perioperative physician has become very fast. So we are doing it since last so many years, but the concept is gaining popularity and people are doing starting from perioperative checkups.
Jason, we are not able to hear Jason. Sorry, we are not able to hear the panelists, the online attendees.
Yeah,
Sorry.
we'll rectify that, please. Thanks. I think can we increase the volume because the online panelists are not able to hear the online participants are not able to hear the participants when they are the panelists when they are speaking. So online is not able to hear.
We can hear you very well, not the
Yeah,
panelists.
because I'm speaking into the regular mic and the panelists are speaking on. Yeah, is that any better? Hello, hello. 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 Is it any better? Not me. Ashish. Can you hear Dr. Ashish?
No.
Hello. Scenarios. के unmute करके कर सकते हैं क्या? नहीं मैं चेक कर ले रहा हूँ अभी ध्यान नहीं मिले तो खाली यहीं से yeah yeah I think I got somebody else from the team to reply that they can hear. ये मेरा तो सुनाई नहीं सर जा रही है ये आपने ऑडियो उठा रहा था मेरे को ऑडियो सुनाई नहीं दे रहा वो मेरा है ये मैं से सुनाई होगा उससे बोलिए तो they will just hello yeah we can do that sure we can do that we can call one panelist on this mic and I think that will be a better thing to do so let's make it easier for the online participants as well so yeah so yeah let's coming back to the question. Dr. Ashish, can you come and speak from here?
Yeah. So, good morning. So, we are doing perioperative management since long, but the particular term as a perioperative medicine or perioperative physician has come up and it's gaining popularity. So, especially for oncological surgeries, rehabilitation and nutrition matters a lot. So, in SGPGI also, we are doing a lot of oncological surgeries. We are not doing oral malignancies per se, but head neck surgeries and abdominal and thoracic we are doing. So we are routinely doing PACs and try to build up the patient in terms of nutrition as well as optimization of coexisting diseases. So we are doing our role as a perioperative physician, and we are getting benefits also out of them. So, like previously, when we are not involved with the preoperative management of coexisting diseases, the day before, 1 or 2 day before the patient was posted, many times when coexisting diseases were not optimized, like sugar controls or hypertension or management of anticoagulants. So many times it used to happen that patient might be postponed due to some or the other reasons. So since we are have been involved in the preoperative management of coexisting diseases, so now there are lesser chances, better control of coexisting and lesser chances of postponement of surgeries. So that is the preoperative, and then intraoperative we are doing alone, and in post-op period also we are taking care in post-op care unit, in intensive care unit. So we are doing a lot in SGPJ as it is emerging at other places also.
Thank you for the insight. Dr. Rajesh, regarding your private hospital, so why I'm coming to you immediately after a government setup is in a private institute. How happy are people to hand over responsibility pre-operatively about management of all these comorbidities, run a rehabilitation clinic, and taking care of these patients in the ICU by an anesthesiologist and not the primary care physician? Thank you. That's a very good question, actually. So I have seen the both sides of private practice, like freelancer and also working in a very big institute. So it is much easier in an institute to follow a protocol where the anesthesiologist will be the primary perioperative physician. This perioperative physician, this emerged maybe 10, 20, 12 years back with the concept of delivering a outcome for the patient who are undergoing for major surgery. So the first or the important where the specialty, subspecialty started was in the cardiac anesthesiology, maybe. So when we see the mortality rate or the morbidity rate when we concern about the cancer patients and the cardiac patients, certainly we have like any colon cancers, anything, we can see that colon cancer morbidity and mortality is more than the cardiac patients. So the structured perioperative physician thing which happens in cardiac surgery should happen in cancer surgeries also, and likewise in private and or in a bigger institute. The same thing should follow. But what I saw here in the private freelancing setup is the surgeons are more dependent on the physician fitness rather than the anesthesiologist fitness. So before the patient comes to us, the physician would have already given the fitness. This patient is fit for under spinal or under general anesthesia. So this is where the anesthesiologist in the private sector is very important, because there are two parts here. One part, any like as a onco anesthesiologist, if you see, more and more patients of elderly patients are coming to the surgery with lot of comorbidities. That's the part one. And part two is the patients coming for
for the cancer surgeries, already with the pre-treatment with chemotherapy or radiation therapy, which is very important to understand, where these two parts where the physicians are really difficult to understand. Maybe the geriatric medicine physicians can understand this, but the general physicians very difficult to understand these things. And this is where the role of anesthesiologist is very important when it comes to both private or in higher institutes. This is what I think.
Right. So, Dr. Samir, you are outnumbered here, like I mentioned earlier. But how comfortable are you for sending your patients to a cardiologist or a physician and being anesthetized by somebody else who is not aware of what the why this particular fitness was given by somebody else and not them? So who is the decision making person for fitness for anesthesia? I understand that if it needs a revascularization procedure or something like that, then you have a cardiologist in the loop or a nephrologist in the loop. But who is the predominant person taking care of the patient during the perioperative period at KGMU? Can you come? Yeah, please.
Good morning, everybody. Thank you for having me here. So I would say in this entire discussion, the biggest stakeholder is the surgeon, right? So we want best for the patients. So now with increasing complexity of, I'll talk more about oncological surgeries, more patients getting given chemotherapies and radiotherapies. I think this perioperative physician concept, the time has come. So the anesthetist or the periop guy has to flag, and then we move on to a specialist. So, and another thing is that ownership is there of the patient. So he sees the patient in the pre-op, optimizes the patient, flags that this patient is fit for surgery. If there is an issue, a cardiology fitness or a nephrology fitness or a general physician fitness, so it's that peri-op guy who, anesthetist guy who needs to flag, no, this is the problem, you need to consult a specialist. Take that advice because ultimately he has to manage the patient in the intra-op. And if we add that post-op component to this entire picture, so it's a complete thing. That guy has the ownership of the patient. He knows how to optimize the patient in the pre-op setting, manages it in the intra-op and post-op. Because oncological surgeries run long duration surgeries. You have a high peg going on. You have complex reconstructions going on. So most of our complex head and neck surgeries, patients are not extubated. They are shifted on tube. The next day they have to be extubated. And 9 out of 10 times, we have to call our anesthetist colleague to see whether the patient is good enough to be extubated. But that's on an ad hoc basis. But if we can have it in a more structured basis, patient going from OT to a step down HDU, managed by the anesthetist or a critical care guy, and then coming to us, I think that will be the best case scenario. So the time for this peri-op thing has definitely come.
Yes. Another question in continuation of that, do you have in KGMU and the other institutes, if any of the other panelists are able to enlighten us, do you have a structured prehabilitation clinic which takes care of nutrition build-up, comorbidity correction and optimization, or maybe exercise and involving a physiotherapist and well in time? Let's say a patient is posted for Whipple surgery and we are nutritionally building him up or taking care of it's like surgery, major surgery like that is running like running a marathon. So you don't run a marathon on one fine morning and just wake up and say I'm going to run for a marathon, right? You need some amount of preparation. So when this patient comes to a preoperative PAC clinic, uh, who is the point of contact who takes and integrates all these services of physiotherapy, nutritional build-up, exercise, and comorbidity correction and optimization and addiction correction?
So we have a well-functioning PhD back at KGFU where we send all our patients. They are being analyzed there, and whatever suggestions, good or bad, are being followed. But yes, there is no, as I told you, the ownership is not there. So the guy who advises in the PAC clinic may not necessarily be there in the OT. In an ideal scenario, the days have to be decided. The guy who has to come to the OT may have it's a good idea to have him or her see the patient in the pre-op setting, advise accordingly, because ultimately he knows that whatever he's advising, he has to give anesthesia to that patient. So we have that kind of thing, but we definitely need.
Right. So we have a very good system in Tata Memorial Hospital which functions, that we've had something called as a high risk joint committee meeting, which involves the anesthesiologist, which involves the primary care physician, the radiation oncologist, medical oncologist, all of that. And all the challenges are discussed. So these patients are flagged in a PAC, and all these flagged patients will actually come at a dedicated time period for a high risk JC, where a joint decision with the surgical counterparts and the other counterparts will be taken with the anesthesiologist there as to what is best suited, whether the patient needs an NACT because we need to buy time for optimization, or upfront surgery, and what are the risks involved. Is it okay to get done in an institute like ours, or you need a cardiac backup or something like that? So there is this concept that we have come up with. So coming to a little bit in detail about this. So we come to the SWOT analysis, which is the strengths, weaknesses, opportunities, and threats. So as an anesthesiologist, what are our strengths when we accept this role as a perioperative physician for the with our new kind of work culture that we are going to imbibe? Dr. Devasri?
So I think it's the anesthetist who is best suited as a perioperative physician, because we see the patient preoperatively. We know the physiology of the patient. We know what cancer does to the physiology. We know what the oncology treatment does to physiology. We are, I mean, we do have a huge armamentarium of skills and knowledge to be able to tackle these patients preoperatively, intraoperatively, as well as postoperatively. We are trained in intensive care unit. We are trained in blood transfusions, IV fluids, and all. So that is our strength. Why we are best suited as an anesthetist to be the perioperative physician. And I mean, there are lots of our skills and knowledge which we have, which if put together, and probably it's time that we imbibe this mindset that yes, we are the perioperative physician, and as Dr. Sameer said, we need to take up that ownership that yes, this is my patient also. We start seeing the patient right from the preoperative time, take an active involvement in its optimization, in prehabilitation. Intraoperatively is definitely, we play a very important role, as well as follow up these patients postoperatively for pain relief in the intensive care, in the ward up to discharge, and probably after discharge, if there has been a secondary admission, we do follow up these patients. This would also help in continuity of care. So these are the strengths which we anesthetists have to become a best perioperative physician.
Sure. Thank you. So, Dr. Rajesh, any weaknesses or any lacunae that you feel are there currently in accepting this newer responsibility?
I don't think so. When it comes to comorbidities, as surgeon here told, the primary ownership always lies with the anesthesiologist, whether to refer that patient to any other further super specialty like pulmonologist or a endocrinologist or a cardiologist or a nephrologist. So what it is left to us. So I don't think there is any weakness other than legally. Legally, I don't think so, because handling all these specialties or super subspecialties under one, this one, we may need a structured education or some fellowships or some diplomas. Maybe that will be asked in next this one. So I don't know whether, I don't think that anesthesiologist uh, gaining this as a perioperative physician, I don't think so. It is a very difficult choice.
Just to summarize what we have discussed, the strengths are that we have better understanding of perioperative physiology, knowledge, skill, and evidence-based practices. Weaknesses are currently a lot of the institutes and DNB institutes, which are private institutes, you lack a structured training program for them. So they may or may not rotate to medical wards. They may or may not be in charge of taking care of post-operative care of these patients. They may or may not get posted in acute pain service or in the ICU. And if they are really busy, short-staffed, and busy in OT, that is the primary responsibility. So they may not be able to do justice to the post-operative management, which is extrapolation of the intraoperative care. Again, like Dr. Rajesh mentioned, that we have medical legal issues, and there could be, if you're not trained for it, I'm not sure whether you are the right person. So whether we should imbibe that in the curriculum so that we are trained and can justify that this is a part of our job profile. Opportunities, again, it is good recognition. The rapport with the patient is better. You see them pre-operatively, you treat them post-operatively. Also, they are under your care in an HDU or an anesthesia care unit, and you take care of the pain management, the epidural infusions, the opioid infusions. So recognition is a lot better. You're not just a gas man behind the mask who just comes in before surgery and disappears immediately after surgery. The threats are that you have medical legal issues, and other medical graduates may get offended if you don't really give them enough work or give them enough responsibility, and they get the threat of being sidelined. So the scope of work as a perioperative physician, coming to that, about the preoperative, intraoperative, and postoperative. So Dr. Ashish, in SGPGI, do you have a established prehabilitation clinic apart from the PAC, which takes care of, and who starts? Suppose you find that the blood pressure of a patient who's posted for a major surgery is, let's say, 200 by 110, and glycosylated hemoglobin is 9, and sugars are, let's say, 350. So what is the optimization involved that you will take care, and how much will be shouldered by you, and how much will be shouldered by a physician?
So in SGPJ, we do have a PAC clinic, but we do not have a separate prehabilitation clinic as such. But when such patients comes to us, we see whether patient is on any medication or not, because many a times patient is first time detected that is having severe hypertension, or he or she is having diabetes, this is uncontrolled. So depending on whether it's a known comorbidity or it's detected first time, so mostly, so like if patient a known is having a known comorbidity and is on any type of treatment, if the control is fine, then referral is not sent. But if it is detected first time, so we mostly send it to the concerned physician, like BP of 200 range in the range of 200 systolic, or blood sugars in the range of 350. So mostly to start the treatment, we do send them to the concerned specialty.
Open question to the house. How many of us actually are involved in the optimization of the comorbidities at their institute? Can we have a show of hands? So that's, I think, around 8 or 10 people. So that's not too many. But if we have to change our face as a perioperative physician, this is what we will need to do. That optimization of nutrition, physiotherapy, comorbidity correction, we will have to take the onus. If it is beyond us, in the sense, if you start one or two antihypertensives and you ruled out causes, then we might need to take the help of a specialist in that particular field. But very often I find that the more and more specialized we get, the more and more tunneled vision we have. So if you have send the patient to a physician, he will just optimize blood pressure, but he will not look at the renal part. He will not look at the effort tolerance and angiography and all of those things. He may not be able to be the correct person for optimization of sugars. So these are some of the problems. So if we have to take up this role as a perioperative physician, we can probably be the point of contact initially during the perioperative period for optimization of these comorbidities. And if they are not getting controlled within a couple of days, then probably you can involve a specialist consultant in this particular problem. Coming to the intraoperative period, how many of you actually from the audience here follow evidence-based practices and ERAS protocols? That's again around 8 or 10% of the 8 or 10 people in the crowd. And how many of the institutes have acute pain service which is functional, and the post-operative care unit which is manned by an intensivist with an anesthesiology background? Okay. So including Dr. Samir, your institute, the intensive care unit or post-operative care unit is manned by the anesthesia department? Perfect. Wow. So that is a good move towards evolving as perioperative care physicians. I have a very interesting thing here that if you look at your adherence to ERAS protocols, Dr. Samir, if somebody from the anesthesiology department comes to you and tells you that why do you need a Foley's, why do you need a rise tube, do you really get offended, or do you rethink that I am the surgeon, I will decide when is the correct time to remove the drains? Why are these people interfering with my area of expertise? How often do you feel that, and how do you tackle this diplomatically?
Why with this word by offending the anesthetist? Moral of the story. So that's one. And secondly, yeah, it's always like a two-way communication, right? So if they have anything to say that early mobilization has, the word is moving towards that, right? So it's an open mind. Yeah, drains may be my domain as a surgeon because I know what kind of anastomosis I have done or what kind of intraoperative difficulty did I face. But other aspects about the rise tube, about the pain management, epidurals and Foley's and chest physiotherapy, definitely. There are suggestions that facilitate early recovery. Definitely welcome.
I'm really happy that the surgeons are also evolving and the egos are coming down, because a lot of the times the surgical oncologist used to be a demigod and used to, like, you cannot address questions like these to them.
Oh, one of my bosses used to tell, you cannot touch surgeon's ego, but you can touch politician's ego.
So it's good that we are imbibing that in the surgical training, and with professors like you, probably your juniors also will get trained that there is no question of ego as long as it's for the benefit of the patient and enhanced recovery. I think we are moving in the correct direction. So coming to the next bit, the feasibility. So I understand that these kind of treatment, these kind of perioperative physicians are relatively challenging to develop in a institute, but once implemented, it is easier to follow. But there is some hurdles from the hospital, and as a freelance practitioner or maybe a institute, not an institute, nursing home kind of a setup, how easy do you think is this implementation going to be, Dr. Rajesh, since you've seen both the sides of the coin?
Yes. Um, so as the surgeon also told, ownership is very important here, whether it is private, freelancing private or any institute, government or any private institute also. So when I was previously working in a corporate setup like HCG, it was very easy to implement because there was a team for it. Whatever the board decision, the meeting we take, it is very easy to implement. But when I am alone as a freelancer and I have a team outside of the hospital which can cover with me for any other cases, it is very difficult to understand for them to what is my level of thinking to achieve this perioperative physician thing. So sometimes it happens if your colleagues are previously working with you, it is easy to implement. But as when we think about the freelancing and the private institutional work, it is always easy to implement things in institution than in the private sector when you're doing the freelance.
I'm sure not only in Mumbai, in a lot of other cities also, a lot of all these oncosurgeries are done by anesthesiologists in nursing homes and in corporate hospitals. So what happens when you are tied up with a long case which is having major blood loss? Unless you work as a team, this is not implementable, because if you are tied up, you can't be waiting for managing the post-operative pain or shifting the patient to the ward until you finish your case and reach and go to him at 8 o'clock in the night, right? So that is a little bit of challenge. So when you work as a perioperative physician, you have to ensure that you work as a team, and you have help in the operating room, as well as if you're going for rounds on the floor for preoperative and post-operative patients, you have protected and dedicated time to do justice to these kind of preoperative and post-operative visits. So coming to the curriculum, are we actually geared to give this title of perioperative physician or onco-anesthesiologist or perioperative physician unless we bring about a change in curriculum? We often see that when we have MD trainees, they rotate amongst all the respective operating rooms like obstetric, ENT, orthopedic, regionals, and all of these. But how often do they get posted in the HDU, on medical wards, in PAC clinics, in APS, all of that? So, Dr. Ashish, do you have a structured kind of a training program where you have them as operating room and non-operating room, which includes not only peripheral locations for anesthesia, but all these other areas which need to be taken care of?
So for MD, since at SGPGI we do not have broad specialties like medicine. So for MDs, we don't have such curriculum. But for PDCC and PDAF, like in cardiac, the residents are posted for 1 month in cardiology. Like for organ transplant, people are posted for 1 month in nephrology. So like that, for postdoctoral certificate course, they are being posted in the area of concern. But for MD, we do not have the curriculum. But I think it's the need of the hour. It should be included in the curriculum if we want to grow as a perioperative physician. So it has to be inculcated during our training period. Then only we can achieve the goal.
I would actually, since this is a Society of Onco-Anesthesia and Perioperative Care Conference and CME, probably we can be the flag holders in bringing about this change, where we can involve the FNB, DNB, FOAPM, all these various degrees, and we can have a change in the duration and time of residency with a dedicated operating room and out of operating room ratio. And in this out of operating room ratio, you have to train them in the intensive care unit, the PACU, the APS. So how many of us actually post residents in all these other areas, or it completely consultant meant? Very few, right? So because we are so overworked and understaffed that it is.
Yes, our FNB program curriculum, it has got the compulsory.
So it may be there on paper, but is it like आज ये लोग कम आए तो चल आप ओटी में ही रुक जाओ, वो बाकी चलता रहेगा types? It cannot function like that. If you are posted there, that means you have to finish your training there. There is no two ways about it. So apart from that, the other skills like evidence-based practices, like guidelines, recent guidelines, communication skills. How do you explain high-risk consent about perioperative cardiac events to a patient? How we have to have maybe a program where you can take the resident. So we've allotted for this high-risk JC. We have a student for each of these high-risk JCs, and the student sees these patients. He comes and informs the respective consultant, and in the joint clinic, we sit and explain the risks, what the patient has, to him as well as their family members, so that they are very well aware that this is the risk that we are dealing with, and these are some of the complications that need not essentially happen, but we can expect that we can face those when we treat patients. So how many of the residents are actually undergoing a medical rotation, medicine, a posting in medicine from the anesthesiology bit? So if you want to starting sugar control or hypertension control or maybe hypothyroidism treatment, how do you titrate the therapy? How many of no, none of the residents are. Correct. So that is why the duration and time of residency may have. Correct. Of course. So, which is a fair thing to do. If you're taking the onus of managing these patients preoperatively in the PSC clinic and taking care of rehabilitation, you should be aware of the newer drugs that are available, of how to titrate the therapy. So, it is a good practice to actually think about whether they need a rotation and need to maybe shadow a consultant who actually is in treating these kind of patients. Coming to the last bit, how do you deal with money, economics? So sometimes when you take responsibility and you're not reimbursed, it is like, why do I even need to get into this mess? Because there is no gains, there is no recognition. Somebody sidelines you. And so, how do you deal with this in a corporate setup? Can you actually bill patients for a PSC visit every time they come for an optimization, for consultation, for pain rounds, for critical care? Dr. Debasri, your take on that?
We need to bill them for pre-op visits. Again, we cannot bill them on each visit. So probably as in our setup, we bill them once and then for next 15 or 20 days, whenever they're coming for a follow-ups, they're not billed. Similarly for your pain clinics as well as our APS rounds. So billing is essential, but now again, I'm not sure in a corporate setup how it works because uh, in a corporate setup, because it's more of a surgeon-driven system where it's the surgeon who gets the patient. I'm not sure about how much they would be comfortable in sending the patient to PSC for a optimization and paying that much money. Instead, the surgeon would say, I might as well send the patient to the specialist and get the fitness. In the same money, the fitness will happen. But probably it's time that this change has to happen, and the way this change can happen is by showing results, by auditing our own results as perioperative physician, as anesthetist being the leader in the perioperative period, by improving the outcomes. And if this audit and these results are being shown to the management, probably this would be the way forward. But definitely we have to charge maybe a very nominal charges and not charge them every time, but that is what I feel is needed.
Dr. Rajesh. Sorry? Yeah.
Are we allowed to give fitness for, say, a patient with a pacemaker? Okay, we are completed enough and we've analyzed the patient, seen the ECG, everything. So are we medically allowed to give that fitness without referring the patient to the cardiologist?
So obviously with the pacemaker, correct. So obviously certain conditions, like if your patient needs a revascularization procedure or perioperative dialysis, you will need to involve the specialties, but this would be a select subpopulation of the cases. Do you need to, like somebody comes to you with a creatinine of 1.5? As to when you should refer and when are you okay to manage patients with your expertise? Correct. No, so to give you an example, like how I just mentioned about a sugar patient with sugars of 350 or a hypertensive 200 by 110, do you immediately need to send this patient to a cardiologist, a physician, an endocrinologist, versus whether you can begin therapy, and if you're not able to get it under control within 2 or 3 days, then probably involve that subset of patient with an endocrinologist or a cardiologist, is what my take is, right? So when to call for help. Correct. So that is what is the debate. How are you going to be able to see in a government setup? There is a fixed salary component. So it doesn't really matter. If you're willing to take responsibility, everybody is very happy to hand you over the responsibility. Okay. But in a corporate setup, every time he sees a consultant, every time he takes up somebody's appointment or time, it is supposed to get billed, because the hospital is going to ask you a question as to how are you generating revenue. If you are spending that much time outside the operating room, you are asking for protected space, protected time away from the operating room in a PAC clinic. If you're not going to generate revenue for the hospital, what is the purpose of sitting there? Right? So how are you going to do that?
This is what I wanted to tell. See, yes, in corporate hospital, this is what happens. Where is the revenue from the anesthesiologist? So you have to charge the PAC as per whatever the surgeon charges for his OPD consultation. It is not that nominally we have to charge. Because in corporate, whatever the surgeon charges, the same charges will be applied for the anesthetist also. So that's the one thing. The other side is the private practice again. The private practice, the surgeon doesn't want to send the patient to pre-anesthesia checkup because the anesthetist will charge the patient. So they tell, anyway, we are giving you anesthesia charges, so you do it on the day of surgery itself. So there are two coins here, different sides. So, but as an anesthesiologist, I always in my private practice also, I insist them, if it's ASA 1, it is fine. ASA 2, 3, I love to see the patient. They charge the patient, then only I'll take the patient for the surgery. This is what is the thing. No. Only one. Yes, yes. Review, there is each hospital has different, like Madam told 15 days in Tata something. In my hospital, it is 7 days. So 7 days, later if the patient comes, then I have to charge him again.
Any other thoughts? I think otherwise we are okay to wind up. Right? Thank you very, yeah, sure.
So I think we have to get out of the thought that fitness has been given by physician. It's not fitness for anesthesia. The, the specialist can give you opinion regarding optimization of that particular coexisting disease. But fitness has to be given by the anesthetist only. So we have to come out of this thought that fitness has been given by cardiologists or pulmonologists. We have to come out of that. They can give their expert opinion regarding optimization, but fitness has to be given by the anesthesiologist who has to administer the anesthesia. So that is my take. That is
So who's taking the risk? Okay, the cardiologist is going to run away. He's going to say, I'm going to be busy in the cath lab. So, do you hold the cardiologist accountable if there is a adverse coronary event in the perioperative period? They should be available on site and answerable to the relatives and the patient if they are giving fitness. Okay, and then they cannot say that, okay, I didn't expect this. That's your problem. You gave anesthesia, so this has happened because of an anesthesia complication. You gave a drug overdose. Okay, that's the usual problem that we face. Dr. Samir, you can close your ears. He's outnumbered here. He has to go back in one piece. Okay, thank you very much. And I think with that, we end the panel. Thank you. ऐसे रखो नहीं कॉपी कर दूंगा कौन सी ये वीडियो आपकी एक तो बुक लॉन्चर वीडियो रहेगा ये एक तो ये है और
ये दोनों ये और ये नहीं है, ये नहीं है, ये ऊपर वाली, हाँ ये नहीं, हाँ ये बस दोनों। तो चलो यहाँ रखो ताकि मैं प्ले करूंगा। एक मैं वीडियो करके यहीं पे रहेगा ना, डेस्कटॉप पे कर दिया, डेस्कटॉप पे तो ये भी है ना, ओके ठीक है, मैं करता हूँ, मेरे को ये बताइए लेंगे।
Thank you, all the panelists and moderators, for engaging in valuable discussion. Your enthusiasm has made this session even more meaningful. Now, moving forward, we are delighted to welcome you to the CME inauguration ceremony. Good morning to one and all present here. We are honored to have esteemed guests with us whose presence adds immense value to this academic event. I would like to invite Dr. Josna Goswami ma'am, President SOAPC National, on stage. May I kindly request Dr. Sandeep Sahu sir to welcome Dr. Josna Goswami ma'am with a bouquet. Now, I would like to invite Dr. Sohan Solanki sir, Secretary SOAPC National, on the stage. Welcome, sir. May I kindly request Dr. Indubala ma'am to welcome Dr. Sohan Solanki sir with a bouquet. Thank you. To commence this auspicious occasion, let us seek blessings from the goddess of knowledge, Ma Saraswati, by lighting the lamp. I now invite our esteemed dignitaries to join us in this symbolic gesture.
All the EC. We request all these cases of present here, please come. Let's take care of it.
Thank you, our esteemed faculty and dear delegates, for gracing this moment. Now, without further ado, I now invite Professor Sandeep Sahu sir, organizing chairman, to deliver the welcome address.
Very good morning to all the esteemed SOAP's National Office Bearer, Dr. Josna Goswami ma'am, President SOAP's National, Dr. Sohan Solanki, Secretary SOAP's, and Dr. Anjali has to go because of some issue, the Treasurer, National Treasurer, and we have Dr. Raghu here who was the immediate past president. So we welcome all the office bearer, and we are lucky to have that we have the quorum of Dr. R. Holulu, Dr. Ranganath, Dr. Jason, the only doctor in this भीड़ में कहूंगा, and Dr. Shagun Bhatia ma'am, Dr. N.K. Vinod sir, Dr. Kalpana Balakrishna ma'am, Dr. Neha Desai. So we welcome the National Society Office Bearer, and we are very privileged to have all of you here on this. Today is very auspicious day, Ram Navami, the birthday of Lord Rama. So अभी यूपी को तो हम लोग भगवान राम के नाम से जानते हैं कि भाई यहाँ अयोध्या में मंदिर बन गया है, और आई होप कि आप लोगों ने उसको विजिट भी किया होगा. So the faculty members, the delegates of the dais, on the dais, and the guests who are online, our delegates those are online. So we all welcome to you this inaugural CME. We will say the national CME of the SOAPC, and this is also the time that the SOAP's Lucknow City branch is forming today in this auspicious day. And I will like to thanks from behalf of SOAP's Lucknow City branch, my all office bearer. Can we stand up, please? So yeah. So they have. This is my team. Those have worked hard, very hard to give this shape of CME. और इस organization के दौरान अगर if you feel that there is some lackness or some lacuna, and I'll take this onus, and I am very sorry if you feel any discomfort during your this stay. So now over to speakers.
Thank you, sir. Now I invite Secretary SOAPC National, Dr. Sohan Solanki sir, for the keynote address.
Thank you very much, and good morning to everybody. So, on behalf of SOAPC National, I welcome you all to this inaugural CME of and also the inauguration of this Lucknow City branch. So, actually, we wanted to start this branch in UP and especially in Lucknow since long time, and then we had a word with Dr. Sahu and all these things. So they ultimately accepted the proposal and they made this plan. So SOAPC is a fast-growing branch. It's a branch, fast-growing society. It established in 2018 in Mumbai, and now we have more than 532 members currently. And this is a very fastly growing society, and soon we'll be like reaching 1,000 maybe in 1 or 2 years only. So I invite all who are not member of SOAPC, please become the society member, so that you have all the privilege of the major member. You can attend conferences. You have like we also run bi-weekly this webinar also, and sorry, fortnight webinar we will conduct, and we also have SOAPC fellowships in many centers in India, and we conduct a centralized exit exam for the SOAPC fellowship. And like and we also have certain honorary fellowship of the SOAPC. We give around 5 honorary fellowships to the did any senior member or someone who's good in that particular field. So we, based on the credential, we give an honorary fellowship also. We have our own journal also, and this journal is we are coming up with the regular issues. You can also send your papers into the SOAPC journals. So without wasting time, I'm just welcome you all, and thank you very much for being here. So thank you.
Thank you, sir. Now I invite President SOAPC National, Dr. Josna Goswami ma'am, for the keynote address.
Everyone, I'm very happy today to be here to for this on the auspicious day for the very auspicious occasion. So we get to start the new society, new city branch of our Society of Onco Anesthesia and Perioperative Care and Lucknow, and it is our combined commitment, you can say, as a society that we are now stepped in 7th year of. I think I started in 2018. Is 7th year of the society, but we started the 6th city branch, and it is still now very small and closed group, but it is ever growing continuously. And we have, as Dr. Sohan mentioned, we have so many members now. We have so many city branches. We are doing a lot of academic activities continuously. We are doing national conference where we have a good interaction with national and international faculties. And I can say one thing that this onco anesthesia, many people are saying, what is it? Nothing. But it's same. We are almost every hospital we are giving anesthesia. Mostly the patients are coming. Many patients are coming with cancer. So what anesthesia for abdominal surgery is mostly in every patient, every hospital we are giving for onco anesthesia. So what is it in extra things? But as you attend this sort of CME, you see the conference, you see so many new things are there. And if we continuously deal with this subject, update ourselves, we know many small nitty-gritties are there. If we take care of all those things, even we can contribute in the good outcome of the cancer. So that is the best part of the things. And I think as in India, globally, there is a lot of cancer centers. In India, also a lot of new cancer centers are coming up throughout the country. And everywhere they need now experienced, trained people for the cancer anesthesia, and not anesthesiologists are not only taking care of the anesthesia inside the theater, but they are involved, as we are discussing since morning. They're involved from the pre-habilitation, pre-operative checkup when the patient comes into the hospital. From that time, they come for different diagnostic procedure that also happening under anesthesia. Then they come for the anesthesia, post-operative care. Then they sometimes go to we are taking post-operative care also, and then palliative care. So whole spectrum of the cancer treatment, cancer timeline, anesthesiologists are there. They can contribute in the cancer care. So that is the major thing we can, as an onco anesthesiologist, we can contribute in the patient's journey. So I feel this is a very satisfying for us to take part actively, and all of us should take part in this onco anesthesia. That's why it's growing day by day. It will grow up day by day, and I feel very happy to to see that many people are involved into this setup. Thank you so much.
Thank you, ma'am. A warm welcome to each of you on this momentous occasion as we inaugurate the SOAPC Lucknow City branch. With this new branch, we aim to enhance accessibility, foster professional development, and create a hub for knowledge sharing and networking. I encourage you all to actively engage with SOAPC and participate in our collective journey towards excellence. Let this branch be a beacon of growth and collaboration. Now, I request Dr. Sohan Solanki sir for the further proceedings.
So, on this auspicious occasion of Ram Navami, from the SOAPC National, we are happy to inaugurate SOAPC Lucknow City branch, and I declare this branch open from today. So I invite all the vice mayor of Lucknow City branch to come gather. Madam, please also you also. Yeah, in this Lucknow City branch, so Dr. Sandeep Sahu will be the chairman of the Lucknow City branch. Dr. Indubala Maurya will be the secretary, and Dr. Aparna Shukla, Dr. Ram Gopal Maurya, and Dr. Abhishek Kumar will be the EC member. Okay. Treasurer also, yes.
Thank you, sir. It is an honor to stand before you on another momentous occasion as we unveil the much awaited book, that is textbook of onco anesthesia and critical care, which is dedicated to the specialized field of onco anesthesia. This book represents a significant step in integrating anesthesiology with the oncology, ensuring better perioperative care for the cancer patient. I would like to take this opportunity to congratulate its editor, that is Professor Atul Kulkarni sir and Dr. Sohan Solanki sir, and all the authors for their dedication and invaluable contribution in bringing the book to you. This work is the result of extensive research, clinical experience, and a vision to enhance the patient's outcome. Let us unveil the book, Textbook of Onco Anesthesia and Critical Care, and mark the beginning of a new chapter in onco anesthesia.
So this we planned almost 1.5 year back, and it books. So many of you are the author of this book, and this book has 75 chapters. And thank you for all your hard work in shaping this book mm, good and in a great way for the all the like students. We are students and the practitioner for the onco anesthesia, especially the DM, FNB, and the fellowship. Everybody they can be benefited by this book. So thank you very much. We will unveil the book now.
Thank you, everyone. Now, I would like to invite Dr. Sohan Solanki, sir, to say a few words about their book.
So apart from this book, we have also like opening the region of the online like anesthesiology material, which is edited by Dr. Atul Kulkarni and Dr. Jigi Divetia. So both these editors are like they are very uh, big name in the field of anesthesiology and intensive care. So I'm happy to unveil their online course also on the behalf of these editors and this JP company. So we have a like 40-second video on that also. So is there? Is there? Okay. So thank you very much, all of you, and thank you.
Thank you, sir. Now, I request Dr. Jyotsna ma'am on stage to felicitate our national office bearers with mementos and certificates. Starting with Dr. Jason, Dr. Sir. Next is Dr. Kalpana Balakrishnan ma'am. Dr. Mithilesh Kumar sir. Dr. Namrata Rangnathan ma'am. Dr. N.K. Vinod sir. Dr. Rajesh Holalu, sir. Dr. Shagun Shah, ma'am. Dr. Raghu Thota, sir. Dr. Neha Desai, ma'am. Now I request Dr. Sandeep Sahu, sir, to felicitate Dr. Josna, ma'am, President SOAPC National. Now I request Dr. Sandeep Sahu, sir, to felicitate Dr. Sohan Solanki, sir, Secretary SOAPC National. Now I request Dr. Sohan Solanki, sir, to felicitate our chairperson and speaker of the first session. Dr. Debashri Larry, ma'am. Dr. Ashish Kanodia, sir. Dr. Sameer Gupta, sir. Okay. Thank you, everyone. Now I invite the organizing secretary, Dr. Indu Bala, ma'am, for the vote of thanks.
Good morning, everyone, respected faculty and dear delegates. It's an honor to stand before you to deliver vote of thanks. First and foremost, I would like to thank our SOAPC National Office Bearer for considering us for this academic event and also encouraging to establish Lucknow Soap City branch. And I would like to extend my heartfelt thanks to all the panelists, speaker, and all the delegates for joining us today. And say definitely your knowledge and experience definitely going to benefit all of us. And I would like to thank my organizing team, Professor Sandeep Sahu sir, Dr. Karna ma'am, Dr. Abhishek, and Dr. Ram Gopal for their meticulous planning and support. And I'd like to thank sponsors for their financial support to making this CME successful. And I would be grateful to all the technical staff and supporting staff for making this CME glitch-free and smooth. Thank you all the delegates and the faculty who has joined online, because without them, the CME is not doesn't have that meaning unless you join it. Let's continue journey of knowledge and sharing experience. Thank you once again.
Thank you, ma'am. May I kindly request everyone to stand for the national anthem?
Yes.
नायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
You have to go downstairs. Those meetings are really तो बाहर निकल के गेट पे लोग होंगे एक ग्रुप बनाएंगे तो वी कम डाउन नीचे आएंगे डाइनिंग एरिया लोग ऊपर और नीचे दोनों तरफ
I request everyone to join us for the high tea on the ground floor after the group photo, and we will gather here after 20 minutes for the next session. Thank you.
So there is a break for online delegates of 20 minutes, and we will again join after 20 minutes. Thank you. Charlie?
के बीच में चला आ गया होता मैं ठीक है आप कराइए तब तक मैं उधर ही आता हूँ अभी आता ही ठीक है कौन सी
लखनऊ करती
मीट 2025 है
ना। हाँ ये
ये यहीं पे डेस्कटॉप
देखते हैं डेस्कटॉप के लेट सी
ये यहीं पे ऐसे डेस्कटॉप पे ये डाल दी ये आगे ठीक है बस कुछ नहीं
नहीं लेट सी वो ओपन करके वही है ना। यस हाँ दिस इज ओके।
मैं दिखा देता हूँ
है ना सब तरफ perfect okay so it is on the
डेस्कटॉप पे ये मैं दिखा देता हूँ
desktop हाँ what is number
ये अलग से ये मैम यहाँ पे ये फर्स्ट फ्लोर पे
Let's go down.
Down to be ma'am, first पे है.
Then the washroom, then the whatever. Because we don't want to miss another thing now.
I know.
Pula?
Yes ma'am. हाँ. फर्स्ट फ्लोर पे. हाँ. नहीं फर्स्ट फ्लोर पे ही है. फर्स्ट फ्लोर पे डॉक्टर राहुल से मिल. पोस्ट ऑफ आईसीयू लिखा हो. हाँ वो. ये आप 5 मिनट रुकिए मैं आ रहा हूँ. 5 मिनट मेरे को समय दीजिए बस आ गया मैं. ओके. ये दोनों का इधर किनारे कर दिया. हाँ ये तो
I'm coming.
चलिए.
Okay. But why don't you put it in your purse? Handbag. Should I put it?
ये देखिए मैं अपनी पीपीटी कर दिया है.
ठीक.
ये डेस्कटॉप पे है मैम. थैंक यू.
या बस इसी में कर दिया सर।
ये सिस्टम उससे काफी चल रहा है। इनको दे दो। हाँ सीधी दे दो।
ये नहीं
कौन सा आपका तो स्कैनिंग तो दिखा रहा है। फिर से लगाए सर। हाँ ये आपका है सर, ये वाला सेशन में ये नेक्स्ट सेक्शन इज योर्स। ओके सर शगुन मैम आपने लोड कर दिया इसमें।
नोट कर दिए।
ओके थोड़ा रुकेगा सर आपका? हाँ, ठीक है, we should wait करते हैं। व्हाट्सएप पे ले लूंगा मैं। मैम आपका कौन सा सोप स्मीट, ये वाला? हाँ।
यही करवा रहे थे, फिर हम नीचे आए तो तब तक खुद से
हम लोग का इंदू देख लेना, स्क्रीन शेयर हो रहा है उसमें। हाँ, अपने लैपटॉप पे देखना उसका। क्या ये
अपने फोन में लगा
कोई दिक्कत?
चल
Moving forward to the next session, now I would like to invite the chairpersons onto the stage. We welcome Professor Sandeep Sahu, Department of Anesthesiology, SGPGI Institute of Medical Science, Lucknow. Dr. Asim Rashid Sir, Additional Professor, Department of Anesthesiology, Kalyan Singh Super Specialty Cancer Institute, Lucknow. Now, I request our chairpersons to introduce our next speaker.
So let us welcome Dr. Shagun Bhatia ma'am. She is a senior consultant anesthesiologist, Rajiv Gandhi Cancer Institute of Research Center. Her major achievement, she has been best original article and lot of publication in Indian Journal of Anesthesia, more than 100 publication, more than 20 book chapters, and area of interest is definitely oncoanesthesia, difficult airway errors, lung isolation, high-PEC, advanced hemodynamic monitoring T and free flap surgery. So we welcome them for this talk. Anesthesia and cancer recurrence, current status and future perspective.
Thank you for the kind introduction. My dear fellow anesthesiologists, a very good morning to all of you. And we're running a little bit late with the session. Sorry for that. And without much ado, I shall start off with this important topic, which is anesthesia and cancer recurrence, current status and future perspectives. So, do you know that when was the seed for this raging controversy sown? It was sown by Exactelos in 2006. He published an article in the Anesthesiology Journal, and the article was titled, Can Anesthetic Technique for Primary Breast Cancer Surgery Affect Recurrence or Metastasis? So, let's get further details of this seminal article. This clinical study was a retrospective analysis, and he looked backward, literally, to point the way forward. So, in this retrospective study, they examined the medical record of 129 consecutive patients undergoing mastectomy and axillary clearance for breast cancer. And the results were amazing, astonishing at that time. They realized that people who were given paravertebral anesthesia along with GA had a much, the recurrence and metastasis-free survival was, say, 94% in this group compared to just 77% in the group which was not given paravertebral anesthesia. So this was statistically really significant with a p-value of 0.0102. So let's move forward and find out why did this happen? What are the causes? Surgery actually results in cancer cell dissemination. It produces surgical stress. There's a neuroendocrine stress response producing cortisol, catecholamines. Then there is immunosuppression. NK cells are, suppressed. T lymphocytes, neutrophils. There are inflammatory mediators which are released, tumor necrosis factor alpha, interleukins, etc. Then there is ischemia and reperfusion injury. There's a hypercoagulable state. All of this result in increasing circulating cancer cells, and ultimately it results in recurrence and metastasis. So a closer look at the picture. So surgery results in release of the CTCs and the circulating tumor cells as well as inflammatory mediators, and these mediators activate the platelets. Activated platelets again release soluble mediators, TGB beta, adenosine triphosphate, etc. And these mediators in turn suppress the NK cells, and they also increase the vascular permeability. Finally, what is the result? You get transendothelial migration of the circulating tumor cells. These circulating tumor cells lodge anywhere, just about anywhere in the body, wherever the vasculature can go. And then they might remain as a single cell, or divide and form a colony, or they might be micrometastasis, or they may be clinical metastasis. So, which is the factor which determines whether the cell will divide into a micrometastasis or a clinical metastasis, and how long will it take for this cell, this dormant colony, to result in a clinical metastasis? It all depends upon the immunosurveillance of the body. So, this particular factor called immunosurveillance, a lot of perioperative factors are responsible for it. So, perioperative immunosuppression, you have inflammatory response to surgery, neuroendocrine stress response, even hypothermia. It may seem a benign condition, but that also results in immunosuppression and cancer progression. So blood transfusions, tissue hypoxia, hyperglycemia, postoperative pain, all these are independent risk factors for immunosuppression and cancer progression. But today, last but not the least, we focus on the role of anesthetic agents and techniques which are involved in cancer progression. Okay, so with great knowledge comes power, and we have the power as anesthesiologists to reduce cancer progression simply by choosing the right anesthetics. And with power comes responsibility. So we must choose the right anesthetics. How do we do that? So in a nutshell, general anesthesia causes NK cell dysfunction, whereas local and regional anesthesia improves NK cell function. So let's delve further into this. So a historical snapshot has been created by the various in vitro studies, animal studies, and retrospective studies. So this is what we already have. And stress response, pain, inflammation, these are produced by surgery. And the villains turn out to be the volatile agents and the opioids, whereas the NSAIDs, the local anesthetics, and antagonists appear to have a positive effect on recurrence and metastasis. So let's see how the volatile agents and opioids affect cancer and recurrence. The volatile anesthetics are pro-inflammatory. They reduce the helper T cell 1 to helper T cell 2 ratio. They reduce the natural killer cell activity, induce T cell and B cell apoptosis, upregulation of HIF, increased transcription of pro-metastatic factors, so on and so forth. Then there are, different volatile anesthetics. Some of them have cancer promoting effects and some of them have cancer inhibiting effects. So angiogenesis, matrix invasion, platelet function, all of this is affected in a differential manner by the various volatile anesthetics. So you can't say, okay, blanket volatile anesthetics are all bad. Some of them are good also. Some of them have a mixed plus minus kind of a thing. Okay, coming to the opioids. Now, they modulate wound healing, they cause immunosuppression, inhibit NK cell activity. All those go to promote recurrence and metastasis. But then there is an exception here as well. Tramadol is known to promote NK cell activity in lung cancer patients, which is a good sign. But then all these studies, like I said, they are all retrospective, translational, animal, in vitro studies. IV anesthetics, these two anti-inflammatory and immunosuppression properties are there, inhibit COX activity, stimulate proliferation of NK cells. So they are beneficial. You have a smiling syringe there, And individually, again, there's a lot of difference. Propofol is good. Dexam can be bad. Ketamine has good reviews. So has thiopentone. So I'll not go into all these details. You will get bored with all this. Let's move on. NSAIDs, COX-2 inhibitors, paracetamol, all these also inhibit the inflammation, as the name suggests, non-steroidal anti-inflammatory drugs. So since they reduce inflammation, obviously they do not promote cancer. They even aid in preventing the metastasis. Local anesthetics, I'd give a big thumbs up to it. Why? Because they activate the apoptotic pathway in the tumor cells.
Inhibit tumor cell growth, increase NK cell activity, increase the number of helper T cells, preserve the Th1, Th2 ratio, so on and so forth. Even they increase the level of favorable interleukins. So, how does ultimately regional anesthesia reduce cancer recurrence? It's by a three-pronged approach. You have the anti-inflammatory effect, the reduction in neuroendocrine stress response, and finally pain relief due to reduced, which results in reduced opioid use. So, again, the same thing, NK cells increase, interleukin-4 increases, interleukin-8 decreases. This reduces the inflammation, tumor cell growth, tumor cell migration. Stress response is reduced. Pain control is there, sympathetic block is there, cortisols are reduced, beta endorphins are reduced, right? And ultimately, we know that opioids cause immunosuppression and they have a pro-angiogenic effect. And regional anesthesia reduces opioid requirement, hence it's beneficial. So finally, this is the composite picture. So some of them are pro-metastatic, some of them prevent it. This is the current picture. So now with the advent of randomized controlled trials, how does this picture change? That's what we'll discuss today. So this was the picture till now with animal studies and vitro studies. So colorectal cancer. Now these are the results of RCTs which I'm giving you, actual trials done on human beings. So in colorectal patients, it was observed that when you gave ketamine in a single dose of 0.5 mg per kg or 0.2 milligram per kg body weight every 2-minute repeated doses, it resulted in a reduction in TNF alpha and interleukin 6, which are inflammatory mediators. So they concluded that pro-inflammatory cytokines are reduced with repeated doses. I repeat, repeated doses of ketamine. Then there's another RCT, a very recent one, 2021, which says that low-dose ketamine does not have beneficial immunomodulatory effects. But then there's another one, still more recent, and it says that if a single dose of ketamine is given, 0.3 mg per kg versus 0.1 or 0.2 mg per kg, then in a dose-dependent manner, ketamine does decrease post-op anxiety, depression, and also the anti-inflammatory markers. So the final word is that go with ketamine. It reduces the inflammation and prevents tumor recurrence. How about breast cancer? Now, different cancers, different agents function, behave differently with different cancers. So this is a very interesting study by Dr. Bhagwe et al. And this is an Indian study, multicentric, and it involves 1,583 patients who were analyzed after 5 years. And what did they find out? They said that peritumoral injection of 0.5% lignocaine, maximal 4.5 mg per kg, 7 to 10 minutes before surgery. What were the results? The 5-year disease-free survival was 86.6 in the group which was given the intervention versus 82.6 in the other group, which is statistically significant. So is the 5-year overall survival rate. Overall survival was also improved in patients who received peritumoral injection of lignocaine. And same applies for the loco-regional recurrence and distant recurrence rates. And of course, I'd like to add here that there were no adverse events because of lignocaine injection. So whenever you can, you should, in your breast cancer patients, go in for peritumoral infiltration of local anesthetics. So this is one of the few RCTs available as of now. Breast cancer surgery, propofol versus volatile anesthetics. So this was again a study conducted on 1,670 patients, multicentric study, 7 Swedish centers, 1 Chinese center. It was a prospective study. And what was the result? The 5-year survival rate was 91.9% in the propofol or the Tiva group and 92.2% in the sevoflurane group. So they concluded that there was no difference at all in the overall survival between the general anesthesia with propofol or sevoflurane for breast cancer surgery patients. So you can switch on your sevoflurane and say, okay, it's fine, you can do it. How about ovarian cancer? So there is an effect of timing of epidural. So this was another surgery time to tumor recurrence in patients with optimal surgical debulking was noted. And the mean time to recurrence depended upon the timing of epidural as per this study. If it was an intraoperative epidural, the mean time to recurrence was 73 months versus a post-op epidural where the mean time to recurrence was just 33 months. So you should give your epidurals intraoperatively. Start them when the surgery starts and not leave them for the post-operative period. Many a times, what do? We put the epidural catheter, but we don't give the epidural. We give it only in the post-op period. But we should refrain from this practice and start the epidurals when the surgery starts, or even better, even before it. Give the loading dose before it. So this was this study. But then after this study, another study was done. And what they did was, they had similar results. Mean time to recurrence initially was 1.6 years and 0.9 years for epidural and no epidural groups. But then after propensity matching, there was no difference in the two groups. Same with the median survival time. So even the RCTs which are present right now have conflicting results. But what we know is the timing of epidural is really important. Ovarian cancer. How about the duration of epidural? We've talked of timing of epidural. What about duration? So this was a historical cohort study on 194 patients. And what did they find out? The overall rate of cancer recurrence in the epidural plus GA group versus GA alone was 72% versus 85% in favor of the epidural group. And in the GA cases where desflurane was used versus sevoflurane, the overall rate of cancer recurrence was 63% versus 84%. So go for epidurals, go for desflurane. Okay, if you have a choice between sevo and desflurane, as far as metastasis is concerned, desflurane would be a better choice as per this RCT. And again, in this study, the primary outcome was the disease-free survival. And disease-free survival depended upon the duration of epidural given. So in the subgroup where the duration of epidural was above 48 hours, 14.9 months was the disease-free survival versus just 10 months in the 24 to 48 hours group. So keep in mind that if you're giving an epidural, give it intraoperatively and let the duration be, let it continue for 48 hours at least. As it is, we remove it only after 72 hours, the epidural. Okay. Lung cancer. What is the effect of epidural? You know that epidural was beneficial in ovarian cancer, but then it doesn't seem to be important for lung cancer. Because in this particular study, on 400 adults, GA with IV opioid analgesia was compared with GA with epidural analgesia for post-op pain relief. The median follow-up duration was 32 months. The recurrence-free survival was similar, overall survival was similar, and cancer-specific survival was also similar in both the groups. So we are left with use what you like, either opioids or epidural in lung cancer patients. So what is the need of the hour? Different cancers and different agents, they behave differently in different permutations and combinations as far as immunosuppression cancer progression is considered. So I'd like to emphasize that not all opioids are pro-tumor. They are not necessarily the villains. Not all volatile anesthetics are pro-tumor. And out here you can see a spectrum of anesthetic agents derived from a narrative review by Montejano et al. And you can see that Dexem seems to be the worst and intravenous lignocaine seems to be the best. So from top to bottom, this is how they affect tumor suppression and cancer recurrence. There are several, based on these current RCTs, there are several anesthetic agents, GA agents like propofol, fentanyl, desflurane, and ketamine, which are anti-tumor. And then there are others like dexmedetomidine, morphine, and sevoflurane, which are pro-tumor. But ultimately, the balance, like you can see, is tilting in favor of the anti-tumor GA anesthetic agents. So even GA can be beneficial and not the villain always. So what should the future research focus on? Now, the future research, whether you should give GA, whether you should give regional, I'd like to emphasize that different anesthetics may have different effects on the same cancer, and conversely, the same anesthetic may have different effects on different cancers. So, multimodal analgesia complicates evaluation of isolated effect of individual agents. Mostly, all these agents are given together. You're giving something for induction, then you're giving propofol for induction, maintenance, you might give Dexmed. Post-op pain relief, you can give opioids. So your patient, if he has a recurrence, you cannot attribute it to just an isolated single anesthetic. So you require well-planned studies. That is the need of the hour. Well-planned studies which are robust, large, multicentric, randomized controlled trials to examine the impact of GA and regional anesthesia on cancer recurrence and survival. So thank you for choosing the right anesthetic. I think henceforth you have the knowledge to choose the right anesthetic because your patients deserve both compassionate care and superior results. Thank you for the patient listening.
Good afternoon, everybody. The next speaker is Dr. Jyotsna Goswami. She has a lot of feathers in her cap. She's the chief editor of the book, A Complete Guide to Oncoanesthesia, Critical Care and Pain. She's the president of Society of Oncoanesthesia and Perioperative Care. She is vice president, All India Difficult Airway Association. And ma'am will be presenting the topic perioperative considerations in cancer surgery, balancing risk and post-operative recovery. Welcome, ma'am. Thank you.
Thank you for your kind information. Yeah, just ask me. This one I kept it. This one. Yes. My colleague is coming. I'll just put the normal. This thing very slow. No, not this one. This one. This is the presenter's view. The normal view. 1 minute. So this is. This is no, this is okay. So thank you for kind introduction. And my topic today is perioperative considerations in cancer surgeries, balancing risk and postoperative recovery. So thank you for the topic. It is a very basic topic in onco anesthesia, and since morning we are discussing many times these issues, but I'll again probably many things will be repeated in my talk. And I bring greetings from my hospital, Tata Medical Center, Kolkata. So we all know that cancer is a huge load, huge burden on a global healthcare setup. The number of cancer cases, which was 20 million by 2022, is supposed to increase up to 35.3 million by 2030. And it has been seen that 50% of all hospital admissions for cancer in the 3rd to 7th decade will need surgery. So perioperative care is very much important, and a good perioperative care can give a good cancer outcome. So if we see a normal case scenario, what we practice in our daily practice, this is a 62-year-old lady, hypertensive, diabetic, CA ovary, and she received 4 cycles of neoadjuvant chemotherapy with paclitaxel and carboplatin. Her body weight was 39 kg, BMI 18, and hemoglobin 8. And her habit, she has sedentary habits, and she has been posted for debulking surgery. So what are the risks here? So this patient is elderly, she has comorbidities, she has the cancer burden of ovarian cancer, she has received neoadjuvant chemotherapy, so that those can have side effect. She has poor nutrition, poor functional capacity, and obviously anxiety, etc. So all these factors can make a patient severely deconditioned. And these patients, when they're subjected to a major surgery, there can be significant surgical stress, and this surgical stress can have effect on multiple systems, and there will be severe catabolic state or anti-inflammatory state. So those things can lead to postoperative complications. And if you see a treatment timeline of a cancer patient, oncosurgical patient, surgery is only one part of the treatment pathway. So it can be many a times it is preceded by the neoadjuvant chemotherapy and followed by adjuvant treatment in the form of chemotherapy or radiotherapy, etc. The time between surgery to adjuvant treatment is very, very important. This is, we call it return to intended oncologic therapy or treatment, REOT. So if patient gets the adjuvant treatment on time, the cancer outcome becomes better. But if patient develops any postoperative complication, then the recovery gets delayed, discharge gets delayed, and they do not get the treatment, pre-scheduled treatment on time. So cancer outcome becomes poor. So that is why this Henrik Keller, this Danish surgeon, he has given the concept of EDAS in late 90s. And that is a patient-centered, evidence-based, multimodal approach focused on reducing the surgical stress and reduce the postoperative complication. It has got many components spanning from preoperative, intraoperative, and postoperative period. So all those components are meant to reduce the surgical stress, so which will reduce the postoperative complication, quick recovery, quick discharge, and reort on time. So better overall survival, better quality of life, and early reintegration into the society. So if we see these components a little bit in details, it starts from the pre-admission period. So whenever patient comes in the pre-admission to us before the admission, the patient has got a lot of anxiety, tension, what will happen to their perioperative period, what will be the outcome, everything. So they need a comprehensive preoperative counseling with procedure-specific and patient-centered information, and also a realistic goal to be set. Then it also contains preoperative optimization of the comorbidities, then lifestyle modification of all the alcohol use, smoking should be stopped, then optimization of the neoadjuvant chemotherapy related adverse effect, correction of the anemia. So we all know that anemia is an independent risk factor which is associated with increased morbidity and mortality. And iron deficiency anemia is very common in oncosurgical patient. So whenever we first encounter the patient, be a surgeon or anesthesiologist in our clinic, we should do the screening for anemia. And if there is iron deficiency anemia, then they should be controlled. They should be corrected immediately. They should do the iron studies. And in iron deficiency anemia, if we have time to optimize, we can start with the oral iron supplementation. But if we have less time, and sometimes these oncosurgical patients do not tolerate the oral iron therapy, so in those cases also we should start iron supplementation intravenously. Then this treatment-related adverse effect. We all know that all the chemotherapy drugs has got the side effect, all the systemic effects. You know the duomycin-induced pulmonary fibrosis, anthracycline-induced cardiotoxicity, Winkelkers-induced neurotoxicity, and also platinum-based drugs can cause nephrotoxicity. So these are, we have to take care and we have to know about the this patient also has got the platinum-based chemotherapy, so we should know the patient may have nephrotoxicity. We have to manage the fluid management properly, and also we can be cautious to use the NSAID this patient. So that is important to know which chemotherapy they received and what will be the side effects. Now, also this patient is nutritionally depleted. Their poor physical status. So all those things require a correction. So this rehabilitation concept is very important because it's a multimodal individualized approach. It prepares the patient for a major surgery, and it can utilize the time from the diagnosis to the surgery. So this time period we can utilize to prepare the patient. And it has been seen that the patient who got the rehabilitation, their recovery is much better, much faster than the patient who didn't get it. So all these nutritional status, physical reserve, psychological status, these things we should assess. There are a lot of scoring system. We should use the scoring system to assess the baseline status, and then we should do the intervention. So nutrition depleted patient, they should get the protein-rich diet, at least 1.2 to 2 gram protein per kg per day. And immunonutrition, there's not much evidence to use it, but it is better to add on to the nutritional supplementation. And also this supplement should be started at least 10 days before. Then physical status also should be improved by personalized and structured supervised exercise involving aerobics, resistance, and flexibility exercise. And psychological status also to be optimized by different techniques. Now, once the patient gets admitted, again, there are a lot of things to be done. Like previously, we used to do all patient bowel preparation that we do not do nowadays. Sometimes in selective cases, rectal surgery may require a mechanical bowel preparation. In that case, we have to take care of the fluid status and electrolyte balance. Then regarding fasting, we all know nowadays we are not giving overnight fasting or prolonged fasting. We all use 6 hours fasting, and for solid and 2 hours for liquids are enough. So this carbohydrate drink, preoperative carbohydrate drink, is very useful, and that reduces the postoperative nausea, vomiting, reduces the insulin resistance. So it is very useful. We all use it. Most of the cancer centers, we use the carbohydrate drink, and in the morning and previous night. Of course, in case of delayed gastric emptying cases in diabetic patient, we still do not use all the time. Thromboprophylaxis is must in case like mechanical thromboprophylaxis is must for all the cancer patient, and in case of high risk cancer patient, we also use pharmacological thromboprophylaxis. Then coming to pre-medication, nowadays we do not use, actually it is not recommended to use long-acting anxiolytic sedation, because we know that they may cause psychomotor and cognitive impairment, and also postoperative drowsiness. So it has been seen that pre-operative counseling and proper education and discussion with the patient, that can reduce the anxiety significantly. Coming to intraoperative period, it is our domain, so we know this. We are now using all short-acting anesthetic agent, but it is a good practice to use anesthesia depth monitor and neuromuscular blocking monitors to titrate the anesthesia agents. Then IV anesthetic prophylaxis to be given within 60 minutes of incision. Nausea, vomiting is one factor which can delay the discharge from the hospital. So we should identify the patient high risk group. In case of two drug combination, in case of two risk factors, we should use two drug combination. But if the more than two risk factors, we should use third antiemetic, and also TIVA can be useful for those patients. Intraoperative fluid therapy. The debate is going on for long. It is still going on, but this is the recent international multidisciplinary perioperative quality initiative consensus statement. They had advised, they recommended that we should not go for the absolutely restricted. Liberal fluid therapy is out now, but we go for sometimes restricted fluid therapy. But they also mentioned that we should use at least adequate amount of fluid, so that we should aim for 1 to 2 liters of positive balance by the end of the surgery. In case of lung resection surgery, we should aim for zero balance fluid therapy in the first 24 hours. And goal-directed fluid therapy will be very much useful in case of high-risk patient. And also sometimes post-induction, we get hypotension. We should not treat with the fluid. We should also use the vasopressors to prevent the vasodilatation. Now, pain management is also we are taking a lot of care about that. And we just now, Dr. Shagun also mentioned a lot of analgesic agent are there. But this is the American Society of Enhanced Recovery, ASER. They had given this nice algorithm. So they gave a lot of emphasis on the counseling part, both preoperative and postoperative. Also, they have used the drugs into 3 groups. One is local anesthetic based drug, and then oral analgesia and other adjuncts. So all the methods should be based on the local anesthetic, mainly thoracic epidural anesthesia based practice. But if it is not possible, then of course TAP block and other blocks can be used. But this local anesthetic based management should be the part of your management. And also they have mentioned that oral analgesia in form of NSAIDs, acetaminophen, gabapentinoid, these things are helpful. You should start those things preoperatively. So in the day of surgery, morning only you can give as a pre-medication and can continue that. And also they also mentioned that you should use at least one or more that from each group of these modalities. And our aim should be not only to optimize the patient comfort, but also to give faster functional recovery with minimum side effects. And they have given a nice terminology, that is dreams, encourage the postoperative dreams, drinking, eating, mobilizing, and sleeping. So again, ESRA, that is the European Society of Regional Anesthesia, they gave the procedure specific postoperative pain management, and they have given this guideline for many of the major surgeries. So it is easily available in the website. They have given even colorectal surgery. They're coming for many surgeries for proper what should be the ideal. But what they have given a guideline, you can change on that. But it's a nice guideline is there to guide you. Of course, the other measures we have to maintain the normothermia, should remove the pelvic peritoneal drains and digestive catheter, a proper glycemic control and minimally invasive surgery. These all help in the early recovery. In the post-operative period, again, we have to continue a good pain control, almost near 0 fluid or electrolyte balance, allow the drink as early as possible, early removal of the tubes, and early mobilization. These are important. Now, this is one study. This is done almost 10 years back by our friends in Royal Marsden. They have looked into two group of patients, their own group of patients in 2011-12 and 2014-15. And they found that their patient population becoming more sicker and more frail patient in 2014-15. And now 10 years down the line, we are dealing with those more frail patients. So frailty, we know it is a multi-dimensional syndrome related to accumulation of age and disease-related deficit, which results into vulnerability of the to stressors. So if you see this diagram, it is very nicely depicts that there is a resource and the risk. With the age, the resource goes down and risk becoming more and more. So it is age-related and it is dynamic in nature. So one point of time, if we assess the patient is frail or less frail, the next point of time, it can be different. So it is a dynamic in nature and gradual decline in physiological reserve. And with that, there is increased vulnerability. So in these, frailty can give a very bad adverse effects. There can be poor postoperative cognitive dysfunction, postoperative delirium, and also fall. So, and also it has been seen that frailty has got a very profound impact on the health outcome. In surgical patient, there can be 25% higher risk of complication, 3 to 5 days more stay in the hospital, and also post-surgical survival rate is poor. So we have to deal with this patient very actively. And this is you can say that age-related ERAS, modified ERAS, and American Geriatric Society bears criteria. They have given the list of drugs what we should avoid. So, but basically, any drugs which have got sedative effect, we should avoid those drugs. In the preoperative period, we should determine the frailty scored by different frailty score are available. So we should determine the frailty score, how much of frail the patient. Then prehabilitation, which is these patient-centered prehabilitation, and geriatric consult will help. Intraoperatively, monitoring the depth of anesthesia is very much important. We should avoid hypotension and glycemic control in addition to other measures. And postoperatively, family presence is very much essential. And good pain control, sleep hygiene, physical activity, and if the patient has got specs or vision or hearing impairment, then we should give their vision and hearing aids to them at the earliest. And early home discharge. This will help to early recovery with the elderly patient. Now, this is another issue just now Dr. Shagun has discussed in details. So can anesthetic analgesic technique affect cancer recurrence? That is also we have to take care perioperatively. These are the things which can affect the perioperative outcome. And many things, many drugs are called as we know just now discussed also local anesthetic agent, regional anesthesia. These are good for the cancer patient, whereas volatile anesthesia, opioids, these are not that good. But these all are based on small retrospective studies without proper standardization. These are many are preclinical and animal studies. So these things still now this current data do not recommend to change any in our practice in cancer patient. So our focus should be to minimize the postoperative complications so that patient can attend the RIOT on time. And that is only possible when there's a robust perioperative care can be built up with the foundation of early risk identification, optimization, rehabilitation, and we have choosing the techniques and drugs wisely. And that can be reinforced by patient education, engagement, and empowerment. And over that, 4 major pillars: optimal anesthetic care, dynamic pain control, pathway-based postoperative care, and rapid rescue system. So optimal anesthetic care, what do we mean about that? It should be a personalized and precision anesthesia, procedure and patient-specific multimodal analgesic plan of pain control, minimize oxygen debt, post-operative nausea, vomiting, prophylaxis, normothermia, euglycemia, lung protective ventilation, avoiding deep anesthesia, and complete neuromuscular blocking reversal. So all these things should be done within the multidisciplinary cancer care setup. So we, as an anesthesiologist, as a perioperative physician, what we call us, we should have a very good communication, a close contact communication with the other specialty like medical oncology, surgical oncology, radiation oncologist. So we should know what patient require, what type of care, what are the chemotherapy they got it, what are the outcome they are expecting, and what are they are expecting from us. We also in turn give the feedback when patient can get early discharge to get the proper post-operative, their pre-scheduled treatment. So there should be a close contact with other specialties. In that case, this together we can improve the oncologic care and we can give the patient back to the family and the society. Thank you very much.
So now the session is open for the questions. I invite both the speakers to be here. Yeah, please.
Increase the volume. Do I use intraoperative epidural and have possibly a high, should the patient possibly a little overload of an that? Which is the better way?
In our setup, we go in for intraoperative epidurals. We give a bolus dose to begin with. We give a volume, that means, and then we give a maintenance dose throughout surgery and continue it in the post-operative period. And towards the end of surgery also, we give a bolus. Yeah, it's in a, say, just a 50 ml syringe going slowly at 5 to 6. You're talking of IV fluids. No, it's, yeah, you can do that. Why not? Exactly. Yeah, your concern. Yes, we do it. And yes, you do require NORAD in certain cases, but it can be tapered off. It's like, I mean, it's worth it. Giving epidurals because
it is not possible all the time to reduce that. This is the guideline says that you should have this much thing, but in practically when you do the major cases, there is a lot of fluid shift, lot of hemodynamic imbalance. That time it's not possible all the time it happens. So many times you have send the patient with a lot of this thing. So it is not possible, but this is a guideline, you should aim for that.
Each patient is different and each clinical scenario is different. You should strive to achieve that. But if you cannot go in for NORAD, go in for something else. Otherwise, yeah, you're welcome.
We have more questions or it's okay. Yeah, I don't know.
Thank you, respected chairperson and speakers. This session has been an incredible learning experience. Now, I would like to invite Dr. N.K. Vinod sir to moderate an interesting panel discussion on topic ERAS, REOT, and role of onco-anesthesiologists in optimizing recovery and perioperative strategies. Dr. N.K. Vinod sir is HOD Anesthesiology, Critical Care Pain and Palliative Care, Sri Shankara Cancer Hospital and Research Center, Bangalore. Welcome, sir.
WhatsApp क्या है वो थोड़ा yeah. Good afternoon, everybody. Thank you very much for giving me this opportunity here.
Everybody, please this side for the next session.
I would like to call upon our panelists for today, Dr. Kalpana Balakrishna ma'am. She is the CEO and Director of Cancer Institute, Adyar, Chennai. She is also a professor and head of Department of Anesthesiology and Palliative Care. And she's a reviewer of many journals in anesthesia and palliative care. And she's also received the Dame Cecily Saunders Award for Excellence in Palliative Care. And her areas of interest are anesthesia for lung surgeries, HIPEC, and palliative care. Welcome, ma'am. Our next panelist is Dr. Durgesh Kumar. He is an associate professor in the Department of Surgical Oncology at Kalyan Singh Super Speciality Hospital, Cancer Institute, Lucknow. And his area of interest are thoracic oncology, head and neck oncology. Welcome, Dr. Durgesh. The next panelist is Dr. Ram Gopal Maurya. He is an assistant professor, Department of Anesthesiology and Critical Care at King George Medical University, Lucknow. He's a BCLS and CCLS instructor and has got over 22 publications. His areas of interest are difficult airway management and ultrasound guided regional nerve block. It's in the top.
Request moderators to please come here when you have to speak because we go from it.
इस वायरस व्हाट्सएप से डाउनलोड करने की जरूरत इसको चला लेते हैं. Our next panelist is Dr. Aparna Shukla. Dr. Aparna is a professor at King George Medical University, Lucknow. Her major achievements are fellowship of Indian Association of Clinical Medicine, and she's editor of 2 books and 27 papers in national and international journals. Her areas of interest are onco-anesthesia. We were supposed to have another panelist, Dr. Anjali Pingle, but unfortunately she had to go back. So we'll be proceeding with the present panelists. We've just heard about the enhanced recovery after surgery lecture by Dr. Josna ma'am. Now, what is important today is not just the theoretical aspect of enhanced recovery of RS, but it's the practical implications and implementation of these protocols in our day-to-day practice. So, as we all know, enhanced recovery after surgery programs are evidence-based protocols, and they are meant to reduce the surgical trauma, perioperative physiological stress, and organ dysfunction related to elective procedures. And as ma'am has told, it was actually conceived by Professor Henrik Kellet, who was a surgeon in Denmark. And the RS Society was officially started in 2010. Now, ma'am has already mentioned the components of RS, but I would like to ask Dr. Ram Gopal Maurya if you can briefly enumerate the components of RS.
Thank you, sir, for giving me opportunity to start the session. As already ma'am has told, it's a multidisciplinary approach. This is the evidence-based protocol, and it involves the triad of perioperative, intraoperative, and some post-operative triad, which includes some perioperative triads like it starts from PAC, where we start from pre-admission counseling and optimization for patient for his any comorbidity and rehabilitation in the form of their nutritional and psychological and physical health. and also NPO guideline. Never too fast, prolonged NPO, and 2 hours liquid NPO guidelines should be followed, and thrombovenous prophylaxis should be included in preoperative phase. And in intraoperatively, we can choose for, if surgical point of view, we can uh, try to go for minimal invasive surgery like laparoscopic surgery, robotic surgery. And for anesthesia concern, we have always choose our anesthesia, which is short-lived and without prolonged duration of effect. And for analgesia, multimodal analgesia, like for thoracic surgery, epidural analgesia can be chosen. And for laparoscopic surgeries, TAP block is very frequently used in ERAS protocol. And we also should avoid put unnecessary drains like rice tube and drains. If it is not required, we should avoid it. And also fluid for goal directed fluid therapy should be focused. Like we can use dynamic parameters like pulse pressure variation, stroke volume variation can be used for fluid, and try to maintain euvolumia. Over hypervolemia is always, as known, it increases the post-operative complication and morbidity in patient. And also we should maintain the normothermia, and hypothermia is deleterious effect on the patient. In post-operative phase, in early mobilization, early feeding, like starting off oral sips in 4 to 6 hours of post-operative duration. If patient is not able to take oral, you can start internal nutrition, but nutrition should be started as soon as early possible. And for analgesia, as already talked, multimodal analgesia should be focused, and prevention of nausea and vomiting is very important, for which we have to go for TIVA, and dexmedetomidine and ondansetron is quite recommended. And early mobilization should be there, and drain should be checked for next day key it is required or not. Nasogastric suit can be removed for next day. If it required, it can be put for next second or third day if patient is still in ileus and abdominal distension and nausea vomiting is persisting. And early mobilization, Jason.
Thank you, Dr. Ram. So these are the components which are there. May I see with a raise of hands, how many of you are actually implementing ERAS protocols in your hospital? Okay, thank you. Kalpana ma'am, can I ask you this question? Do you think really that implementation of these ERAS protocols can lead to better outcomes? And what is your experience, and what does the evidence say?
Hello. Yes, there is, I think, I don't know, a little bit of evidence from India, but lot of evidence from abroad to say that yes, ERAS protocol can be implemented, and it does say that there is the decreased complications and decreased length of stay. Regarding the other long-term outcomes of, better outcomes, better post-operative long-term outcomes, there is not enough evidence. But the most important thing would be the compliance to the so many elements that are there. There are so many elements, and there is a lot of variability across institutions on how these elements are actually done. So that is one important point. And from our own experience, we have not been very compliant, very good at maintaining, is what I would say when I look back on auditing our own department. Maybe we should ask the rest of the people on what do you feel about your departments. I'm not satisfied with what we are doing.
Thank you. So, yeah, as ma'am has said, there are several papers which have shown that implementing an ERAS protocol does help in reducing the recovery time, length of stay, cost to the patient, and has also increased to some extent the patient satisfaction. But there is definitely some resistance to change, which is one of the barriers. And here, this is one of the important papers where they have shown that patients who are undergoing colonic resection with enhanced protocol had half there was no increase. One of the few papers have shown that when we measure the physician-centric metrics of patient care in the hospital, they have definitely shown improvement. Whereas if you ask the patient-centric metrics, like their patient's comfort after going home, or the quality of life after they have gone home, there has not been significant changes, or it has not been audited properly. In fact, this study by R.W. Day, which included Dr. Henrik Kellett himself and also our uh, SOAPC member, Dr. Vijay Gottumukala, they have shown that less than 10% of the studies were patient-reported or patient-centric metrics of recovery, which included quality of life or the functional status of the patient after going back home. So, with regard to these, there has not been adequate evidence to show that ERAS protocol implementation has got significant effects. Of course, there have been given suggestions that we have to improve, or we have to do further research, uh, taking into consideration the outcomes of patient metrics like functional status or overall health or quality of life. So these are the things which we need to actually do research on to establish that ERAS protocols have a significant improvement on the patient condition. Now, Dr. Aparna, what are the common barriers to implementation of ERAS, and what is your experience in your hospital?
Thank you, sir. Yeah, there are multiple barriers for the implementation of ERA, as said by ma'am. First and foremost, the most important barrier is that development of a unified, novel, and the center-based approach, and so that all surgeons, nursing staff, and in the multi-specialty hospital all come on the common platform. They understand same language and behave in the same manner. Another barrier is patient education of the patient. Most of the patients which come to my institute are belong to low socioeconomic status. They don't understand. आप बोलोगे ये क्लियर कार्बोहाइड्रेट ड्रिंक पीना है, वो लस्सी पी के आ जाएंगे। आप ही ने बोला था डॉक्टर साहब पीना है कुछ 2 घंटे पहले। तो ये एक इम्पॉर्टेंट बैरियर है। दूसरा, देयर इज रिलक्टेंस ऑन द पार्ट ऑफ सर्जन, on the part of anesthetists, our residents, at every level. We do not want to start any new thing which will be some sort of headache. कि ये क्या है, अच्छा खासा जाते थे, उल्टी करा देते थे, चले आते थे। So actually we need a proper teamwork for the implementation of ERAS protocol in every institute, and in my institute the OTs are very much scattered. We don't have proper pre-operative ward nor post-operative ward. Burden of patient is too much. We have to do 11 oncosurgery cases in one day. One consultant runs 3 tables at a time. So we are running here and there, some difficult intubation, something here and there. So implementation of ERAS protocol becomes very difficult. We are trying to build small teams of the anesthetists, surgeons for the different super specialties, so that we can introduce this in our institute also.
Thank you, ma'am. So there have been several studies in the past also where they have found difficulties for implementing ERAS. This study by Rulin et al., they have shown that reasons for non-compliance are usually medically justified, especially in the post-operative period. They've seen that the non-implementation is maybe medically justified for retaining the drains or catheters and etc. And another study by Pearsall et al. Have shown, they have interviewed the team members of the ERAS committee, and they have seen that conditions like lack of nursing staff and poor financial resources, and the most important thing is the lack of communication between the team members has led to poor implementation of ERAS protocols. In this study, they have actually, sorry, Dr. Durgesh, they have actually blamed the surgeons for poor implementation of ERAS. If you can see the last line there, surgeons are ready to accept changes that do not interfere with their practice. So whatever changes need to be done as far as anesthesia is concerned, they have allowed them to do it. But with regard to surgical management, they are not willing to accept the changes. So these are some of the barriers which lead to poor implementation of ERAS.
Dr. Durgesh, may I ask you this question? What are the common areas of resistance from the surgeon side for implementation of this?
Sir, first of all, we have to understand that oncological cases are a very good subset where we can implement the ERAS protocol. Because unlike the benign cases or the emergency surgeries, we have enough pre-operative sufficient time to prepare the patient. I don't call it resistance, but it's my concern. When we talk about the three parts of the ERAS, that is perioperative, intraoperative, and postoperative, we have no problems in dealing the patient in intraoperative period. But in the preoperative period, in almost 70-80% of the cancer cases, they have received preoperative chemotherapy or preoperative radiation therapy. We have almost 4 to 6 weeks of time to prepare them. So what I think that we should have a very good team that that has proper communication setups to counsel the patient in the preoperative settings. Regarding, first of all, cessation of smoking, tobacco, proper nutrition, and the patient must have to be informed about the surgical procedures, possible complications, and they should know that what is the expected outcome when we are going to discharge them. Intraoperative, there is no problem. But again, in the post-operative period, in our day-to-day practice, we find some resistance from the patient point of view. For example, if we allow the patient orally on the day one, so our staff or our team must be ready to follow the instructions and tell the patient on regular basis that you have to take, because many times patient by himself will not follow your orders to take the oral diets and all that.
Many of the surgeons have some hesitation in starting oral feeds about 8 to 12 hours after surgery. So what is your concern in that situation? Why are you hesitant to start oral feeds immediately after surgery?
I think, sir, in current situation, I don't think any surgeon has hesitation in starting the oral feeds. But depending on the surgeries and what organ we have operated, we decide the feeds. Like if we have done a commando surgery, we are not going to give any oral feed. We start the rice tube feeding or feeding through the feeding gynostomy on the day one. Likely, if patient has underwent esophageal surgery and we have done anastomosis in the neck, though evidence has said that you can give oral diets on the day one, none of the surgeon is going to give any liquid diet. So we prefer to give the enteral nutrition in the form of either feeding gynostomy or rice tube feeding or nasovaginal feeding. Yes, in colorectal surgeries, lower anterior resection, ovarian, endometrial, or pelvic surgeries, we have no problem in starting oral feeds in that period.
So Dr. Durgesh mentioned that we have to have a team and we have to establish a team in starting the ARAS protocols. So Kalpana ma'am, in those hospitals where ARAS is not implemented, what suggestions would you give so that they can proceed in a systematic way in order to implement their program?
I feel that any form of systematic implementation needs a systematic improvement. That means a quality improvement process that has to happen across the institution. For any quality improvement process, there are to be people who are drivers of the thing. So you need somebody from the administration who is with you for you to do. The HOD has to be on the same page like you. So you can try the best. You need people who are going to fight for this cause. You need a few people who are going to be there for it. Maybe surgical residents, maybe anesthesia residents, maybe nurses, physiotherapists. Have them get them fine. Typically, in a quality improvement, you do something called a PDCA cycle. You do plan, do, act, and check. You keep doing those cycles repeatedly till you improve. Take one component at a time. So plan, find out the baseline. What are all the lacunae that you have before starting your record? The ERAS. This. You write down you plan it. Then you try to act on one of those things. Can I improve one of them? Yes, I know that the highest compliance is best for a ERAS, but we cannot suddenly and start doing everything. So start one by one, try to change the administration, the head of the department of surgery. If you get them to be on board with you, then he's just going to say, follow this anesthetist, whatever they say. So that is great. So things like that, whatever is possible, go and talk about it. Let people know about how important it is. Let the other champions, the nurses, the physiotherapists, people who are going to start making the patient walk on the first day itself, make the patient, let them be aware of the benefits of this, and start build a team of people who are going to be with you, and try to convert the people who are not with you over a period of time with the evidence and this. That's what is the crux of it, and keep doing the cycle till you achieve what you want. It's easily said, but quite difficult to do. But
Thank you, ma'am. Very well said. So for ERAS implementation, as ma'am has mentioned, first of all, you have to assemble a group of motivated and interested healthcare professionals. You have to first form a steering committee consisting of the anesthesiologist, surgeon, primary care nutritionist, physical therapists, nurses, etc. Identify an informal leader. As far as possible, preferably an anesthesiologist would be the best person. He or she should serve as a facilitator to interact with all the other members. And we should not try to change the organization, but we have to try to change people who are willing to change. Those who are interested in adopting these practices, those are the people whom we have to change and motivate. And it's very important for the people to have self-conviction and self-motivation so that they will drive the system properly. And for conviction to occur, the individual should experience some sort of dissatisfaction or discontent with the present system. And that will be the most important motivating system to drive those people. And once you get this team, then you have to develop a protocol, the best practices from whatever evidence is available, then identify those areas which may pose difficulties for due to the local circumstances and culture, and modify the protocol according to that culture, and check out what are the limitations, educate all the other healthcare personnel, and then start with a pilot project in relatively healthy subjects. Once you have established this in relatively healthy subjects, then you can take it over to the other patients also. So this would be a very systematic way in which you can start a REST protocol in your hospital. Dr. Ram Gopal, how does prehabilitation help in better post-operative surgical outcomes, and what does the evidence say regarding prehabilitation?
Rehabilitation. Basically, in oncological surgeries, as Dr. Durga said, that we have enough time, so we can plan a patient accordingly and electively. So we get a time of 3 to 4 weeks for oncologicals in some oncological surgery. So prehabilitation help in many ways for good outcome in the patient, like a prehabilitation in the form of physical prehabilitation. Patient may go with some mild aerobic exercises and breathing exercises, which may help in increasing their muscle power and which help in preventing post-operative fatigue and weakness. And chest exercises and respiratory exercises help in prevention of post-operative basal atelectasis and post-operative respiratory complications. And like nutritional rehabilitation, we can assess the patient nutritional status and what the required for patient good outcome, like a protein supplementation, immune modulation supplementation like omega-3 fatty acids, and protein diets can be increased, which can be helpful. And also psychological support. It is very important psychological support as a patient is for going for surgery. It is already a stressful condition. If we provide a patient with a good psychological support and proper counseling, what is the patient condition, what our patient is going with, what are the process through which patient is going, and what are the recovery time. Most important is the patient to have to be explained about recovery time. If patient is not explained about recovery time, it is very cumbersome to understand कि मेरी recovery कब तक होगी. जब तक ये patient को exactly नहीं पता होगा कि वो अपने इस disease condition से कब तक recover कर पाएगा, उसके लिए वो बहुत anxiety full stress condition होती है. तो psychological support बहुत important रहता है, जो उसकी anxiety को reduce करने में help करता है. तो all these are basically, and second thing is बैड हैबिट अगर उसको कोई है, लाइक स्मोकिंग है, अल्कोहल है, तो उसका भी हम एक प्रीहेबिलिटेशन कर सकते हैं. सिजेशन ऑफ स्मोकिंग कर सकते हैं, अल्कोहल को उसको विड्रॉ करने के लिए, मतलब इमीडिएट तो विड्रॉ नहीं हो पाएगा, बट उसको धीरे स्टेप डाउन करने के लिए कर सकते हैं. All these are helpful in increasing the post-operative outcome. As per asked, what is the evidence? There are some systemic reviews. Reviews are there, like one study in 2014, multimodal rehabilitation model they have done. They have included 10 studies with including 115, 150, 100, 1,500 patients, and they have found there are no significant effect on post-operative, but they have found if physical activities were involved in pre-habilitation program, this lead to decrease in duration of hospital stay. So one study is this, and another study, I think 2021 की systemic review है, 178 patients के आसपास था, but they also had concluded that there is no significant difference in overall outcome in cancer patients, but they have definitely quoted that hospital stay length is decreased. They have quoted with so all these studies had low recommendation, but still they are recommending you can go with a prehabilitation in oncological substance.
Thank you, Dr. Ramdev. Correctly said, the functional status of the patient is increased significantly with rehabilitation in the form of exercise, nutrition, and psychological counseling. And this study was another significant study which was done in very recently, 2025. They have compared the standard care with rehabilitation, and they have clearly quoted that compared to standard care, rehabilitation significantly improved the 6-minute walk test at 4 weeks after surgery. But there was no statistically significant difference in the 6-minute walk test between the two groups 6 weeks or 8 weeks after surgery. So it is an immediate improvement in the functional status of the patient. Rehabilitation reduces post-operative complications and improves short-term physical function in digestive surgery patients. However, long-term effects are unknown due to a lack of follow-up data. There's another study here in 2025 itself. Thus, rehabilitation improves surgical outcomes. Here also, they have clearly said that the certainty of evidence was low to very low for most analysis, largely due to challenges in achieving blinding of participants. As we all know, the types of surgeries are totally different, and the interventions which are given are also different in different types of patients. So, though the analysis supports rehabilitation involving exercise and nutrition, but the available evidence offers little guidance as to how these interventions should be designed and implemented. So let us go to the next question. Again, Kalpana ma'am, what is riot? Dr. Josna ma'am has already explained, but as anesthesiologists, how can we
I think Dr. Josna has spoken about it in detail. Return to intended oncological treatment is the idea behind us as onco-anesthetists. We want them to go back on the treatment so that they can finish their oncological treatment in the period that is specified, so that the best outcomes can happen. So with that idea, anything that can be done to improve outcomes, to ensure that time gap doesn't happen, whether it is time to surgery or post-surgery, for them to go back to neoadjuvant chemotherapy, whatever you can do to improve outcomes, wherein the ERAS fits in very well with rehabilitation and with intraoperative, many of the elements, if you do it the right way, there is enough evidence to definitely show that the post-operative hospital stay length is, in almost every study, it says, length of stay in the hospital comes down, the patient goes back to. It may be another challenge which I didn't speak of is, some patients will say, why do you want to send me off home the third day? I don't want to go home. That patient, so that is one more challenge which we'll have to, may have to address. But the thing is, with good ERA protocols, we should be able to go back and return to the intended oncological therapy on time. So,
thank you. So it has been clearly said that failure to REAT is associated with significantly worse oncological outcomes, and it is an unequivocal sign that surgical patient has achieved an adequate recovery, which is sort of a metric for success of the ERAS protocol. Dr. Aparna, now coming to some of the specific components of the ERAS protocol. Dr. Aparna, how does a carbohydrate loading help a patient? Do we need to stick to maltodextrin alone, or can we give some water or any carbohydrate drink too?
As we know, as suggested in the conventional fasting guidelines, the 6 hour fasting time is not a 6 hours. It is 12 hours or sometimes 18 hours for the patient who are posted last in the list. So the carbohydrate loading in these patients is very helpful as it reduces the anxiety, decreases the release of inflammatory markers, reduces the insulin resistance, and to some extent corrects the negative protein balance. So yes, the carbohydrate loading is helpful for the patients. It is suggested now and it is an established fact by many studies. Maltodextrin we use because it is a complex carbohydrate. It has a slower absorption, slower digestion, and therefore rise in the blood sugar level is not sudden. So can be given in the type 2 controlled diabetic patients also. The patients who are intolerant to maltodextrin, other polysaccharides can also be given. And in the patients with issues with the financial issue, other carbohydrate drinks we can give, like the apple juice, cranberry juice, or grape juice. But grape juice has high carbohydrate, suddenly blood sugar level is raised. So it should be avoided in the diabetic patients. So yes, complex carbohydrate drinks are good. Protein supplementation and other amino acids supplementation should be started at least 2 weeks prior to the surgery to build up the patient.
So the concern with preoperative feeding the patient with carbohydrate drinks has two aspects to it. One is we are concerned that if the patient takes too much too close to surgery, they might regurgitate or aspirate. And the second thing is if we delay the feeding, if we fast the patient for too long, then they'll be very uncomfortable, and that will also increase the insulin resistance. So with this regard, there are several studies which have shown that maltodextrin or fructose before surgery can improve the patient's subjective well-being, and also it reduces the post-operative insulin resistance without increasing the risk of gastrointestinal discomfort. This is another study where they have shown that the preoperative carbohydrate loading is very important, and it helps in reducing the insulin resistance. In our institute, we did a study where we compared preoperative maltodextrin, preoperative water, and preoperative apple juice in about 120 patients. We measured the level of insulin resistance by using the HOMA-IR method, and we found that those patients who received maltodextrin had the least amount of insulin resistance in the postoperative period. This was followed by those who had water. So the insulin resistance was least in those with maltodextrin, followed by water, and those who had regular apple juice had the maximum amount of insulin resistance. But all three of them, with regard to the patient comfort, all of them were equal. So definitely preoperative maltodextrin helps in reducing the insulin resistance. Dr. Ramgopal, how strict are you in practicing 2-hour NPO for liquids in your institution? What are the difficulties you face? And have you had any problems by giving liquids 2 hours before induction?
In our institution, we usually order in PAC for NPO as the regular guideline for 6 hours solid and 2 hours for liquids. But PAC orders are usually followed by surgical teams, like their residents and surgery teams are involved in following the PAC orders. So sometimes it is followed, most of the time it is not followed. The patient is kept NPO from midnight of the surgery, and he is on NPO from next evening, afternoon. So it is very difficult to follow for 2-hour NPO guideline from our side, because if we are following pre-operative assessment and pre-operative preparation is done by from our teams, from our side, then it is easy to follow. But in our institution, it is only and solely taken by surgical team, and we are just ordering, and we are trying to get it done, but we are facing much problem. As Aparna ma'am has mentioned that we are doing a lot of cases, like 10 to 11, 12 cases, oncological cases in a one day, 3 to 4 trolley on a single faculty. So it's very difficult to analyze each and all the patient that to follow and strictly to follow the ERAS protocol or FPO guideline. So it's very difficult in our institution.
Thank you. So there are several studies which have shown that the gastric emptying of clear liquids is mainly affected by the volume of fluid. And if you give clear liquids before the surgery, 2 hours before surgery, it in fact washes off the gastric secretions also, and it reduces the chances of aspiration. This graph shows the volume of liquid as well as the caloric content of the liquid. And if you can see, those liquids which have very high caloric content are transported slowly, but whereas those with the low caloric content are transported through the stomach rapidly, and that along with that the regular gastric secretion also is cleared out. Dr. Durgesh, on what basis would you start feeds in the post-operative period, and what prompts you to wait to start the feeds? This, of course, you already partially answered, but
So depending on the type of surgery and general condition of the patient. So we prefer to start the feed, whether it's oral, oblique, internal feed in form of nasojejunal feeding gynostomy or tube feeding. So despite of any cases, we are happy to start the internal feed. And so we start with the sips of the water. So on day one, we don't follow that. On the day one, we start feeding the solid or semi-solid, because we are of majority of the cases are major cases, except some breast or thyroid or parotid we remove from the list. They can be allowed in a full normal diet on the post-operative day one. Rest all the patients, we start with the oral sips of the water, approximately 30 to 50 ml per hour. If patient tolerates well, there is no nausea or vomiting, then we slowly increase the clear liquid. That is water or the coconut water only on the day one. And after the day two, then slowly we progress to the feeding. And if we start jejunal or RT feed, we usually start with the approximately 50 ml per hour and slowly progress to the 150 to 200 ml per hour in the post-operative day two.
So how do you optimize the caloric content and the protein in this one of the patients? Suppose the patient has undergone a major uh, abdominal surgery like intestinal resection or something. By what days, how many days do you take to optimize the caloric content?
Till day 5 or day 7. Till that we can manage with the normal feeds and all that. If the patient we are expecting some prolonged deficiency, then we go for the proper calorie calculation.
Dr. Aparna, can you answer the same question? Any changes in your answer?
Actually, here also, this part is majorly taken up by the surgeon. But if we are lucky enough and the patient is shifted to our ICU, then and the patient is not having any nausea, vomiting, and we try to start early feed within 24 hours after surgery.
Thank you. So most of the evidence says that you can start early oral feeding, say with clear liquids initially, and then progressively after about 4 to 6 hours, you can go to full calorie feeds and try to optimize the calorie content by within 3 days. If you're not able to optimize the caloric and protein content by 3 days to at least 80% of the caloric content by 3 days, then you can give some supplemental feeds in the form of parenteral nutrition. So Dr. Durgesh, again, how often do you leave drains and catheters for more than 2 days in a patient? And what prompts you to leave it for longer?
So first of all, urinary catheter. So if there is a specific bladder surgeries or during the pelvic surgeries, we have some expectations that there is a possible injury to the nerves. In those cases, we intend to keep the urinary catheter for the long time. Otherwise, in rest other surgeries, if it is a minor surgery like head and neck or upper GI surgery, day one catheter is removed, or maximum on the day two we remove the catheter. And coming to the post-operative drain, we have to first understand the drains are not meant to prevent the complication. If complication is going to happen, it will happen. It will help us to identify the complication early. So being a surgeon, I would like to put drains in approximately all patients. But in some subset of patient where there is no multi-visceral anastomosis or patient was very prolonged time, we can remove the drains on day 2 or day 3. Like radical cholecystectomy, if there is no biliary leak on day 1 or day 2, we can remove the drain on day 2. But if patient has underwent Whipple surgery, so definitely the drains are going to be there at least 7 to 10 days to detect the sentinel bleed. Otherwise, we have a very good facility of intervention radiologist and alternative method of percutaneous drainage as and when required. If patient has minor amount of blood in the wound, at that time only we get the CT angiography to look for the bleeder and CT angioembolization must be done. So depending on the hospital resources, we should plan accordingly.
Okay, now coming to the last question, we have seen that there are so many protocols, so many points, the components in the RAS protocol, almost 26 points are there. Kalpana ma'am, compliance to what percentage of these RAS protocols will ensure maximum benefits to the patient?
So with 23 for 26, whatever number, it's very variable. This many protocols, if you take off 3 and have 19, it's outside, but it may be, but when there are permutation and combinations, when there are 23, are so many. How do you give weightage for each of that? That's very difficult to give weightage. And that is why when we talk about compliance in a general trend of saying over this many percentage, there are multiple publications which talk about in hepatic surgeries, in the gynecological surgeries, wherein they say that the greater the compliance, the better the outcome. The better the outcome in terms of early discharge, lesser complications, maybe better outcomes long term. There is not much evidence for that. The typical numbers that are given are, there is one study where 60 to 80, more than 80, and less than 60, it was divided into, and one which more than 80% compliance was better. And then in gynecological surgeries, it was a fairly recent publication where they saw less than 70 and more than 70, and they found that the group which is more than 70 had a better compliance. But my point again is, when you have so many numbers, what is 70? How do you give weightage for each of those things is very important, is something that I feel strongly. And this was brought forward in a checklist by which was published, called Recover Checklist, wherein they said that it is typically a recommendation for ERAS with a checklist on compliance, outcomes, and recovery. So there is a bunch of checklists wherein they say that each of these points, that if you go into the specifics and then compare, the outcomes can be better. When you talk about like preoperative counseling, what all was counseled, how much? You are talking about education of the patient. What was told? You're talking about preoperative fasting guidelines, maltodextrin or water or appy or whatever. Intraoperative. He did say that intraoperative is fine. There are so many elements in intraoperative which are not so fine. So what about temperature? How do you do it? How much, what drug is used for multimodal analgesia? Whether it is comparable between studies. So those are the elements which you have to go into the details for you to say whether some compliance is correct or not. So I think we should all be following these checklists to see and have a robust multimodal, multicentric study to see that whether outcomes are similar and whether they can be compared. Otherwise, at this point, I feel that it cannot really be compared just by ticking something and saying that it is over 80 or 70 or 60% may not be the answer, is something that I strongly feel. So when they talk about the epidural, they are saying clearly indicate how much epidural, what dose was given, and go into the details of each of those points. Then only it makes sense to compare. So that's what I would say.
Very well said. So studies have, as ma'am has said, studies have definitely shown that compliance to these protocols have shown a form of dose dependency. As the compliance increased, the complications decreased, and there was an improvement from 50% to 90% of decreased compliance rate by increasing the compliance rate by 20%. So patients who had higher compliance had reduced risk of 5-year cancer-specific death, according to these two studies. So I think this will conclude here, and thank you very much for giving us this opportunity. I will thank all my panelists for Excellent answers. Thank you very much. Yes, please.
The second was valid. So the Delta hospital it was 9 days in the without Erasmus and 10 days, 9 days in the Erasmus, 10 days in the just 1 day difference. And the valid was a difference of 10 days of course. So what I'm trying to emphasize is we need other indicators measure the efficacy of Erasmus, not just LOS and RAI.
Yes.
So in us, we noticed there are 3 competency levels. They were lower in the patients who we given who are the Erasmus. So the so these dynamic surgeries with reconstruction, this was the patient sample. So that's all. And another aspect was creating levels. It made a lot of
Thank you all the respected panelists and moderator for engaging in this valuable discussion. Now, I would like to invite Dr. Sikha Sachan ma'am onto the stage to moderate an interesting panel discussion on topic Onco-Critical Care, ICU Admission to End of Life Care. Ma'am is Associate Director of Critical Care, Regency Hospital, Kanpur. Welcome, ma'am. Now I request ma'am to invite our panelists onto the stage.
So, hello everyone, and at the outset, I would like to congratulate Dr. Indu, Dr. Sandeep Sahu, Dr. Sohan, Dr. Jyotsna ma'am for the inauguration of the Lucknow branch of Society of Oncoanesthesia and Perioperative Care, of which onco-critical care is always going to be a very, very essential and integral part. So today's panel, is this working? Yeah. So today's panel discussion is about everything starting from ICU admission to end of life care. And I have with me a very eclectic and experienced group of panelists. Please welcome Dr. P.V. Sai Saran. He is Associate Professor in CCM SGPGI. In place of Dr. Sohan Solanki, Dr. Abhishek Kumar will be pitching in. He is DM Oncoanesthesiology from AIMS and currently he is a faculty in KGMU. Dr. Bindya Salunke, Professor in Anesthesiology, Critical Care and Pain at Tata Memorial Hospital, Mumbai. And Dr. Amit Rastogi, he is Additional Professor of Cardiology, Cardiac Anesthesia and Perioperative Care at Sanjay Gandhi, Lucknow. Now, there was a time when treatment of cancer and cancer patients, particularly those who had advanced malignancies and active lesions, they were admitted into the ICU with a very dismal prognosis and with a lot of despair because the treatment options were limited. But now, in past few decades, the therapy for cancer has grown by leaps and bounds, And it's not just limited to radiation and chemotherapy, but newer and sophisticated advancements in surgeries have taken place. And also immunotherapy, particularly immune checkpoint inhibitor therapy, has now become the new game changer. And so many patients are being treated, which were early unthought of. But we have to remember that none of these therapies are without their side effects. No therapy in cancer is a walk in the park. So, with newer therapies coming up, newer side effects, consequences which were unheard of, they are also cropping up. And sometimes a person who is working in a general ICU may not be aware of these new changes which are coming with newer group of therapies coming every couple of months. So my first question to you, Dr. Abhishek, is that how is onco-critical care distinct from standard critical care, and should critical oncology patients be managed in dedicated onco ICU setups? Yeah, you can. आप यहाँ से बोल सकते हैं.
How is oncocritical care distinct from standard critical care? Now, this is a good question. So I think everyone who has worked in ICU receives a spectrum of patient, and I think one subgroup of patients will be oncological patients. Now, it depends if you are receiving this patient, what was the indication of these ICU patients. For example, a young male, 34-year, in case of hematological malignancy, he was treated with chemotherapy and he landed in tumor lysis syndrome. He is sick, he is in shock, he requires mechanical ventilation. So I think for this patient, everybody will be pro, yes, we should take this patient, we should salvage this patient. Now another patient, a 70-year-old male patient, metastatic colon cancer to liver, pancreas. Now he has been, you have received a referral. Now this patient is having fever, hypotension and altered sensorium. Please take this patient to ICU. So there will be a resistance and reluctance to this patient. Should we take this patient to ICU, or just will say we have no beds available, or will focus on other patients? So first difference is the indication, the type of patient which we receive. So in standard critical care, we generally receive patients who are critically ill and we can salvage these patients. Although we have some patients like geriatric patients with severe heart disease, severe respiratory failure, but even then the indications become to save this patient, because if reversible conditions are there, we try to save them. But in oncological patients, we will receive various patients. Some will be salvageable in acute conditions, and some will have poor prognosis. So I think similarly, one most important thing is sepsis. Sepsis is a common indication for admission for general patients as well as oncological patients. So it depends. Now, if a sepsis of patients come from oncological sites, these patients are more vulnerable. They have more mortality because they are immunocompromised. Again, the staging, the patient's physical condition, the type of treatment, and the whether we can revert the sepsis so that he can again go for oncological treatment, because treatment will not be shortened in this patient, it will be prolonged. And so critical oncological patient be managed in a dedicated, obviously, yes, because an oncological setup needs multidisciplinary approach. Now, if you are having an ICU where you are taking general patient, but you do not have medical oncology, radiation therapy, or other expert opinion, and if you are managing an oncocritical unit in a cancer hospital, you will always have an expert opinion to help. So first of thing, you will always want to know what is the prognosis of this patient, and that you will need experts to help you in then decision making. And second, if you want to treat those patients will again go back to the primary physicians to get treated overall. And then the whole thing decision is made by a common consensus between patient, family, the primary physician, and the critical care physician. So how should we proceed with this patient? So yes, a critical oncology patient should be managed in a dedicated ICU if possible. But even if you are running a general ICU patient, you should have some beds for oncological patients, because if these patients are salvageable and you neglect this patient on the sake, if this patient is having cancer, so we are not going to focus on this patient. So you may lose some salvageable patient just because you have a background cancer, so you should not focus on it.
So, Dr. Abhishek, you've really addressed the question in a very point-wise manner. So very quickly, my next question is to Dr. Sai. as you said, there will be some challenges if these oncocritical patients are managed in GICU. So, Dr. Sai, what technical challenges and skill set and staff-based challenges and design-based challenges that you may face in a general ICU when you are treating these patients?
Thank you. First of all, I congratulate Professor Sandeep Sahu and Dr. Indubala Moria for inviting us and for this great conference. I think Dr. Abhishek, Dr. Abhishek has answered majority of the aspect. I will tell you practically what is not there, what is written in the textbooks and literature and all, we don't know. But I am a general intensive care physician, trained not much in oncology background. But I work with people like Dr. Durgesh who are sitting here, who has good amount of experience in cancer setup. So when I worked in Cancer Institute, even though the patient flow that time was less, when I was building an ICU, I really don't know which patient should be given a full code of resuscitation. So, and which patient should be taken to palliative care. So definitely, and once I went back and I worked in KGMC for 3 years. There I have Dr. Suhail Siddiqui, who is very well experienced with Tata Memorial Cancer Setup. Then he used to tell me, like, whenever a malignancy patient is there, definitely a general intensive care physician, a physician who is trained in intensive care, like with dealing with oncological patients, he will be more versed about the surgical procedures, more versed about the chemotherapy drugs, and more versed about the prognosis, especially at up to what level of intensive care these patients require. So I agree with him. And what challenges in general ICU? General ICU usually doesn't have such infection control precautions, like especially when you have a febrile neutropenic patient or a recent bone marrow transplant patient having a positive pressure isolation room, negative pressure isolation room. This structural quality of intensive care unit is lacking in majority of general ICUs, where immunocompetent patients will be handled further. These patients are immunocompromised. They require special approach and special dedication through intensivists who are trained in oncocritical care. Nurses, special skill set, yes, definitely. More stringent infection control practices should be followed with respect to these patients. And I think I have answered majority of your question. Yeah, thank you.
At this point, all of us agree that coming future, we need dedicated onco ICU setups for such patients. Now, post-operative care in complex oncosurgeries is one of the largest indicator of admissions in ICU, with newer batch of more sophisticated surgeries coming up. And it is a good thing because actually this is the subset of patients who respond very beautifully. So, Dr. Bindia, you work in a very high, one of the biggest high volume oncosurgery centers of India. And in the previous panel discussion, there was a talk about a lot of buzz about ERAs and riot. So do you specifically follow a protocol-driven approach to reduce length of stay in ICU and improve outcomes? And also what strategies you follow in terms of opioid use, blood transfusion practices in order to avoid cancer recurrences in far future?
Yeah, so we definitely follow the ERAS protocol. We try to follow as much as possible. I will not say we adhere to the 100%, but yes, we try to follow good ERAS protocol. We have a dedicated sisters which will be going to the ward, seeing to that patient gets a 2 hours prior, or if a second patient is post-state, the first patient will receive a 2 hours prior some epi or liquid. So even at 11 o'clock, one round will be taken. The sister will go and see to that the patient has the next patient. She'll confirm in the OT and she'll go and the sister is only for that. She's going to see. Post-op, yes, we have been trained well. The ICU nurses plus ICU residents plus the anesthesia residents. So they start with the early mobilization. Even our surgeons are more driven to that. Removal of the RT early, the DVD prophylaxis, all this have been followed stringently with us. Yes, that definitely we do. Next thing, yes, length of stay in ICU. Even esophagus, pancreas, they go by next day. Day 2, they go to the ward. We follow them. Our APS team is very well. Team is very good. I will say we have a anesthetist consultant. We have residents. We have a nurses which have been round the clock there. So even the ward nurses have been trained by these nurses. So if the APS team is so good that when they follow up, they find any complication or anything, intimate the surgeon or the anesthetist who are there in the ICU, and we go and check. And if you have to readmit the patient, that is also been followed. So we even discharge within 24 hours. Our patients go to the ward. Most of the patients, except for the high tech major surgeries like liver, maybe they may stay for a year.
Next question is also for you. You talked about surgeries. So, what special fluid electrolyte management guidelines you follow for these surgeries? Because these are complex surgeries, large volume shifts. These electrolytemias are common owing to the chemotherapy and drugs that are instilled. Routinely, you would never go for magnesium, phosphorus level check-ins in a general ICU per day. So, do you have a protocol for tackling those in place and well? Very briefly, just answer.
Yes, we do have. Actually, I can say that ERS, that the management perioperatively, it starts intra-op as well. So intra-op only, most of the patient of us get a flow track or some cardiac output monitor. So stroke volume based monitoring we do. If patient becomes intubated, when there is a diaphragmatic stripping, large volume high packs which are taken, then they will come ventilated for at least for 24 hours. From then, we'll look at the ultrasound, we'll see the IVC. Even when the patient is extubated, we'll see the IVC, how not a variability, but we'll see the size of the IVC and the stroke volume of the patient, and that we mostly follow for the fluid management.
Thank you for the succinct answer. Now, whenever we think of immunodeficiency, when we are asked to enumerate the causes of immunodeficiency, cancer comes to our mind. But cancer and immunodeficiency is rather a umbrella term. What is more important it is important to understand how immunodeficiency takes place. What are the various mechanisms that can lead to immunodeficiencies in malignancy? And Dr. Amit, I would like you to answer that. So this how the presence of immunodeficiencies leads to higher chances of sepsis and opportunistic infections.
Thank you. Thank you, ma'am. I mean, these all malignant patients are being exposed to lots of chemotherapies and radiation therapies. And see, every therapy has got a better way and has got a bad way. So better way in the sense that definitely the chemotherapy or the radiation therapy has been targeted for the cancer therapy, but then it's a double-edged sword. The other way around, what happens is basically it is suppressing all the overall immunity of the body. As we know, the T cell immunity has been mediates the T cell mediated immunity and the B cell mediated, which is the humoral immunity, both are getting affected. So there are increased chances of development of various other chemo malignancies. According with that, there's a high incidence of development of Hodgkin lymphomas and non-Hodgkin lymphomas along with this particular therapy that we are giving. So overall, this all chemotherapy targeted therapies are affecting the organ systems, and then all these therapies, like suppose they are giving methotrexate or like cyclophosphamide is being given to the patient, they all are affecting the immunity, and then apart from that, they are affecting the DNA structures. They are affecting that lymphoproliferation. They are causing myelosuppressions, immunosuppressions, and the lots of bone marrow separations there. So that causes a lot of other things like anemia, thrombocytopenia, lymphopenia, neutropenia, and then what happens is opportunistic infections comes into the role with that particular thing. So what is happening is we are treating the patient for his cancer part, but then again we are on the other way we are exposing the patient for as an immunodeficient person. So opportunistic infections, various viral infections, toxoplasma, pneumocystic infections, candida infections. They are also viral infections like cytomegalovirus infections are also coming into role to play. So we have to edge out, and then when these infections are flaring up, we need an ICU, and then again we have already discussed lots about whether we need an onco ICU or we need a general ICU. But I think I just wanted to add that particular point. It's because there are very few centers in India which are dedicated onco centers. Most of the centers, surgical patients, the malignant patients are being operated. They are being operated here and there, but they don't have dedicated onco ICUs. So I think putting up separate beds and separate nursing staff who can cater these particular patients in that general ICUs will suffice more rather than having a dedicated onco ICU, but because it will be a very burden on the hospital to dedicate a separate onco ICU.
So that's right. So when it comes to sepsis and immunodeficient cancer patients, you have to broaden your lateral thinking and think about opportunistic infections like staphylonegative, conch, and also invasive fungal infections, and as he said, CMV, PCP, etc., which would really not trouble another septic shock patient who is otherwise immunocompetent. So you have to think. Yes. So steroid therapy is going to hit a cancer patient in all ways: B cell, T cells, qualitative and quantitative dysfunction of neutrophils and phagocytes, etc. So, Dr. Sai, because time is crucial in these patients, and you may get a bug which you may not have anticipated. There can be atypical infections, there can be PCP, CMV, etc. So, how often do you rely on PCR-based tests for bacterial infections, viral, etc., and fungal biomarkers for early detection of sepsis in these cases?
See, PCR-based diagnostic modalities, as in rest of the immunocompetent patients, we still use whenever a patient has developed chances of infections, viral infections like herpes simplex encephalitis, where the CSF HSV PCR has a role, or any suspicion of common infection which is in immunocompromised patients like pulmonary tuberculosis, where nucleic acid amplification test is being done. That is a bacterial PCR. For bacterial infections, PCR not much use at present. We are getting various pharmaceutical diagnostics which can detect NDM carbapenemase producing organisms, and but these are not developed in every center. And regarding the fungal biomarkers, beta D gluconaceae is not available in our center, and the majority of the centers which we use, it is a pan fungal marker which can be elevated in candidal infection, even in pneumocystis zoonotic pneumonia, these infections. But what we usually do is galactomannan assay. Galactomannan is used in diagnosis or screening of infections like aspergillus pneumonia, where there also a lot of confusion is there at the bedside. The clinical host factors should be meeting it, like the patient with neutropenia, hematological malignancy. There are so many guidelines like EORTC, MSG guideline, or you take ASP-ICU guideline. So many ICU protocols are there in how to diagnose or how to confirm this invasive pulmonary aspergillosis. But whenever we see the host criteria and entry criterion, which is required, like aseptate, acute angle, branching, hyphae, whenever you see in the ET aspirate, when such a background of clinical picture is there associated with neutropenia, and we send the galactomannan, whether in the serum, next question comes whether in the serum or whether in the ball. Serum is taken, but these patients are, when severe hypoxemia is there, when you are not able to send ball, you rely at when cutoff of more than 1 optical intensity, and ball 0.8 to 1 cutoff can be taken, the optical density, whenever you think that there can be chances of invasive aspergillosis. Other than these two PCR-based diagnostic modalities and fungal biomarkers in detection of sepsis, I don't think so commonly we use nothing more. If I can miss anything else, you can tell me. Thank you.
I think for atypical organisms, which are not very easy to grow on cultures, and if time is short, it would be prudent to go for PCR-based technologies. But the only problem is that these tests, whether the PCR or fungal biomarkers, they only detect the component of the organism, of the bacteria or the fungi. Let's say the DNA or the cell wall. They'll not be able to tell you whether that organism is live or dead. So, of course, you have to follow up the cultures, and also the clinical picture and radiological picture, as you said, in aspergillosis is important. But I think as we are moving ahead into the new era of diagnostics, these tests should be more rampant and should be more encouraged in time-sensitive patients like. How you interpret is also important. So again, a person who is working dedicatedly with onco-critical care and attuned with sophisticated setup, he or she would be better able to interpret these results into context. Now, Dr. Salunke, we all know that the incidence of infections in cancer patients is very high. The ratio may be 10:1 versus neutropenic versus normal septic shock patients. These are the IDSA statistics. And for every 1,000 cancer patients admitted in hospital, 16.4 are going to develop line infections. So what would be your empirical antibiotic in catheter-related bloodstream infections compared to other septic patients who do not have cancer? So do you go early with BLI combinations, or do you go early with carbapenem sparing drugs, considering that the carbapenem resistance has become very rampant? Almost 1 out of every 3 patients who is admitted in hospital detects carbapenem resistance. And also, do you start gram positive? Like, what do you do? How do you decide which antibiotic, whether gram negative, gram positive coverage? What do you decide? So I'll tell you about what we do, our protocol. So as soon as a patient comes with a line-related infection, if they have a PICC line or a code, so we have to see why you are saying it is a line-related. If there is a contamination is there, like just on a suspicion of patient neutropenic has come in sepsis, I cannot pinpoint anything. Maybe this line is the reason. So in that case, I will say, don't remove the line. If you have a suspicion, you have a clear cut, there is a pus coming, there is a redness or something, you have to pull out that line there and there. But or previous culture which was positive, maybe then. If it is like your just suspicious basis, you want to pull out the line, you have to think twice, because that long line, it really takes a good effort. And to remove that line is very easy. So if the central line is there, I will say yes, remove that line if with even a minus suspicion, because you can put it again very quickly. But when you have just on suspicious basis, don't remove the PIC line or a port. You can lock it, don't use it. Lock it with the antibiotic, don't use it. Send your peripheral and the central culture, and then see for the time to differential positivity, how much it is. More than 2 hours, yes, then it is line related. Then you have to think that it is line related, you remove the line. So central line is there, I will say even on a minute suspicious, remove it. After that, we also do that, we send biofire, basically we send a PCR in our institute. Also we send a BDG of the patient. On this, we get it within 10 to 12 hours, we get the report. On that basis, we can hit hard on that. So in our institute, we go with the carbapenem. Yes. So that time we also ask the history. If patient is received in the recent past, in the 30 days period, if patient is received BLBLIs, then we'll go for carbapenem. If patient is received carbapenem, we'll go for Zesna. That is the protocol which we follow presently in our institute. So I will say yes, carbapenem resistance has increased, but you have to think if patient is received within 30 days, the same medication, carbapenem is received prior, the patient is going to be most likely resistant to this drug. So you have to go hit hard on a higher this. By the time you send your culture and you start deselecting on depending on that. That will be my take on it. So what we really follow is that we are really scared of carbapenem resistance. It's lurking everywhere. So if a patient who has had a long stay in in hospital, and has received BLBLI combination and is crashing, now he is in critical care for a certain reason, not just for fever, but because of organ damage, hypotension, altered status, and some evidence of organ damage due to sepsis. So we like to add on polymyxins early. And then, as you said, we follow up with a PCR panel or cultures, and then we like to tweak it. So yes, we do start with polymyxins early. And when there is a documentation, even before documentation of infection, if there is pus coming out, if there is a previous history of MRSA infection, if there is a incidence of skin and soft tissue infection, or within 2 days the patient is not responding well to the therapy you have started and cultures have not arrived, we start with gram positive coverage. At least this is what we do at our place, because we really don't want to lose time on that. Now, we know that cancer is closely associated with neutropenia, specifically febrile and critical neutropenia is a troubling entity where you have neutropenia because of the chemotherapy, particularly up to 80% of hematological malignancies, and to the tune of around 10 to 20% in solid malignancies. These patients have troubling mucositis. So because of neutropenia, there is going to be bacterial and microbial translocation from the gut to the bloodstream. And because the first line of defense is broken, the bone marrow is depressed, neutropenia is there are chances of critical sepsis. So how does Dr. Sai, how does neutropenic sepsis affect your empirical antibiotic choice? What do you start? Do you start antifungals head on? What is your empirical? Do you start empirical antifungals? Why I'm asking this question is because giving empirical antifungal, I'm sure you will agree, in a general ICU, even in sepsis, high grade sepsis, is really unheard of. There is no role for empirical antifungal really otherwise. But yes, there is a place for empirical antifungal in select situations in cancer patients. So just tell us your plan. How do you tackle neutropenic sepsis? And also, is there a role of empirical antivirals anywhere in cancer therapy?
It is a difficult question actually because nobody listens in this condition. As you have seen practice, what the guidelines say, I can tell now, but what is being followed? Honestly, all of us should say that what are we following? So guidelines say that it should be whenever there is neutropenic sepsis, we should start with the anti-pseudomonal beta-lactam or beta-lactamase inhibitor. But I have not seen such prescriptions going on even in big tertiary care centers. She can tell about Tata Memorial probably. I can probably say that we have to have some stringent policies in antimicrobial stewardship and prescription. The ideal antimicrobial, as I told, it should be anti-pseudomonal beta-lactam or beta-lactamase inhibitor combination like piperacillin tazobactam. Then, if it is carbapenemase producing, when you have a growth of extended spectrum beta lactamase and the infection, you think that empirical UTI or something needs to be covered, then a carbapenem might be chosen. Next question comes to what about empirical antifungal? Antifungal is not being thought at this moment or at this stage unless there are certain host risk factors like the patient is having a chronic liver disease, patient is having chronic kidney disease in which the patient is dialysis dependent, or the patient is hospitalized for long time. Actually, what we do in bedside scenario is we create the risk factors for giving empirical antimicrobial. The biggest risk, yeah, that's what I mean to say. The biggest risk factor for empirical antimicrobial is us, in which we prescribe broad spectrum antimicrobial therapy. That itself is a risk factor for developing fungal infection. So the patient is already on polymyxin B, meropenem, and teicoplanin. Then there is a fever. Immediately we start empirical antifungal like echinocandin, straightforward. So the guidelines will not recommend at this stage unless there are certain host risk factors. Especially, you can have risk factors in ICU like multifocal candidal colonization. Candida coming from the ET aspirate, Candida coming from the urinary tract of the patient, Candida, as Dr. Durgesh mentioned, coming from the drains of this patient. Okay, these are the multifocal candidal colonization. In such conditions, empirical antifungal will come into the life. What about empirical antiviral? I think hematological malignancies, I think they are very much worried about whenever I go to ward with ALL, AML, all these patients are on acyclovir prophylaxis. And empirically, when I will give antiviral, I have not encountered in the scenario. Like whenever I told that encephalitis picture is there, it has a role. But I don't think so. The respiratory panels, which we had sent prophylactically, we give drugs like amantadine, drugs like oseltamivir. I don't think so. Empirical antivirals have some specific role. Even for CMV infection, ganciclovir, which we have to give, but there are very specific reasons where empirical antiviral should be given. I don't think so. It is mentioned in clear cut in the guidelines.
So what you mean to say that there is no reason to rush with empirical antifungals and empirical antivirals are a strict no-no. Regarding antifungals, I would say that if the patient is having unrelenting fever, is not settling, and you are able to isolate fungal culture from two non-contiguous sites, not just one but two non-contiguous sites. So if there is fungus growing in the drain also and fungus recovered from the blood also, then you have to treat. But just fungus colonizing in your urinary catheter or just in the drain, single site, that is not an indication. And especially you said that you have to follow up with radiological image because invasive fungal infections of the respiratory tract are going to be common. So you do need not just an X-ray, but a CT scan to look for those hints of invasive aspergillus infections. Now, as I said, that cancer immune therapy is the new chalk in the block, and immune checkpoint inhibitors have really changed the way cancer treatment is being seen. And so many cancer conditions which were previously thought untreatable are now being treated with reasonable success. But with every new, so many new maps coming every couple of months, they are coming with their own unique side effects, sometimes in the form of accelerated inflammatory response. Now, not every patient who shows an inflammatory response is a candidate for success. This we should learn. So, Dr. Bindya, my question is to you is just give all of us a brief hint of what could be the side effects of these immune therapies, and why we need to know that, especially a person who's working in a non-oncology setup, and what are immune-related adverse events which can lead to admission in critical care, why are they important, how to differentiate from sepsis, and how to treat them, very briefly.
So, as you have already mentioned, with the treatment, with the oncological treatment, more and more coming, more and more maps are coming in a picture. All this will cause the immune modulation. They cause the depression of the, along with the depressing that system, the T system, they also depress the good healthy system, which is against the whatever, like what do I say, like, so yeah, again a normal organ. So it produces with the like SARS-like symptom. Patient can produce like an infection or autoimmune. Patient can produce with pneumonitis, with myocarditis. So especially when your patient is on this max, then you have to keep in mind this patient can be because of this. Especially after 2 to 3 weeks after the treatment was initiated, even after stopping the treatment, this patient can present with the similar symptom. They can have from neuropathies, myocarditis, pneumonitis, anything, yes. So all the symptoms can come, and only the skin rash they commonly present with. So depending symptoms, we have to keep. And when we send our cultures, when we send our procare, if that comes within normal range, if I send our cultures that is coming negative, then we have to. It is kind of a diagnosis from exclusion, basically. When you don't have any infection, that time you have to. Everything is not infection. You have to keep in mind that. So all these drugs, that's why they are important. They are new and new drugs are coming with new and new side effects. You should know about those immunomodulators as well. Treatment, first thing, stopping, yes, they even after stopping the treatment, it can continue. We have to start with the steroids for this patient. Yeah, high dose steroids are there. Some patient might have to go for plasmapheresis also, and high dose steroids, IVIG. These are the treatment modalities.
So the basic premise of adding this question was that people who work in general ICU, they should understand that not every inflammation is infection or sepsis. And these maps, they come up with everything that can be called as itis, inflammation widespread. And the timing is very characteristic, because what really happens is that with all these immune checkpoint inhibitors, you are trying to fire up the patient's T cell response, so that this fire T cell response, it eats away the tumor cells. But this response is not just going to kill the tumor cells, it is also going to attack the normal tissues. So up to 5% of patients will mount a IRAE. And if you're working in ICU, you have to be wary of that. कि कोई भी patient अगर आ रहा है, specifically after 3 weeks of MAB therapy, you have to be wary that this patient may be a candidate for high dose steroid therapy, as he may be mounting a side effect of the immune checkpoint inhibitor therapy. Now, everything in oncocritical care is not about treatment. Not every patient is admitted with curative intent. So there's something called life prolonging or curative therapy. And then when you realize that this patient's chances of survival in the long term with therapy are not high, sometimes these patients will be admitted in ICU, who will need to have short-term respite from the symptoms that are troubling them, which we call as palliative care. And eventually, when the death is imminent, when the death is very close, then what you offer is hospice or end of life care. So these are 3 distinct entities, and anybody who's working in critical care and dealing with oncology patients should be aware of these 3. Now, my question to you, Dr. Abhishek, is that what is the role of palliative care in advanced malignancies? And just give some examples very, very briefly, as time is running short, of palliative care, so that residents sitting here, they understand what palliative care is all about. And also, I would like to ask if how do you offer palliative care?
And what is the role of palliative care in advanced malignancy? I think there is a special specialty of palliative care for dealing these branches. So I think as the ma'am showed this slide, I think this is the role of palliative care in oncological emergencies. As the patient is diagnosed with a cancer, the palliative care starts at the time of the diagnosis, but initially the goal is to treat the patient. And the palliative care has a small role. As the disease progresses, it becomes untreatable or the symptom burden is increasing, the palliative care role starts. And towards towards the death, I think the life prolonging therapy should be stopped and the palliative care takes a front seat for and the goal is just to give comfort and support to the patient. Do not harm the patients. Basically, palliative care is based on the ethical principles. That is the 4 ethical principles of autonomy, non-beneficence, maleficence, and justice. If you follow these 4 ethical principles on the background of medical knowledge, we can practice palliative care. What are some of the examples of palliative care in unique oncological situations? This is, I think, there is a lot to say on this. It starts from pediatric oncological, then emergencies in palliative care, patients, advanced malignancy patients in ICU who is almost going to die in next 24 hours. And similarly, palliative care is just not treating the patient, it is about treating the family. If you are over treating the patient and you are harming the psychological, financial situation of the family, you are not giving a palliative care situations. So palliative care, if I say the examples of palliative care, there are too many. In fact, all the advanced malignancies which we are not going to treat all becomes an examples of palliative care. What are the challenges in offering palliative care in ICU? Again, these are ethical challenges, and I think most of us worry about legal challenges. Then medical challenges and institutional protocol. There is lack of any institutional protocol. There is lack of any guidelines from international and national societies to how to offer palliative care in ICUs. Regarding, I want to talk about the legal aspects, which I think most of us are worried about. There is no clear guidelines from Supreme Court or any other court how to provide end-of-life care in India. But yes, they have laid some foundations where they are made some important issues, like we cannot use the word euthanasia. We cannot use the word active euthanasia. We cannot use the word passive euthanasia because these are now not the terms which we should use in medical practices, as well as the court has not allowed. Some of the important terms which we can use medically is withdrawal of life support, withholding of life supports, then providing end of life care. And if you are trying to provide end of life in practice in an ICU, it should have 4 steps. The first step is recognition of the patient who needs end of life care. This is a very important, and it is a common consensus found between primary physician, patient, family. If a legal cell is there, yes, this patient should receive end of life care in India. Second is initiation of end of life care pathway, which is a complete protocol. I think there are 2 documents. I will give an example of Blue Maple document from Manipal. If you have time, go and read the documents, how they are made, and end of life care policy. Third is if, including the family, legal and medical, with the goal of comfort care. That is the, now you're practicing end of life care on the patient. That is, you're removing any harm to the patient. You're not giving extra treatment, not putting the patient on dialysis. Considering everything should be documented, so why you are doing it. And fourth is the feedback, and overall how the aim was the comfort care without harming the patient, whether you were able to achieve it or not. Challenges, yes, legal, ethical, lack of institutional protocols, and lack of any guidelines from our societies.
So, before we move to the last set of questions, I will just share my understanding of palliative care. So, if you know that the disease is non-curable, but the patient is conscious and he has come for immediate respite of symptoms, in such patient, you are going to do the procedure. So, if there is a need and there is you cannot place a Foley's, you have to do an SPC. So, that is a palliative intervention. advanced head and neck malignancy, if the patient is having flushing of head and difficulty breathing and symptoms of SPC obstruction, you are going to do palliative stenting in that patient. So these are the, if the patient is conscious and he needs a tracheostomy or an alternative gastrostomy for feeding, because he is going to survive for the next couple of months or a year or so, so you are going to do certain limited procedures in palliative care. So this everyone should know. Now, coming to the last aspect, that what I think I've already answered this question: what is end of life care and how is it different from palliative care? Okay. Okay. And I thought I added a few points more. So any person who is just going to die in a 24 hours or couple of days, that patient deserves end of life care. Now, can you just elaborate on how the end of life decisions taken in India? Are there really any protocols in place? How do we decide? Is it between कि doctor ने और attendant ने आपस में decide कर लिया कि end of life care हो गया? Do we have to involve the judiciary? Is there any clear-cut guideline? And we are doctors. We have to keep ourselves medico-legally safe also. Do we have enough laws and guidelines that protect us when we are taking end-of-life decisions? Because nobody wants to be drawn to the courts, right? So give us your perspective.
I mean, if we talk about my perspective and your perspective and our perspective, there are three perspectives. What we see in Western countries and Western world, their guidelines are very clear. But now we talk about our perspective, Indian perspective, the guidelines are, there's no guidelines actually. And whenever we asked, many times in our ICU, in many of the ICUs, we asked about attendants, what do you think about end of life care? Doctor साहब जब तक सांस है तब तक आस है. They always say. So it's a very contentious issue. Ki what exactly, how exactly it has to be taken. So we have like plethoras of societies are there, but still we don't have any cut short guidelines. How to do, what are how to in which patients we can withhold support, without life support, which are the candidates for do not attempt resuscitations. So still the guidelines are there. Like India is a very big country. We have a population of 1.44 billion at present. We have got 28 states right now, but only 2 states have given some guidelines about end of life care. These states are Kerala and Maharashtra. And that's the dignity. There are lots of other things like that, the dignity and other things, but only 2 states have given few instructions, not the guidelines, but only the few instructions. Like Kerala and Maharashtra, they have given, some society has given so few guidelines about how exactly we should proceed in such circumstances. But then again, when we talk about broad aspect, when we talk about pan-India situation, we don't have any clear-cut guidelines as of now. We don't have any advanced directives there. But then again, it's again a very contentious whether we should advanced directive should be followed or not. So there is no clear-cut guidelines about advanced directive also. Now, so we don't in the paucity of any guidelines, we just follow the autonomy of the patient, and then we have to discuss there are other social and reforms are required for this particular point. And then again, if we discuss this end of life care with attendance of the patient, there's lots of discordance also. So in the absence of all these guidelines, clear-cut guidelines for the end of life care, we are still in catch-22 situation. How exactly we have to proceed in these circumstances. As far as judiciary is concerned, intervention of judiciary is very important. If we want to put any patient for end of life care, judicial consent is very important, because we never know when the judicial hand will come and catch up us for this situation. So I think authorities, society should come together and make a clear-cut guidelines for providing end of life care. And a clear-cut document should be there, and advanced directive, how exactly it has to be framed, how the end of life consent has to be there, everything has to be framed up. So with this line, I just wanted to say the judiciary has to be involved, and society should come up and make guidelines for this particular point. Want to add something? You can come in. It's not okay. It's not okay. You can come in, please. Yes, sir.
All right. So as far as the guidelines, there are guidelines. Okay, the Indian Society of Critical Care Medicine and Indian Association of Palliative Care, we have come up with a recent consensus and position statement of how to offer an end of life care to the patients in ICU, not to the patients who are in the wards. They have been recently written, published in one. I am one of the author of that. So they are there. So we have how to identify these patients. There are certain steps which have been written. Okay, what is exactly about primary medical board, the secondary medical board, even about the judiciary. They had made a very good amendment at the Supreme Court of India way back, I think, in February 2023. They had come up with a wonderful steps how to do a withdrawal and withholding by forming a primary medical board, a secondary medical board. But there was one catch of forming a secondary medical board. We are not very sure, especially in metropolitan cities where we have a municipality rather than a district. So if there is a district medical officer, you can go ahead. But if there is a municipality, we really don't know what exactly to be done in that particular situation. So everything has been clearly mentioned, what to be done, how to do that, how to withdraw, what exactly to be done, what medications to be given. All these things have been clearly mentioned in that paper. And if I think I will share that link with Indu, and I think she can circulate amongst every one of us. Thank you very much.
But what I meant to say is, has it been validated by judicial authorities?
Yes, yes. There is no need of validation by the judicial authorities, this consensus position statement, because it is a position statement by the practicing physicians of the critical care medicine and the palliative care medicine. The judiciary has given an amendment, so we have used that amendment in that particular guidelines.
So I think that guideline has to be followed in that much. Thank you.
So, Dr. Raghu, you very aptly elaborated on that, and you were one of the co-authors of that position statement. But I still think that we have a long way to go and need more clarity. And this position statement is for patients who are in ICU. Now, most of the critical care in India is governed by private sector, right? So, हमारे यहाँ जो सबसे common question आता है कि अच्छा अब तो आप कह रहे हो कि end of life death हो गई है. So keep the patient in ICU or take the patient out of ICU and don't charge as much. Why still the patient is getting charged so much? So I think there are still a few lacunas and we need to elaborate more on them because still in India today, even with the position statement in place, most of the deaths in critical care are by death by cardiac arrest rather than death by end of life declaration. And also there is still a common and consensus end of life form in place. We need a pan-India standard end of life form, which should be very, very simple. It should trickle down even to the MBBS resident who's working in critical care and otherwise hospital. So yes, I agree. I have read that wonderful position statement, but if there is still a lack of understanding, that's why we are holding a discussion here. It needs to be simplified so that every person can understand it, so that we are all medical legally protected. We don't have to face any hassles, and we don't want to be landed in a soup. So there is a long way to go. So I'm very happy that this was a very fruitful panel discussion. Oncocritical care is a vast topic, but we were able to cover up all the essential points in detail, and I'm really happy with that. And also, I believe that as I'm reaching the end of this panel discussion, I believe that just as we have special fellowships in onco anesthesia and special fellowships and DM courses in palliative care, we should also have some short fellowship courses, 6 months or 1 year, specifically dedicated for onco-critical care. So that because oncotherapy is really, yes, you do have, but then there should be more and more cases because financially oncotherapy is now a very lucrative proposition for private sectors. Everybody wants to jump into it. It's no more a science of doom. Everybody, with all the newer and costly therapies coming up, everybody wants to jump into the wagon. So with this, I thank Dr. Indu for having me here and giving me an opportunity to discuss these nuances with all the panelists and all the esteemed delegates and faculty present here. Thank you very much.
Thank you, all the panelists and moderator for this knowledgeable session. Now, I would like to invite Dr. Raghu Thota, SOAPC past president, to felicitate chairperson and speakers of this session. starting with Dr. Asim Rasid. Dr. Sandeep Sahu. Dr. Shikha Sachan. Dr. Sai Saran. Dr. Bindiya Salunke. Dr. Amit Rastogi. Dr. Aparna Shukla. Dr. Ram Gopal Maurya. Dr. Durgesh Pandey. Thank you, sir. Now I will. Yes, sir. Now I would request everyone to proceed for lunch. We will continue the session after 1 hour. Thank you. Continue.
After 20 minutes, the participants who are online, we will start session after 25 minutes. Have your lunch. Thank you. चलो भाई चलो कोई नहीं चल रहा है
सर के लैपटॉप में
नहीं तो व्हाट्सएप से कैसे डालेंगे इसमें? बुलाने इनको भी भेजा था मैंने।
आपके नोन नंबर से तो नहीं है ना? मेरा मेरे नाम से देखिए क्योंकि नेट तो चल रहा है। तो सर को यहाँ पे नियर बाई होना पड़ेगा कि नहीं? चल काम नहीं जाएगा।
चल जाता है एक बार चलने पे तो। अच्छा ऊपर टाइप करा मैंने, वो देखा नहीं, कब तो आ जाएगा। हाँ हाँ
ये आपके
हाँ बढ़िया।
कैसे आएगा? बस ठीक है, मैं देख लूंगी। ठीक है। पहले सब चेक कर।
आया होगा लगता है। वो कराया उसने। यहाँ से तो ठीक है।
वो आगे हरी बत्ती हो गई, बस बस आपकी हरी कर दी। So now we are going to start post lunch session and we have 15 participants here online. and they also have some questions. Okay. Okay. So I request the all in charge to please.
Thank you, sir. Now moving forward, I would like to invite the chairpersons for the next session onto the stage. We welcome Dr. Rajesh Hulalu, sir, Senior Consultant and Executive Director, Jaimus Hospital, former Senior Consultant and Head of the Department of Anesthesia, SCG Hospital, Bangalore. We welcome Dr. Sanjay Chaubey, sir, Professor and Head of Anesthesiology and Critical Care, Eras Medical College and Hospital, Lucknow. We welcome Dr. Hemlata ma'am, Additional Professor, Department of Anesthesiology and Critical Care, King George Medical University, Lucknow. Now, I request our chairpersons to introduce our next speaker.
So, a hearty good afternoon that requires, of course, special mention. We are over with the brainstorming sessions of the onco-anesthesiology, the intricacies, the critical care aspects. And now we enter a stage, a session whereby most likely we are going to discuss something about the way forward. What is the future trend in this case? Mostly. And I think one other topics as well. One is by Dr. Mithilesh Kumar Mishra. So, with the tummies full, and I would say I have had right up to the cricopharynx, the fill is up. Now, I would request, on that note, particularly Dr. Mithilesh Kumar Mishra to just go through his presentation, highlight the importance of his topic, and enlighten us by the presentation. Thank you.
Thank you, sir. Respected chairpersons, seniors, and my dear friends. Greetings from Sir Gangaram Hospital, Delhi. Today we'll be discussing a very important topic. I think it is the most important for all of us. Whatever you do in OT, whatever you do in perio period, if patient is not pain-free, everything is ruined. Nobody will count you. Whatever you do, a patient should be pain-free at all level, at all costs. Okay. Now, the topic chosen by committee, Dr. Sahu, Dr. Indu, personalized cancer pain management. Pain management was always personalized. We do have some addition by genetic makeups, by ergonomics now. We will be seeing that why that phase has come that we want individualized pain management. In any patient, if a cancer patient, mostly from years to come, we are using opioid, morphine for cancer pain. So most of these genetic testing, individualized things are also coming for opioid first. Later, slowly, we will see for other mild opioids and NSAID and other recent drugs. To understand the pain, if a patient of cancer is coming, whether the pain is due to the primary disease, whether it is due to the metastasis, whether there is any nerve compression, whether it is a chemotherapy induced, whether it is a dermatitis, radiotherapy induced, or a concept of total pain, whether there is any psychosocial part involved in this pain, if we do not take care of all aspects of pain, we will not be able to treat that patient. For students, now they have come post lunch. Good evening. Okay, so
Why this personalized? I want to just start with the why we need this personalized pain care. We have found outside Western countries, they are doing so many of genetic mapping for pain. So what they have seen, a certain group of patients were not responding well to oxycodone. The same patient, when they were given some other opioid like fentanyl and all, they responded well. By genetic mapping, they found that because of the CYP2D6 gene, which was altered in particular set of patients, which is involved in conversion of oxycodone to morphine, that was defective. And so those patients were not responding to oxycodone. So whatever dose you give of that, that will not be of helpful. So if you change to fentanyl, that is where from where the concept has come, why we need personalized cancer. Since there is this topic, we will cover newer addition also in our. Okay, so we have advanced in almost all aspects of pain, starting from the definition which ISP has given in 2020. Pain is unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. We will not decide whether patient is telling lie, whether the score given by patient is wrong. I don't think in this patient this much pain is there. If patient is saying there is pain, you have to accept and try your level best to treat. These were some 6 keynotes given by the ISP, which are very important. And it's the one point which I have highlighted here, that pain and nociception are different phenomena. Pain cannot be inferred solely from the activity in sensory neurons. What we have learned in palliative care, the total pain concept. It is not only the sensory neuron which are involved. Now we are having a descriptive words for our pain scoring system. Normally we say measure your pain between 0 to 10 or 0 to 100. It is very difficult to understand if you consider from patient perspective. So now we are having what type of pain you say minimal, what type you say mild, what type you say intense. So these are the wordings which are added for us and patient to understand the measurement of pain. Without measurement, you cannot treat, you cannot monitor your treatment. In pathophysiology also, we are having now Nobel Prize who have researched the human sensory perceptions. We have searched some new transmitters, neurotransmitter, glucoreceptor antagonist, in which topiramate it will be in market very soon. We are having lycophenol, we are having cannabinoids. Now all the review literature, I don't know, this also need to be like last session medical legal part, Dr. Raghu, whether we can use legally cannabinoids in India or not. The way they have reached our market, the way they are reaching our OPD, hospital, and the formulations they are having, I think it is a magic drug. They are using it for everything. They say it can treat, and people are using off levels. But now we are having receptors. The studies are going on. Very soon it will be legally allowed to use cannabinoids. We are having some. Okay, thank you, sir. We are having some new drugs added to our sumatriptan nasal spray. It is very good for migraine. Zolmitriptan, it is more potent than zolmitriptan. Zolmitriptan was available beforehand also. Meloxicam for osteoarthritis. To avoid the risk of addiction, to avoid the risk of drug misuse, now we have come with oxycodone plus naloxone mixture, which is now final part of many drug authorities are doing this, and it will be easily available very soon. Indomethacin, it has gone out except for some types of headache. People were not using indomethacin. Now it has come with a nanoparticle. We are having hydrocodone bitartrate, fentanyl formulations, everything. If there is a nasal spray, there is lozenges, there is lollipop, there is transmucosal pads, IV preparation. So fentanyl is a lovely drug. It is coming in all the formulation. The only issue is cost. Ketorolac, tromethamine, intranasal, moderate to severe pain. Why we are searching for so many new drugs? Somehow we want the effect of morphine without side effects. Somehow we want that US will not be guiding us for everything, that you are creating morphine addicts and sending to US. We want the same effect in such a formulation that we can treat pain not at the cost of addiction. Again, this is a 20 times more potent paracetamol, which is in market, naproxen. It is less hepatotoxic. All are worried about the ulcer and acidity because of diclofenac. We are having a preparation which is causing less GI disturbances. All these are individualized. We see what this patient need, whether he can accept orally, well and good. The way of treating pain is oral morphine tablet. If patient is having severe vomiting, nausea, for any reason cannot take orally, some oral surgery, not able to dilute, pass the step, you are having these formulations. Capsaicin, as I told, maybe very soon. This is also recently we have seen an article. They have done a very large study and showing it use. Cannabinoids, we have discussed already. These are the formulations which are easily available everywhere. People are writing. Maybe we need some verification and confirmation from our respected court before we start using it, but we can write. These are the novel routes of administration. We already know that now patches are easily available in all setup. Before 10, 20 years back, when we were searching for patches in government setup, or there were even in Delhi, there were few shops available. RML chale jao, CP mein chale jao. Now all those things have gone. These things are available in all the market, and they are advertising it also like anything. So it is helpful for us. Patient will not feel that doctor साहब का पर्चा तो सिर्फ इसी दुकान में मिलता है. So you can use this newer available drugs. Buprenorphine patch 5 milligram and 10 mcg. It is easily available and it is very helpful. It is if you are using fentanyl, that is costly also, and in 24 hours, 48 hours you have to change. This is effective for 7 days. Multimodal analgesia, as I discussed at the beginning, the same patient may be having pain because of so many reasons. So unless until you add some other drugs, morphine with some antidepressant, some pregabalin, some duloxetine, some paracetamol, it will not cover all. Already know that there are procedure-specific, case-specific, surgical site-specific pain procedures which are available. Nowadays, we avoid systemic painkillers as much as possible. For almost all the onco anesthetists sitting here, ultrasound is available in all the OTs, and we are trying our level best to do regional blocks as much as possible. We are at Gangaram, we are doing one every year we conduct one IDRA course under ICA, and we are teaching almost all students to use these blocks in almost all cases. And surprisingly, when we now, after just 3-4 years, we have done it. When we go to peripheries, we see that these people have started learning, and those where ultrasound is not available, they are taking on loan and then also performing. So we have to just start. People will take up the things. This is a new addition. Most of you would be knowing. We are afraid of ultrasound. Most of the people are saying that you are not trained in ultrasound and you cannot give written thing that you have done this. Maybe when we are assessing now gastric content, we are assessing the hydration, IVC status, photo. Even if you are not trained, this AI inbuilt ultrasound, it is available. We are next, we are going to have this. So it will tell you everything. It will tell you the structure. It will tell you the way your needle will enter. It will guide you to the trajectory. It will show both AP and longitudinal view in the same screen at the same time. These are some newer muscle relaxant, epirizone, baclofen, dendrol. The baclofen we are using from lab, but it has seen a resurgence in recent. These are some neuronal potassium channel opener, very helpful in fibromyalgia. Till date, we don't have a proper drug for fibromyalgia. This is maybe a new addition. Zinc oxide and magnesium oxide nanodrugs particles. These are FDA approved. Not easily available, but maybe in a year or two, it will be available and approved by FDA. So just the marketing part is lacking. Okay, so when you go to literature for this precision medicine in everything. Now it is a new term added, cardiology, endocrine, chest medicine. Similarly, in pain, we don't say now that it is a, like when we were doing our fellowship that in government setup, if a patient is coming from head to toe pain, the time he or she finishes complaint, our prescription was ready. Diclofenac, Pantop, Rantac, and just give it. Most of the studies, they are making groups, they doing genetic map up and say, trying to assess that whether this drug will be helpful for this patient or not. If this screening will start very soon, if we can see that whether this patient is a good responder to our pain tablet or not, good responder to fentanyl or morphine, I think it will be of great help. These are the two genes which are identified and that oxycodone and conversion CYP2D6 group. Cancer related pain, this I'm sharing this article. I will share this so that all students should go and read. It is very good, and they have covered almost these are review articles. So they have covered more than 500 studies, and they come up with some guidelines, some idea how to individualize pain. We are having a robot also available for regional blocks. That is Magellan robotic nerve block systems. I don't know. I have asked it in national conference also. Some people, maybe Rajesh sir, some people are using in Bangalore this robotic system for nerve block. A national conference, somebody has told that in South they are doing. I don't know. Neuromodulation, we are doing it for a long time, but now the indications has improved. And for CRPS, chronic regional pain syndrome, this is very helpful. Dorsal root ganglion stimulation, peripheral nerve stimulation. Before we were doing only central nervous system stimulation. Now peripheral nerve stimulation for particular. Suppose somebody's brachial plexus is gone, and now it's more than 2-3 years. They are having different sensation, phantom pain, phantom breast pain. So all the situation, this peripheral nerve stimulation are very helpful. They reduce. Means they have checked with acupuncture, they have checked with placebo, they have checked with this physiotherapy. It has shown promising results. In case you cannot treat the pain of SI joint by or any intervention, now we are having this SI joint fusion technique available, percutaneous procedure. We were discussing in the morning that palliative surgery, even if you can't treat the thing, you do palliative surgery. Similarly, in cancer patient, now people are offering more and more intervention to reduce the doses of morphine. And even if the patient's survival is not that much, we can do this procedure. They are daycare procedure. They are done under local anesthesia. We can, if suppose somebody is having pain of a fracture of vertebra because of metastasis, something, by doing some plasty, we can immobilize that joint and reduce the pain. Regenerative therapy do not have much role in cancer pain, but yes, otherwise, recently we have seen that some study has come that PRP is not that promising, but those who are using for 10, 15 years, we say that yes, maybe we need some more study. Genetics and pain, this is the next thing in next 1 or 2 years, maybe we will be discussing guideline for screening of genetics in pain management. Thank you so much. Sir, any addition? Actually, it's a long slide. I don't have much time. Sir. No, AI part I missed, but it will take more time. Any addition, ma'am? Any questions?
Thank you so much, sir, for your insight into this important topic, the personalized medicine, especially for this cancer pain management. Now, thank you, sir. Thank you so much, sir. Now we move on to our next talk, which is integration of onco-anesthesia and palliative medicine, enhancing cancer care till last breath. And our speaker is none other than Dr. Raghu S. Hota. Sir is a professor in the Department of Palliative Medicine, Tata Memorial Hospital, TMC, HVNI. He has got lots of major achievements, like he's the corresponding author of first Indian Cancer Pain Management Guidelines. He is associate editor of Indian Journal of Palliative Medicine, GOAPM. He is in the editorial board of Pain Medicine Journal. He is the founder secretary, Society of Onco-Anesthesia and Perioperative Care. And he is also examiner for MD Palliative Care, MD Anesthesia and DM Onco-Anesthesia. So welcome, sir.
Good afternoon, everyone. So I will be talking about an integration of onco-anesthesia and palliative medicine. So I really wonder, it should be integration of oncology and palliative medicine or onco-anesthesia and palliative medicine. So it much better it would be integration of oncology and palliative medicine and enhancing cancer care till last breath. So which includes the end of life care and all. But since I have been given this onco-anesthesia, I will be talking about this integration. So this is what I look at the integration, how it looks like. So though I am an onco-anesthesiologist, my background is onco-anesthesia and anesthesia, but I switched over to palliative medicine. So who better than me to integrate this specialty with onco-anesthesia? All right. So why actually do we need an integration into onco-anesthesia? Do anyone have any idea? Pardon? So, all right. So, basically, with palliative medicine, it is actually holistic care. We call it as a patient-centered care or a family-centered care. So, it includes every aspects into it. And onco-anesthesia is a component of an anesthesia which has certain components of this care which are included, right? So, even in onco-anesthesia, we have a holistic care, right? And if you look at onco-anesthesia, it is not simply giving anesthesia to a patient who is having cancer. That patient may have some issues with cardiac, some issues with neuro, some issues with kidney. Okay, she may be a antenatal patient. So everything, so all aspects of anesthesia are included into onco-anesthesia. So it is a holistic thing which we look at into. Then there is a lot of concepts which are coming newly into onco-anesthesia. That is all right. So that is the rehabilitation. Then we have what is called as now post-op rehabilitation. So all these things are coming. So we are just not looking into giving anesthesia only into the OT, right? We are going out of the operation theater and looking the patient pre as well as post. So that itself is a holistic care. So I think we can make a better way of integrating onco-anesthesiologist to a better palliative physician. That is what I think. So why there is a need for an integration? So if you look at this, there is a cancer now is a leading cause of mortality worldwide. And if you look, it has even, though it has not surpassed cardiovascular things, but still it is the leading cause, second leading cause of death in the entire world. And if you look in India, there are many centers which are coming up with a specialized oncology block, right? So the trend towards the ortho or towards a cardiac, I switched over to now oncology. So this itself states that we are in need of this particular specialty. Then it is a multidisciplinary approach, and what we are looking at improving the quality of life of these patients. So if you ask me, as a palliative medicine specialist, we really don't look into the disease aspects. So most of the things, when I initially switched over to palliative medicine, I used to think are a symptom management we will do and we will talk about the disease and all, which I think was a wrong concept and a wrong notion, because it is what exactly palliative care involves is that making the experience of the patient from the day one of his diagnosis till the last day a most dignified way. So that is what we should look into, because we are not the disease specialists. We really don't know anything about the disease, and we are not there to talk about the disease. So that is what I usually feel, and I usually advocate this to my students, that rather than talking about the disease, we should talk about the experiences. Yes, definitely, palliative medicine involves a lot of science. It is not just hand holding, right? Because we really need to treat the distress, and the distress is basically in the form of physical symptoms, that is constipation, breathlessness, pain, nausea, vomiting. Many things are there in that. So we really need to take care. So ultimately, the main goal is that to improve the quality of whatever life the patient is having, as well as to give a good journey or a dignity to the caregivers, we call it as. Okay. So that is what very, very important. So onco-anesthesiology, I already said, it is a specialized field. Okay, it's a perioperative management. So it is not only intraoperative management, which was there a decade back. Not onco-anesthesiology a decade back looks only into the operation theater, nothing more than that. And what we are looking nowadays in onco-anesthesiology is the outcomes, right? So for the past decade, there is a lot of research in onco-anesthesia about the impact of anesthesia and the metastasis or the disease outcomes. So we are looking into that. That's a new aspect or the new window in onco-anesthesiology. And I think even Sohan is doing one study on that to look about the technique of anesthesia and its impact on the disease outcomes, right? And palliative medicine, right? I said it supports the patients and the caregivers and improves the quality of life. So where we should look at the key areas of integration. So these are the 4 key areas where we can really look into the integration. That is the perioperative care, though we may not be a major role player during that period of, because whenever we go and we talk, the patient is always in a different genre, because he's always thinking about the cure, because he's thinking he just got operated. He will never ever think of that, the other anticipatory things which can happen to him. So, but still in the perioperative care, certain components are there. Okay, so especially pre-surgery, I feel that there should be something called as an early integration of the palliative physician, just to develop a rapport. And I always tell to my palliative care colleagues that when you are developing a rapport, no need to talk about all the aspects of your palliative medicine, which includes the end of life care, because that really takes back the patient away from you, and the trust is lost, because they think that whenever I go to Dr. Raghu, he always talks about all this nonsense that you are going to die and how you should die, what should be done, and all those things. You should never talk about those things, because the patient in that particular period of perioperative care is in a different level, because he's thinking of cure. Second is pain management. So this is another area of integration where we can come into. It is not that anesthesiologists can't do a good pain management. Okay, I'm not questioning their abilities here, but there should be an integration over here, because the transitioning happens. So the transitioning happens from the hospital to a home setup, and there I think the palliative physician is the right person to take care of that patient when they are having pain aspects, especially the chronic pain thing. They can take care. Then end of life care. Yes, I think we had a previous panel, and in the ICU. Okay, most of the patients, if you ask, we talk a lot that I want to die. Means patients wish to die at home. They should die at home. That is the best. I don't think anyone wishes to die at home. Even if you ask me, I being a palliative physician, I don't want to die at home. I want to die in a hospital setup. No, I will not call it as an hospital setup, rather a hospice setup. That would be more preferable because I don't want to stress my relatives and my family members and caregivers surrounding me, and I am just gasping in front of them. Okay, so these are not my words. These are the words even from the Western faculties who frequently visit to Tata Memorial Hospital, and they also say that the Western world always prefers not to die at home. And we have that wrong notion that dying at home is a good thing, is a dignified death. It is not so. Then symptom control. So symptom control, not only pain, there are many other symptoms. If you see, we have an Edmonton symptom assessment scale, and we have some 9 symptoms into that. Other than pain, there is tiredness, there is loss of appetite, then there is nausea, there is loss of sleep, anxiety, depression, constipation. All these things are there. We look into that and we try to give a good symptom control to this group of patients. So, after looking into the key areas of integration, we will look at, are there any striking similarities between onco-anesthesia and palliative medicine? So there are 7 aspects into onco-anesthesia. There are 10 aspects into palliative medicine. And if you see, these are certain striking similarities in these 2 specialties. So these similarities we can integrate and we can work in a coordinated fashion, ultimately to give a better quality of life to our group of patients. That is the post-operative care, critical care, pain management. Emergency care, you might be wondering what is the role of a palliative physician in emergency care. If you ask me, in Tata Memorial Hospital, almost 50% of the patients in emergency department are seen by the palliative physician there. Because most of the patients are not on any cancer-directed treatment, so they are directly fall under palliative medicine care. And so the most commonest thing they come with are acute pain crisis, they come with breathlessness, then they will come with severe abdominal distension, okay, and electrolyte imbalance. And being an anesthesiologist, I have the privilege of managing these patients very well with respect to that. Okay. So the benefit, again, the same thing which I've been repeatedly talking: enhanced patient outcomes, improved quality of life, better symptom management, and comprehensive care from diagnosis to end of life care. But there are certain challenges. And the most important thing is that now you go to sleep and tomorrow morning you will wake up and you will say, I want to be a palliative physician, which is utterly disappointing to say that. It is not so easy, okay, to just convert yourself into a palliative physician. Okay, even I used to think so, but after working in that specialty, I thought it is not so. Okay, anesthesiologist, just because they manage pain doesn't become a palliative physician. Please, I'm not trying to, I can say, means lower the specialty of anesthesia. Even I am an anesthesiologist, I respect anesthesia a lot. But I would like to highlight the point that it is not that easy. You really need a specialized training to become a good palliative physician. I have underwent a specialized training and I'm still doing a training. I am doing my MSc in palliative medicine. So it is not that easy to become a palliative physician overnight. Okay. You need a lot of coordination between multiple specialities. For example, if the patient is from has come from the medical oncology, has been referred to us, okay, not only we will talk about the experience and the journey and the way ahead about the anticipation and the challenges which they may have when they go back home and how to treat them. We really need to coordinate whether they had seen the radiation oncologist and what is the final call from the radiation oncologist, or what is the final call from them, or if it is a head and neck cancer, the speech and swallow therapy, we really need to coordinate so that they can have a better nutrition, they can swallow it better, and all these things we really need to coordinate. And again, education, because we really need to change perceptions about palliative care. And this is a real big challenge in not only in India, everywhere, all over the world. It is a huge challenge for us. So what are the future directions? What I think is that it should be included in the curriculum. It should also be a part of a super specialty program. For example, our medical oncologists should have that. And in Tata Memorial Hospital, they come for 1 month rotation to palliative medicine, and a lot of research is needed to that. So why do we still need an anesthesiologist should become a palliative care physician? If he's a trained anesthesiologist decides to become a palliative, care physician still needs education. And there is a lot of gap because we really need a good physicians who can take care of these patients, not only at the tier 1 cities, even in tier 2 cities, tier 3 cities, as well as the village levels, because we really don't have people. So it is not that if you're an anesthesiologist, you can't become a palliative care physician, but you really need an education for that. Okay, palliative medicine, it is now is an independent specialty, mind it, because we have MD programs. 10 centers in all over India are giving MD programs. Tata Memorial Hospital is one of the centers which provides MD palliative medicine, and there are almost more than 10 centers all over India which provide DNB program in palliative medicine. Okay, so just not that you can do some 1 month or a 3-week program and can become a palliative physician. Since it is a recognized specialty, the law is there. The law will directly ask you when there is an MD palliative medicine specialty, who are you to practice palliative medicine if something goes wrong. If something goes wrong, otherwise the law never asks. Okay, I'm not going into that. So in conclusion, an integrated approach is essential. Ultimately, we should look about enhancing quality of life and continuous improvement and adaptation of care strategies. Thank you very much. I am open to take questions, and moderators, if there is anything from your end. Thank you. Tell you. Yes. Palliative medicine, yes. Yes, I never said that is not the best person. Yes. Yeah. Yeah. Yes, anesthesiologist is the closest person who can practice palliative medicine, provided he takes a. No. There are other persons also. There are other persons also, but he is closest who can switch over to palliative medicine. But he needs a training. All right, he just can't switch over like that. That is what I wanted to highlight. Yeah. 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 So my transition didn't happen. On 9th August, I was in anesthesia last day. 10th August, I was in palliative medicine directly. So there was no transition. It's a direct switch. Thank you. Thank you, everyone.
Thank you, respected chairperson and speakers. The session has been an incredible learning experience. Now moving to the forward to the last session of the day, I would like to invite the chairpersons onto the stage. We are honored to have them here. We welcome Dr. Shagun Shah Ma'am, Senior Consultant Anesthesiologist, Rajiv Gandhi Cancer Institute and Research Center, Delhi. We welcome Dr. Tanmay Tiwari Sir, Additional Professor, Department of Anesthesiology and Critical Care, King George Medical University, Lucknow. We welcome Dr. Ravi Prakash Sir, Associate Professor, Department of Anesthesiology and Critical Care, King George Medical University, Lucknow. Now, I request the chairperson to introduce our next speaker.
Dr. Neha. आपने मुझे भेजा है ना नंबर बताइए तो 974
Thank
Thank you, ma'am, for your kind introduction. And thank you to the team Lucknow for having us here and giving us this opportunity to talk to you all. So I have a very vast topic to cover in 20 minutes. Obviously, I don't think I'll be able to do complete justice to it, but I'll try to do my best. So I'll be talking on thoracic cancer surgery and perioperative management. So I'll briefly just share about what are the preoperative concerns, some intraoperative points that we need to take care of, and on postoperative management. So what are the indications? What are the common scenarios we see thoracic surgery for? The perioperative concerns and their assessment, intraoperative management, and postoperative management. So indications, common indications include lung surgery that can be starting from a small wedge resection to segmental resection to lobectomy, pneumonectomy, or lung volume reduction surgery, esophageal surgery, mediastinal masses, there can be thymectomy, other mediastinal masses, chest wall surgeries where you have sarcomas or other chest wall tumors which have invaded, and that can include multiple level of rib resection, pleural surgeries, and others like tracheal surgery, retrosternal thyroid extensions, and other procedures. So if you look at the Globocat data, lung and esophageal surgery remain one of the two of the commonest cancers in India as of 2022. So we are likely to see more and more of these patients in our onco-anesthesia setup. So what are the preoperative concerns? One is to identify these risk of these patients and take measures to reduce the risk perioperatively. Because the anesthesia in thoracic surgery, the anesthesia field and the surgical field correlate closely. So we can actually play an active role in improving patient outcomes post-operatively. Other general preoperative assessment, the patient's age, existing comorbidities, any addictions which need to be taken care of, their concurrent medications and airway assessment. I will not go into details of these. The effect of the cancer, both anatomical and physiological effects of the cancer on the patients, and effect of neoadjuvant therapy. So these are the areas which should be looked into when you go for preoperative assessment. So for thoracic anesthesia, our current international guidelines, there is from American College of Chest Physicians, British Thoracic Society, and there are the European guidelines. So most of the preoperative assessment is derived from these guidelines. Now coming straight to the respiratory assessment. I will not go into the other systemic assessment and laboratory investigations. So the respiratory assessment is basically what is called the three-legged stool, where we see a combination of respiratory mechanical function, the lung parenchymal function, and cardiopulmonary interaction. So these three assessments give us an idea of the patient's risk status and what are the chances of any perioperative complications. So respiratory mechanical function, spirometry is the commonest test which is done, where FEV1 remains the most important single indicator for postoperative complications. So PPO FEV1, which is the postoperative predicted function, which is I should talk about that later. So which, if it is more than 30 to 40%, or rather if I say if it is less than 40%, puts a patient more at risk for postoperative complications. Other parameters which can be seen are the minute volume ventilation, the FVC, and the RVTLC ratio. For lung parenchymal function, again, the single most important indicator remains the DLCO. If the DLCO is more than 30 to 40%, then these patients are at reduced risk of postoperative complications. If DLCO is not available, an ABG can be done. So ABG, a PaO2 of less than 60 or a PaCO2 of more than 45 millimeters of mercury, again shows the patient may be at increased risk for post-op complications. And finally, for cardiopulmonary interaction, to see the patient's overall cardiopulmonary status, the gold standard remains the cardiopulmonary exercise testing, where we measure the VO2 max. And if it is more than 15 ml per kg per minute, it is said to be of lower risk. CPET is not easily available. In fact, it's not even there at our centers. It's there at very few centers. So we use surrogate tests to check these cardiopulmonary interaction. The commonest test used is the 6-minute walk test. So the distance covered during the 6-minute walk test remains debatable. It varies in literature from 350 to 500 meters. But a drop in saturation of more than 4% during the 6-minute walk test is said to be a reliable predictor of postoperative complications. So what is the predicted postoperative function? The PPO FEV1 or the DLCO is derived from the preoperative FEV1 or DLCO and by subtracting the number of segments to be removed during the lung surgery. So what are the other tests that can be done for regional lung function? If required, we can do a VQ scan, a quantitative CT scan, or a three-dimensional dynamic perfusion MRI. These again can be matched with the FEV1 to give an idea about the risk of postoperative complications. For CPET, like I said, 6-minute walk test. There are 2 other tests which can be done. One is the stair climbing test, which is defined as the 20 steps per flight, in where each step is around 6 inches in height. If there is inability to climb less than 2 flights of stairs, then it corresponds approximately to a VO2 max of less than 12. Similarly, for the shuttle walk test, where the patient is asked to walk between 2 points placed 10 meters apart, and the speed of walking is gradually increased. If they are able to walk less than 250 meters, it indicates a VO2 max of less than 10 millimeters per kg per minute. So these are surrogate tests for CPET, which give you an idea about the cardiopulmonary interaction and which to stratify patients according for their risk. Now coming to the cardiovascular risk. Patients with lung and esophageal cancer tend to have more risk of cardiovascular disease because these are patients who definitely are on the older age. They have more likely to have history of smoking and its related complications. They are likely to have atherosclerosis and other cardiovascular disease. They have increased chances of MACE. So how do we stratify these patients? So there is something known as the thoracic revised cardiac score, which is the thoracic revised cardiac risk index, which includes ischemic heart disease, history of cerebrovascular disease, serum creat level of more than 2, and if the patient is undergoing pneumonectomy. So each of these carries a points and patients are stratified according to the total score. How would you assess these patients? You can start with assessing their MET score. If the METs is more than 2, then you go for spirometry, both FEV1 and DLCO. Then if it is more than 60, these patients are of low risk, then you can proceed with the surgery. If it is between 60 to 30%, then you can go for exercise testing. It can be the 6-minute, mostly 6-minute walk test. If it is more than 400, you can proceed with the surgery. If it is less than 400, you go for further testing like cardiopulmonary exercise testing. And then based on the VO2 max, you decide whether you take them for an increased risk for surgery or you consider other alternative procedures. If the METs is less than 2, then you defer for medical consultation and optimization and again do a CPET and consider, they are considered high risk and you consider alternative therapies. So this is about the preoperative assessment from the respiratory point of view. Other optimization like nutrition, anemia, smoking and alcohol cessation, education and counseling of the patient, something we've been talking about since morning in various talks, treatment of COPD and optimization of other comorbidities. Physiotherapy plays a very important role, chest physiotherapy. These patients in our hospital, they are referred to the physiotherapists at the first or the second visit itself. So even before beginning the chemo and radiation, they go to the physiotherapist, they start their spirometry and they start their breathing exercises. Rehabilitation in whatever terms is required, whether it is nutrition, exercise rehabilitation, everything. These are all part of the preoperative optimization setup. Then another thing that we need to be aware of is the effect of the cancer and its treatments. Cancer can have mass effects, so patients can have obstructive pneumonia, they can have lung abscess. If there's a anterior mediastinal mass, they can have SVC syndrome or tracheobronchial distortion, nerve palsies, and chest swallow mediastinal extensions. Then secreting tumors can have metabolic effects, so we have to be aware of the electrolyte imbalances that can be caused because of these. Any distant metastasis that may be present, and effect of medications. So chemotherapeutic drugs, which can have both pulmonary or cardiac toxicity and renal toxicity. So our knowledge, when the patients come to us for a preoperative checkup, a history of what drugs have been given, what doses have been given, we should be aware of the maximal dosages of these drugs, and an evaluation accordingly should be done. Now coming to intraoperative management, what are the main points which it is like any other intraoperative management: monitoring, positioning, choice of anesthesia and mode of analgesia, fluid management, role of ERAS in thoracic surgery. I will not be touching much about specific procedures for lack of time, and what are the potential complications. Monitoring a standard ASA monitors. Advanced monitors, most patients we nowadays put arterial lines. Central lines are only if medically indicated for surgery, lung and esophageal surgery per se. We do not routinely put central lines for most patients. And another important part of monitor is the flexible bronchoscopy, because most of these patients will require one lung ventilation. So a bronchoscope is a must. Positions, they can be lateral, most posterior lateral thoracotomies are done in the lateral position, and lung surgeries. Some of these stenotomies, anterior mediastinal mass or chest wall tumors may be done in the supine position. And for esophageal, whether it's minimally invasive or robotic surgery, they will be in prone position. So a quick head-to-toe survey after the position, where you check the monitors, you check access to your lines, check your circuits and the access to the circuit if required. You check for all the dependent and non-dependent prominent parts, the ears, the eyes, the position of the spine. Then you look for the dependent and non-dependent arm to prevent any nerve injury, pressure injuries, to maintain the circulation, and position of both the dependent and the non-dependent leg. This is a head-to-toe survey we do after positioning each patient to make sure that nothing is missed out. So what are the goals of anesthetic care? Hemodynamic stability, obviously, lung isolation, satisfactory one lung ventilation, and minimal duration of one lung ventilation, avoidance of lung injury, both via means of ventilation and by fluid balance, control of any bronchospasm and secretions during the surgery, to provide for rapid, smooth emergence and extubation, and good analgesia. So the anesthetic technique should focus on short-acting agents that permit early extubation unless there is any surgical contraindication to extubation, which is usually best accomplished with a combination of regional and general anesthesia. Inhaled versus TIVA, we've heard a lot about it today from terms of cancer recurrence. There's also a debate about the effect of inhaled anesthesia and TIVA on postoperative pulmonary complications. So we know during one lung ventilation, there is hypoxic pulmonary vasoconstriction. So volatile agents have been shown to be weak inhibitors of this HPV. There's no clinically relevant difference in oxygenation compared to TIVA. And SIVO and desflurane have been shown to reduce local inflammation during one lung ventilation compared to TIVA, and reduce postoperative mortality and respiratory complications. Sorry, the slide is repeated. Yeah. So we generally go ahead with 2 large bore IV access. We avoid sedative pre-medication. Anti-sialogogues are generally avoided unless there are too much secretions which preclude doing a safe bronchoscopy. Thoracic epidural remains the method of choice for analgesia. Now, with minimally invasive surgery, facial plane blocks are also coming up, and antibiotic prophylaxis, PONV, VT prophylaxis as part of a routine anesthetic practice. Fluid management, ideal strategy remains elusive. Restrictive, if there's too much restriction, it can cause hypoperfusion. If there's too much fluid overload, then it can cause pulmonary complication. So we have to balance the risk of acute lung injury versus acute kidney injury with the fluid management. So what are the general principles for fluid management in thoracic surgery? For first 24 hours, the total positive balance should not exceed 20 ml per kg per kg body weight. Crystalloid administration should be limited to less than 2 liters intraoperatively and less than 3 liters in the first 24 hours. This is specifically for pneumonectomy patients. Colloids should be used to replace equivalent volume of blood loss if blood is not required, provided the hemoglobin is more than 8 and the patient's medical condition otherwise allows to keep a hemoglobin of 8. There's generally no third space loss in thoracic surgery, so that extra replacement is not required. Urine output of more than 0.5 ml per kg is more than that is generally unnecessary. So up to 0.5 is acceptable. And appropriate invasive hemodynamic monitoring should be initiated to guide treatment with vasopressors, inotropes, or fluid administration as indicated. Now coming to goal-directed fluid therapy, which has become the standard for all major surgeries, at least in high-risk patients. So there is a question of the utility of goal-directed fluid therapy, whether because of the open chest physiology and its effect on the parameters, patient in lateral position, patient with one lung ventilation, and the usage of low tidal volume. So how these affect the stroke volume and the pulse volume variation. So most current evidence for GDT is not conclusive for thoracic surgery. So they say you can restrict its use for high-risk patients where it will actually make a difference. You can use cardiac output or cardiac index as a monitor and use it to guide your fluid management. Analgesia, thoracic epidural is still the preferred method in most centers with other adjuncts like acetaminophen, NSAIDs if they are not contraindicated otherwise. Dexamethasone has a multi-purpose role, so it's used routinely in almost all cases. Ketamine infusion is an option if patient has chronic pain or is on long-term opiates. Facial plane works. I will not go into details of this, but these are the options available depending on the site of surgery. Paravertebral block, PEX 1 and 2 block if there is anterior chest wall surgery, the serratus anterior plane block, and right now the most popular, the erector spinae block. I will skip this. So now coming to methods of lung isolation. So there are two options for lung isolation. One is the double lumen tube or bronchial blockers. Each has its own advantages and disadvantages. Double lumen tubes give excellent quick isolation of the lungs. Both deflation and inflation and switching between one lung to two lung ventilation is faster and easier with double lumen tubes. They allow easy suctioning of the non-dependent lung on the operative side. But they are comparatively more difficult to place, require more training, and there's a chance of a tracheal cuff tear or tracheobronchial injury because of the large size of the tube. On the other hand, bronchial blockers, they are easy to place, can be placed through the single lumen tube, can be used in patients with difficult airway once you've secured a single lumen tube. But relative to double lumen tubes, they give slower deflation. The dislodgement of the cuff because of surgical manipulation during change in position is more compared to double lumen tubes. A bronchoscope is essential for placing bronchial blockers. We can place double lumen tubes without a bronchoscope by just methods of auscultation and monitoring the airway pressures, but a blocker cannot be placed without a bronchoscope. So a flexible bronchoscope remains essential for placement of a bronchial blocker. Suctioning is difficult because of the very narrow channel. And switching from one lung to two lung ventilation is also not easy because every time you have to inflate the cuff, it is ideal to do it under bronchoscopy. So it's not as easy as a double lumen tube. But there are some definite indications for the DLT, like if the patient is going a pneumonectomy or for right upper lobes, right side surgery, especially if they're involving the right upper lobe because of the difference in anatomy of the right upper lobe, left-sided DLT remains the tube of device of choice. So double lumen tubes come they are left-sided and right-sided DLTs. The shape, they have two tubes which are coaxially attached with two curvatures, and the right cuff, if you can see, the right cuff is different from the left cuff. That if you can see the image on the right, that it is a donut-shaped cuff with an extra Murphy's eye to place it against the opening of the right upper lobe, while the left-sided cuff is a typical round cuff. And the size of the tube is typically chosen according to the height of the patient, and the depth of insertion is based on the patient's, a rough estimate can be made based on the patient's height, following which you can confirm its placement with a bronchoscope. So this is a typical appearance of a left DLT. So once the tube is placed and we have a pointer. Once the tube is placed and it is in the left main bronchus, you can see the first bronchoscope going, the figure A, the bronchoscope going through the tracheal lumen, where you will see that and you can see just the top of the blue cuff at the carina. So it shows that the tube is correctly placed. And after passing that, you can go into the right bronchus, and you can see the opening of the right upper lobe, where you can see the right upper lobe dividing into three, what is known as the Mercedes-Benz sign. Following which, the bronchoscope goes into the bronchial lumen, and you can see the opening of the left mainstem bronchus, the division of the left mainstem bronchus. This is a right double lumen tube. You can see this is the Murphy's eye, which is to be approximated in front of the opening of the right upper lobe. And when you see from the bronchial lumen, you can identify the posterior part of the trachea through the trachealis muscle. So it is in the right side, and the top of the cuff just at the carina, and the Murphy's eye in front of the right upper lobe. Bronchial blockers, the different types of bronchial blockers. There's the one which is attached to the single lumen tube, which is known as the univent tube. And then independent bronchial blockers, which are inserted through our regular single lumen tubes. Wire guided is the ANT blocker, where there's a loop at the end. I will show an image later. which is guided along with the bronchoscope. Torque control, the Fuji bronchial blocker, the Cohen bronchial blocker, and the Cook deck, and the easy blocker. So here you can see the easy blocker, the uni blocker, and these are torque control. So they have a fixed tip which is bent. So rotation of the give you access to right or the left side. The ANT blocker has a loop in the end which is looped onto the bronchoscope and it is guided into the bronchus along with the bronchoscope. And the easy blocker, like the name suggests, has two cups which go and sit on the carina, one on either side. So based on the bronchoscopic vision, you can decide which side is to be isolated. All bronchoscopes come with a three-way attachment, one for the passing the blocker, all blockers, one for passing the bronchial blocker, one for the bronchoscope, and one for the ventilator circuit. This is the Univent tube, where you can see the blocker is attached to the tube and with under bronchoscopic vision. Again, this is a preformed tip which can be rotated to either side, and under bronchoscopic vision is advanced into the desired blocker. Now, coming to principles of one lung ventilation. It is basically a non-physiological ventilation, so its duration should be the minimum possible. These are general principles after isolating the lung. Recruitment maneuvers should be applied to the ventilated lung to prevent pressure atelectasis at the beginning of one lung ventilation so that there's no rapid collapse of the distant alveoli. FiO2 should be minimized to maintain oxygen saturation above 96% during one lung ventilation. Low tidal volume, it's usually 5 to 6 ml per kg of idle body weight is what is recommended to prevent any volume trauma to the ventilated lung. And the respiration can be managed with adjustment of the respiratory rate. PEEP to the ventilating lung should be titrated to maintain the least driving pressure, which is derived by the difference between the plateau pressure and the PEEP. And mild hypercapnia, that is a PaCO2 of 55 to 60, is acceptable if it is cannot be adjusted with adjustment of the respiratory rate. CPAP can be applied to the non-ventilated lung either through just like a passive insufflation through a catheter, or if there's a CPAP machine which gives a pressure of about 5 centimeters of water in case of persistent hypoxia. So who are the patients who are more at risk of desaturation during one lung ventilation? If there's higher percentage of ventilation or perfusion to the operative lung on a preoperative VQ scan, if the PaO2 before putting the patient on one lung ventilation, if you do an ABG while they are on two lung, and if you do ABG, if the PaO2 is low during two lung ventilation, then these patients are more likely to become hypoxic easily during the one lung ventilation. Patients with right-sided surgery, because the right lung is bigger than the left lung, so you have smaller lung volume to ventilate the patient, so these patients are more prone to hypoxia. If there's normal preoperative spirometry, because these patients are dependent on both lungs. Many times patients with lung cancers, where the mass is huge, so they are functionally dependent on the normal lung. So when they go on one lung ventilation, they are still already dependent on the other lung for their respiratory function. And if the surgery is done in supine position, because the lung mechanics are not supportive during the supine position. So what are the common causes of hypoxia during one lung ventilation? The main reason for hypoxia is the ventilation perfusion mismatch, which happens when the non-ventilated lung continues to get the blood flow. As the hypoxic pulmonary vasoconstriction sets in and the shunt fraction is reduced, that hypoxia comes down into. If there's hypoventilation of the dependent lung, so it can be due to dislodgement of the tube or blocker. So you should do a bronchoscopy, check the position of the tube. During change in position, they can slide in during the change in position. So you should once again do a bronchoscopy after change in position and confirm they are in the correct position. If there's blockage of the DLT lumen of the bronchial or the bronchial blocker lumen because of secretions, they can be malposition. Any conditions which decrease the PVO2. So if there's decrease in cardiac output, so you should stabilize the patient. Hemodynamic stability is important. If there's increased oxygen consumption, good analgesia is important. Conditions which increase O2 consumption, so increase sympathetic activity, hypothermia, shivering. So temperature management is also important. Or finally, rarely if there's mechanical failure of O2 delivery system. So how do you manage this hypoxia? If the hypoxia is sudden, then we should immediately put the patient back on two-lung ventilation, increase the FiO2. A sudden desaturation is generally a mechanical cause, so you should check for the position of the tube or the blocker and confirm their position again, and then gradually put them back on one-lung ventilation. When the hypoxia is gradual, then the steps that you can take is, again, confirm the position of the device with a bronchoscope, ensure hemodynamic stability, make sure the blood pressure is not too low, apply a recruitment maneuver to the ventilated lung while keeping a watch on the blood pressure, increase the PEEP to the dependent lung, apply CPAP of by 1 to 2 centimeters to the operative lung. Like I said, it can be passive insufflation through a catheter, or if a different CPAP machine is available, that can be used to give with a continuous pressure. If the hypoxia continues to be too much and it is not controlled with these measures, and if the patient is undergoing lung surgery, then occlusion of the pulmonary artery to the diseased lung can be considered. If none of these works, then you consider switching to two-lung ventilation, and with the management of intermittent two-lung ventilation and intermittent apnea with constant communication with the surgeon, the surgery can be continued. So what are the common complications that you see during thoracotomy? Hypoxemia, sudden severe hypertension because of surgical compression of the heart or the great vessels during the surgery. This is more common on left thoracotomy. Sudden changes in ventilating pressure or volume because of surgical handling, there can be movement of your tube, or there can be, if there's injury to the airway, there can be air leak. Arrhythmias, again, more common on the left side because of direct stimulation, mechanical irritation of the heart. Any bronchospasm, massive hemorrhage obviously is common during any surgery, and hypothermia. And finally, a very little bit on post-operative care, because again, this is another topic in itself. What are the common concerns during post-operative care? Pain management is very important for the patient to be able to be mobilized and cough. If a patient, a post-operative patient with lungs post-thoracic surgery, if they don't cough and there's accumulation of secretions, they put them at a higher risk for other pulmonary complications. So good pain management using both IV or oral analgesics and regional anesthesia. Respiratory support as and when required, oxygen therapy, mechanical ventilation, good physiotherapy in the post-operative period, early mobilization to prevent complications, proper monitoring for complications where you look for bleeding, infection, respiratory distress, so you monitor their respiratory rate, you look for any signs of fever or any inability to cough, all of those, and follow-up care with oncologists and surgeons. So to conclude, thoracic cancer surgery, it's a complex procedure, requires careful planning and coordination. Anesthetic management plays a critical role in safe and successful outcomes. And post-operative care is essential for recovery and long-term health. Thank you. I cannot do justice to thoracic anesthesia in 20 minutes, but I have tried to do my best. We see their saturation on air during, before the surgery, how they are maintaining before the surgery. And we try to keep it and we monitor that with, in the ward, we get a reading. Yeah, so that's what I'm saying. So we get a reading, their room air saturation pre-operatively, both in the OPD and before we take them for surgery. And we start with, say, 30 to 35%. And we keep it close to their preoperative level. We don't target for a higher saturation during the one lung ventilation. We may accept up to 88 to 99% or 90% also in these patients. And sorry, ma'am? Yeah, that's what I'm coming to it. That, and we have a CPAP machine, so we give CPAP to the non-ventilated lung. But our target saturation for these patients won't be like other patients. We'll accept a slightly lower saturation, 90 to 92, and we'll manage with whatever minimum FiO2 we can give. We start with the minimum and try to keep it as low as possible. Yeah. Yeah. It generally goes up. It generally goes up, but we start with the minimum and gradually increase it.
Yeah,
No, we put a blocker. We don't have that many blockers. So I'll tell you, when we don't have, in our center, we don't have robotic esophagectomies frequently. They are on and off. We mostly have wax esophagectomies, like the regular wax esophagectomy. So we keep an easy blocker. Sometimes if it is difficult in the apex or something, and if the surgeon wants the thing. So we keep it in. We don't always start with one lung ventilation. Generally, the prone position and a little of pneumothorax that they give with about 6 pressure is generally sufficient. But we do keep a blocker in place in case they ask. Generally, they ask us to keep it in, and then if we require, we put it out. Yes. Yeah. Yeah. Yes. 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 So we keep the blocker just in case. Most of them are not. Yes. 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 DLT we stopped using a long time back, ma'am. We do single lumen with a blocker as a ready to in case, if required. So we don't have that many robotic. For esophagectomies, we don't use DLT at all in whether it's open or VATS or robotic. We use single lumen tubes with a blocker. For the open, obviously, we use one lung with a blocker. And for minimally invasive, when the patient is prone, if the surgeon asks if they are finding it difficult, they want proper one lung ventilation, only then we give one lung. No, we keep it in. We put it first. We don't put them on one lung. Yeah, we don't inflate it. Yes, yes. Yeah. I understand what you say, ma'am, but our surgeons are not ready for that yet. Huh. Yes, yes. So some of the surgeons are our contemporaries. They are like a friend. So we tell them, try to karo, ho jayega. So they try this too, but mostly when they reach the yes. Any okay. There is literature for TIVA versus this, but I personally don't have experience with that. So yes. Yeah.
So thank you to the chairperson. Question? We have questions or we have feedback? So thank you, chairperson, for this your precious time here. We will have facilitation, so please wait some time till the things are moving on. भाई देखो कैसा रहा आज का डे खत्म होने को आ गया. अब तो आप लोग जाग जाओ. चाय चाय मिलने वाली 15 मिनट में चाय रेडी हो रही है. तो अभी हम लोग कैसा रहा उस पर बात करें या वी हैव वन सेशन विद द तो पीछे से भाई खाना कैसा था रिगार्डिंग सीएमई पीछे वाले हाउ वाज द फूड. जो लोग ऑनलाइन है देखो उनको फूड नहीं मिला तो बेचारे वो जवाब दे नहीं सकते. बट व्हाट हाउ वाज द कंटेंट. कैसे आपको स्पीकर टॉपिक्स उनका कंटेंट एंड वेदर द स्पीकर्स वर एबल टू डिलीवर टू यू एंड दे मेट योर एक्सपेक्टेशन. कैसा लग रहा है आप लोगों को. नहीं बोलोगे नहीं तो फिर सर्टिफिकेट नहीं मिलेगा. यू हैव टू स्पीक. पीछे से इधर. हाँ क्या अच्छा था. अच्छा क्या था. हाँ तो आई विल इनवाइट सेक्रेटरी साहब आइए सोप्स नेशनल कि आप मेंबरशिप और इसका सोप का और क्या क्या आप फायदा उठा सकते हैं.
So, thank you very much, and it was a very hectic day, and we enjoyed all the scientific program today. So, I will request all of you to become the SOAPC member. So you have now your city branch, so you can become the member. Although you will enter your city name, but you will be the member to the national directly. So, but
when you put your name in the city branch, so you'll be member of the city branch as well as the member of the national SOAPC. Okay? So you'll be you will be invited for all the webinars, all the national conferences you can attend. You can present your paper. You can also publish your research into the journal of SOAPC and everything. So we invite all you, and this onco anesthesia is a growing branch. Okay, and now every hospital is going to have a oncology wing, and there are many dedicated external cancer hospitals also coming up in India and abroad everywhere. So onco anesthesia is going to stay for your life. You will need to give the specialized anesthesia to the many complex surgical procedures. So please become a member. It is very easy. Just go to soapc.org and it online. It will only take 5 minutes to it. You need not to send any documentation to the SOAPC Central. Totally online. 7,000 rupees is life membership. Okay. So online, just get to pay by your credit card or your net banking, whatever it can pay. Yeah. That is. Okay. So I think
अदर इज ट्रांसप्लांट क्योंकि लाइफ एक्सपेक्टेंसी बढ़ेगी तो ये दो चीज होंगी और
So last lecture.
So we have last lecture and yeah. Yeah. Spare मेरे मोबाइल पर व्हाट्सएप पे
No, forget it. नहीं खुल रहा है ये. So told you how to do just SOAPC and you click on the become member. Enter your names and evident degree. As long as you are MD anesthesia or DNB anesthesia, you can become member.
अगली कॉन्फ्रेंस
Okay.
next conference.
So the SOAPCon 25 is from 22nd to 24 August in Chennai. Okay. So we do annual conference every year in the month of the August only. So August, mostly the last week of August, we do national conference. So you can all come and you have to present your paper in the SOAPCon.
So it's at Mahabalipuram Beach, Chennai. Nice venue. So this is the website of SOAPCon. Yeah.
So this is the
Rudra pen drive de do please.
So you can go to this website soapc.org and become a member, and you can do member registration, and you can fill this online form. Okay, you will do. So like all this form, and you can do it. Payment is online. And we also have our JOPM journals. You can go to
pain, cancer pain, perioperative surgery, whatever you can send your topics here.
So this is the journal of the onco and anesthesiology and perioperative medicine. You can submit your original article, everything to this journal. And it's coming in a big way, so you can all publish your paper in this journal, as long as your topic is the related somewhere in the cancer. Don't send any obstetrics paper, something like that. But yeah, but you can present the and publish. Gynae onco is okay, not obstetrics. Okay, thank you very much. So,
So today's last discussion is on onco neurosurgery, and we have Dr. Udrashish Haldar for this talk, and he is working here as an additional professor in Department of Anesthesia, and he will discuss. Actually, पेन ड्राइव में दो, क्योंकि ये ऑनलाइन भी टेलीकास्ट कर रहे हैं ना हम लोग, आपका वाईफाई से जुड़ा नहीं होगा, यहाँ आराम से पानी पी पेन ड्राइव में पेन ड्राइव में कर दो या मेरे व्हाट्सएप पे कर दो किसी। So people have also question online, and they are happy. Good morning, and they are for the part of discussion. See, and they were happy what the discussion is going on. Reduce. इसी में चला दो, ये है ना, अरे ट्रांसमिट हो रहा है।
good evening, everybody. Sorry for the delay. Actually, I was in a different session. I had to rush. Anyway, thanks a lot for bearing with me. Let me begin by thanking the organizers for giving me this privilege. And the topic on which I'll be speaking today is balancing comfort and precision in brain tumor surgery and anesthesia for awake craniotomy. I'll begin with a few disclosures first. I don't have any conflict of interest. And secondly, there are some live videos. So we have taken appropriate consent and permission from the patient for displaying those live videos. Now, to begin with, craniotomy is one of the oldest surgical procedures which is known to mankind. Historical evidence states, or even the human skeletal remnants obtained from Peru, South American civilization, Chinese civilizations have shown that trephination or small craniotomy openings have been done as therapeutic procedures way back in prehistoric times as a measure to alleviate brain trauma as well as intractable seizures. Nowadays, we all are well conversant with the procedure of craniotomy, and majority of the time it's done under general anesthesia. However, the trend nowadays is towards going for awake craniotomy. Awake craniotomy requires a certain subset of patients, especially those patients who have tumors or growths in the eloquent areas of brain. So awake craniotomy actually allows you to delineate the border of the tumor in a much more precise manner, thereby retaining the motor functions. And in addition to that, there are certain other advantages of awake craniotomy. First is that it avoids the risk of general anesthesia. Then awake craniotomies allows longer opioid-free period in the postoperative period, especially in neurosurgical conditions where early emergence and neurological intactness is mandatory. Emergence hypertension is avoided. It translates into reduced total length of stay in the hospital. This ultimately translates into decreased nosocomial infections and decreased chances of thromboembolism. So we can see that many boxes are being ticked once we go for an awake craniotomy approach. Now, what are the goals of awake craniotomy? First, you need to sedate patients in a way that they are comfortable throughout the procedure. Maintenance of hemodynamic stability, which is imperative for any surgical, especially neurosurgical procedures. And last but not the least, maintenance of adequate analgesia and angiolysis. One thing is very important, especially during awake craniotomy, is that the patient selection has to be appropriate. We need to have patients who do not have chronic cough because the patients are awake and they are usually lying over pins. So any sort of coughing or bucking might cause injury, especially cervical injury or bulging of the brain, which is undesirable during the process. Then we do not select patients who are known to have difficult airways, because intraoperatively management of airway becomes cumbersome. People with obstructive sleep apnea and airway collapse, they are also not ideal candidates. And last but not the least, patients with severe deformity, rheumatoid arthritis, for whom lying in a particular position for a considerable duration of period becomes difficult. So these are not the patients who are good candidates for awake craniotomy. One of the most important factor for the success of awake craniotomy is that the patient should be highly motivated. And we on our part as anesthesiologists can increase that level of motivation by performing a first-hand counseling. We do a fair bit of awake craniotomies, close to around 20-25 per year. So we have a good deal of experience in awake craniotomies. And this thing which we have found, that if we spend some time, maybe 10-15 minutes building the rapport with the patient, it really helps in the long run, because it actually motivates the patients and it also clarifies many apprehensions which the patient have. There are certain points which we stress during those preoperative counseling sessions, that they will be offered the best possible margin of resection, thereby maintaining the motor powers. Patient satisfaction is usually higher in patients undergoing awake craniotomy. They have lower pain scores and lower PONV. This is one of those sessions where we treat the patients, we exercise the OT, familiarize them with the setting, and believe me, this thing has a best possible bearing in the outcome of the surgery, because at the end of the day, patients, when they actually walk in the OT during their procedure, they are much more calm, relaxed. They know what they are going to face, and the results are a much more comfortable, sedated patient.
बाकी मरीज हैं अभी जो चल रहे हैं जैसे ऑपरेशन चल रहा है एक का चल रहा है एक का भी स्टीमर है
Now, for awake craniotomy, what we do is we put in a scalp block. Initially, they used to use a ring block, but nowadays it has become much more specific. We target 6 or 7 nerves, namely the supraorbital, the supratrochlear, zygomaticotemporal, auriculotemporal, lesser occipital, and greater occipital nerve. They can be done using the landmark guided technique or with the use of ultrasound. They can be used, they can be administered using ultrasound too. We still stick to the old landmark guided. This is the supraorbital and the supratrochlear nerve block, which is done in unison. This is a zygomaticotemporal nerve. The landmark being just above the zygomaticotemporal arch. Right then, once the entire, I've just demonstrated these 2 nerves. Of course, as I told you, there are 4 more nerves to be blocked. Now, once that entire scalp has been blocked, the patient is then placed on the pin. And that the vitals remain pretty stable if the block is administered properly. See the vitals before the pin has been applied.
लोकल और दिया है क्या? लोकल लगा लो तुम। नहीं ओके चलो टाइट नीचे वाला टच टाइट।
Now, as you can see, even with such a noxious stimulus, the
navigation
vitals remain pretty stable. So this is a very good example of the adequacy of the block. That if your pin tightening is smooth, that means your surgery will go pretty smooth. There are certain pearls for a successful scalp block, which I'd like to share. First, sound anatomical knowledge for the conduct of nerve block. We still are dependent upon anatomical landmark-based methods, but then, of course, ultrasound can be used. Certain degree of sedation is necessary as performance of block is painful. It's a multiple point injection, so the patient has to endure around 10 to 12 different pricks. So some degree of sedation with dexmedetomidine, remifentanil, metazolam, whatever is in your armamentarium is necessary. And especially for the softer areas of the face, a 26 gauge needle is preferred, but scalp being pretty thick, you'll require a thicker needle, a 10 cc syringe needle or something, which is desirable. And another thing I'd like to add upon is that once the block has been placed, it's a good practice to wait for around 15 to 20 minutes for the block to actually take place, because any application, any other noxious stimulus before this period will invariably lead to pain. So it's a good practice to allow the block to set in before any manipulation is done. This is the usual setup of the patient for awake craniotomy with the surgeon on the head end and the anesthesiologist on the side. Now, different regimens are used depending upon the availability. So, dexmedetomidine is what we are using nowadays. Of course, prior to that, we were using propofol. With the advent of remifentanil, that can also be used. All have been used with variable degree of success. Ventilatory aspects have to be taken care of throughout the surgery. Oxygen supplementation with nasal high flow cannula or Hudson mask should be administered, or if need be, a LMA or a nasopharyngeal cannula can be used. Usual monitoring gadgets include monitors like ECG, NIBP, SpO2, temperature probe, urine output, invasive arterial line, VIS monitoring, capnography, and it's a safe practice to have a dedicated IV line for sedative drugs because it avoids inadvertent boluses. Intraoperatively, we should be aware of few events. First, pain and discomfort, especially dura, which is close to the middle meningeal artery, is sensitive to traction. So the surgeon should be advised to apply topical anesthesia as and when needed. Anxiety, the osteotome produces noise which might be distressing for the patient, so prior warning or deepening of sedation may be required. Intraoperative seizures are quite common occurrences, so you should be prepared as an anesthesiologist to advise cold saline irrigation or barbiturate administration in case it happens. And some degree of nausea, vomiting, especially when surgical manipulation of the temporal lobe or tonsillar region, meningeal vessels, they might cause nausea and vomiting in the postoperative period. So usual drugs like dexamethasone, ondansetron, etc. should be tried. I was going through the literature available and found certain novel uses or certain out-of-the-box uses of awake craniotomy in recent publications. First, in pregnant patients, of course, avoidance of general anesthesia is a priority. It has been used successfully for supratentorial tumor resection in pregnant patients. Then a very recent publication of 2025, awake craniotomy for a deaf patient. Then awake craniotomy in aged patients with severe hearing impairment using bone conduction voice amplifier. Then in patients with post-traumatic stress disorders, in super obese patients using HFNC. And this is one of the newer trials which has come up, which in fact is a meta-analysis describing the differences between awake craniotomy versus surgery under general anesthesia. However, they did not find any differences in the outcome. That's all from my end. This is just a video of the awake craniotomy procedure being performed in ROT. Monitoring for awake craniotomy. For awake craniotomy, we usually don't, because patients are already talking. They are dexamethasone is used. Dignocaine.
अंगुली हिलाओ, हाँ हिलाओ हिलाओ, पंजा हिलाओ, पूरा पंजा हिलाओ, हाँ हिलाओ, पैर उठाओ, देखें बस ठीक है, ओके।
Thank you.
Thank you, sir, for such a knowledgeable lecture. Now, I request Dr. Sohan Solanki to felicitate our chairperson and speaker of the session, Dr. Tanmay Tiwari.
डॉक्टर तन्मय तिवारी हाजिर हो। So this was the last session, and I request all the delegates who are online, we are switching off. The session is over. If you want to give any feedback, you can give online. The facilitation is going on for the faculty members, and thank you so much.
Dr. Ravi Prakash.